Good morning, everybody. On behalf of Sheikh Abood Medical City and Mayo Clinic and our organizing committee, I would like to welcome you all. Warm welcome to all the online delegates and on-site delegates. I would like to, I'm very glad to have in our midst some special guests, Dr. Al-Rumaiti from Radiology Society of Emirates, President, Dr. Holland, and other members of the Emirates MSK Radiology Club. Thank you all for attending and making this possible, this conference. I would like to invite Dr. Holland to make the opening remarks.
Thank you. Good morning and welcome to all of you online and in person. I'd like to welcome you to the first SSMC Musculoskeletal Radiology Case Conference. First, I'd like to thank some of the people who made this possible. Our organizing committee and scientific program committee made up of SSMC's own Dr. Rafa, Dr. Assad, and Dr. Vijay. Our distinguished international guest, Dr. Rami, Emirates MSK Radiology Club, Dr. Abdullah and Usama from Radiology Society of the Emirates, and our academic affairs team, Alam, Krista, and Mark, and of course, our director of the course, Dr. Vijay. So we have a full day of excellent talks for you. I'm sure they'll be very educational and generate some interesting conversations. Personally, I enjoy general radiology conferences, but find that these specialty conferences are where you can really appreciate the content and the collaboration with your colleagues that share the same passion for your specialty. And for that reason, I really like these specialty conferences that have a little bit more depth. And I think it'll be a great day for all of us. So again, welcome and enjoy the day.
Thank you, Dr. Holland, for the opening remarks. Now I would like to invite Dr. Al-Rumaiti to make his opening remarks and make a little introduction about the recently formed Emirates MSK Club. Thank you, Dr. Rumaiti.
Thank you very much, Dr. Vijay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It's really give me a great pleasure to welcome our distinguished guests and speakers and welcome you all to the first SSMC Radiology MSK Case Conference. And this is for us in the Radiology Society of the Emirates. It's very important day, and it's because it's marked also the official foundation of the UAE MSK Imaging Club under the umbrella of the society. We are very proud that this is actually the second club that's formed under the society. The first club was UAE Breast Imaging Club, which was formed last November. And since then, they were very active also. This is also give me an opportunity to ask our colleague if they are here. I hope that's not only MSK people attending. I saw so many on the virtual, and the number is very good. So we are looking forward to enhance the culture of subspecialty practice in UAE and this education. And we are encouraging our colleagues in neuroradiology, body imaging, chest and cardiac, pediatric, and all other subspecialty in medicine to approach us in the society informing this club, because we saw that this is really the way to go in improving and being more productive in the radiological community in UAE. As you are aware, there are so many challenges as forming this profession as a radiologist around the world, and UAE is no exception. We face a vast advance in technology, which is very good for us as a radiologist, but it's also form a challenge in that we have to keep up with this change and keep the profession within the field of the diagnostic imaging, because this technology also open a door that's be used by other that's not in the same specialty. We also have, I think, a responsibility towards our younger colleagues, because in my opinion, the practice of radiology in the next coming era or years will be different than the practice in our generation. And it is opportunity for us in forming this organization and event to prepare our younger colleague for this era. So I don't want to take a lot of your time, but the last two remark is to my younger colleagues, either who are present here or virtually. You are the future of this profession as a radiologist. So my advice that you need to be proactive, not protective. And you really show your colleagues in the clinical side the potential of the radiology, the radiologists that have in the impact on patient management. And you also be on the head of the technology and you own it. At the end, I would like really to thanks the organizer, the Radiology and Academic Affairs Department and SSMC and Mayo Clinic, and also my colleagues in the UAE Musculoskeletal Imaging Clubs, namely Dr. Vijay, Dr. Rashid Sharhan, Dr. Nadeem Pat, and Dr. Asad Shah, and all members of the club who I saw them that's working very hard and make this event to become and to be reality in very short time. So thank you very much all. And I hope that you will have a nice and fruitful day. Thank you very much.
Thank you, Dr. Methi, for the wonderful introduction and the message. I would like to invite I would like to start the first session. I would like to invite the chairs, Dr. Rumethi and Dr. Ravi, to come onto the dais and chair this session, which is shoulder and elbow, imaging of shoulder and elbow. I would like to invite Dr. Rami Mansoor, who is the international speaker, who is a very well-known MSK radiologist in this region. Is trained in, is my senior colleague from Sheffield training program. And following that, he trained in, he did his fellowship in Oxford. And now currently he's the lead MSK radiologist at Oxford. He's, he works very closely with the Royal College of Radiologists, and he's got several publications and book chapters. So without further ado, I would like to welcome Dr. Rami to start off the first session, which is shoulder imaging.
Thank you, Vijay. Thank you, Dr. Abdullah, for the nice introduction. And it will be my pleasure to start the day with the first meeting or first symposium of the MSK Emirati MSK Radiology Club. So the first presentation would be the MRI presentation, and during the next 20 minutes, I will focus on the glenohumeral instability. Of course, the shoulders, there's lots of pathology in the shoulders, and it's very difficult to cover everything. So we'll just focus on the instability and shoulder dislocation. And this will be the overview of the talk. We'll talk about the stability of the shoulder, normal anatomy of the glenoid, and the MRI features of the glenoid and the glenohumeral ligaments, and the pathology and some variants. And we'll conclude by a summary. So the glenohumeral joint is one of the joints that gives a great mobility. And because with our joint, we throw things, we try to catch things. That's why we need a wide range of mobility. And I think that the shoulder joint was one of the most mobile joints of in our body. And to achieve that, we need a small glenoid fossa and a large humeral head to do that. And of course, this is on the expense of the stability of the shoulder. That's why the shoulder joint is one of the most joints that can be dislocated. The stability is achieved by a passive structure, which mainly the ligaments, labrum, and the joint capsule. And the bony stability of the shoulder is very, very, what I'm trying to say that the bone stability is not as strong as compared to the other joint. So the bone stability does not really contribute much to the stability of the joint. We have also some active stabilizers of the joints, like the rotator cuff and the long head of biceps. And this is how we maintain the stability of the joint by adding this soft tissue structure around the glenoid, mainly the glenoid labrum, which, as you can see, it gives more depth and not just depth to the glenoid, it gives more surface area. So it achieves more depth and surface area to the glenoid and to give more stability. And I think this is this diagram shows that the soft tissue stability of the joint is achieved by several layers around the shoulder. We already mentioned the glenoid and also the joint capsule, and the last layer around the shoulder, which is the rotator cuff, gives all this stability. So different layer of structure that keep our joint stable. And you can see that the bony stability is very limited only to the superior part of the joint. So that's why more likely, if you're going to have, if someone gets a shoulder dislocation, it will be either anteriorly or not superiorly because of the bone stability. Then the important also structure that keep our shoulders stable is the glenohumeral ligaments, and they are not like true ligaments. They are not separate from the joint capsule. They are just basically represent some thickening of the joint capsule, and you can see most of them or all of them are concentrated or located anteriorly. And I think this is the best diagram to represent the glenohumeral ligament, because you can see they are like three different layers that protects the anterior capsule. Whenever we throw something or someone throw something, the humeral head tends to move anteriorly. That's why we need to protect the anterior capsule from anterior stability. That's why most of the soft tissue stability is focused or concentrated anteriorly. So the most important one of the glenohumeral ligaments is the inferior glenohumeral ligament. As you can see, it originates from the labrum anteriorly and goes to posteriorly. And by having this recess, so we can protect the humeral head, especially in abduction. And it's best seen in the coronal and sagittal plane. And when the sagittal plane, we can see that the glenohumeral ligament is seen there, and we can see there is a recess, joint recess there. The best way to scan or the MRI, to scan the shoulder is by doing MRI, and especially MRI arthrogram. And this is the way we can check for stability or instability. And the whole idea is we want to achieve joint distension, so we can separate the different structure, ligament and cartilaginous structure of the shoulder. The arthrogram can be done under ultrasound or fluoroscopy. In our institution, we prefer to do the arthrogram guided by ultrasound, because this gives you a way of scanning the shoulder and see the soft tissue, especially the rotator cuff, before the patient goes to the MRI scanner. So just, it gets you 2 in 1. So with one scan with our MRI, you can get ultrasound and also MRI. It really depends on your expertise and how you trained. You can do either anterior or posterior approach, but ideally, a musculoskeletal radiologist would be able to do both, and you can give the choice for the patient whether he or she wants to see the needle or don't want to see the needle, and accordingly you can go from the anterior aspect or the posterior aspect. If you do arthrogram and the patient can put his joint or shoulder joint in abduction, so this is also one of the preferred position. It's what we call it the ABR, abduction and external rotation. And in this way, you extend the anterior capsule of the shoulder joint, and you can see if there is any labral tear. And you can see in this patient is in an ABR position, and you can show there is a labral tear here. The problem with this position is, as I mentioned, it's painful, and not every single patient can do MRI arthrography in the ABR position. This is just one example how useful the ABR is, and I got it from the literature, and you can see this is a normal position, and you can see here there is a small tear. An inexperienced radiologist might miss it. But if you put the patient in the ABR position, you can see the tear very, very clearly. But you can argue we already see it there. So again, it really depends on your preference. And this is another example. I can see in the ABR position, and you can see the labral tear is clearly seen with the contrast going into the tear. So talking about instability, this is the types of instability that you can come across. The main cause of instability is trauma. So a patient can have acute dislocation, and this can lead to anterior dislocation. And it's mainly the traumatic or secondary trauma is unidirectional. So it's either anterior or posterior, but it's commonly anterior. The other type of glenohumeral instability is because of overuse, and this is mainly for in sports. Patients who play crickets, like to play crickets or javelin or the American baseball, they can suffer from this kind of called micro instability because of repetitive micro trauma. And this can be multi-directional. So those patients who have atraumatic instability, their humeral head can go anterior posteriorly, and it's micro instability. And there is the congenital one because of congenital dysplasia. So this is what we expect to see in MRI, the different appearance of the labral tear. It could be anteriorly. This is the normal labrum here. And if there is a labral tear, you can see the labral is avulsed from its bony attachment, and also there is tear of the anterior capsule. Sometimes the tear can happen and with avulsion fracture of the periosteum. And this is type of tear, we call it the elapsa tear. And the other tear is you can have a tear of the labrum and also a piece of the underlying cartilage, which we call the glad tear. You don't have to remember all this elapsa glad. All you need to do is just describe what you see, but this is how they describe all this kind of tears in the literature, which sometimes I think it is, doesn't really make any sense. It's just describe what you see, describe the injury. And when the anterior dislocation happen, they can have an impaction fracture of the posterior aspect of humeral head, what we call Hill-Sachs lesion. Again, another thing that we don't necessarily have to remember the name of it. So I'll just show you some examples of different labral tear. You can see here, this is the classical one. The patient had done an arthrogram, and you can see that the contrast is going under the labrum, and this is just what we call classic labral tear, or sometimes they call it Bankart lesion. And this is an example of a bigger tear where the tear went through the underlying articular cartilage. So this is an example of the GLAD tear. Sometimes the impaction fraction can happen, and rather than the labrum is torn, it's also the underlying bone can be fractured. And you can see here, this is in the sagittal view, that a piece of the inferior labrum is missing. Okay, instead of having this kind of pointy triangular appearance, it's just blunted. And you can see that the bone and the labrum has been displaced superiorly, and this is what we call the bony Bankart lesion. This is a patient with a big Hill-Sachs lesion, which basically is just an impaction fracture of the posterior aspect of the humeral head. And you can see there is an association labral tear, and the labrum is being displaced. And if you look in the anterior cortex, it's been also involved. So this is a kind of possible alapsa type of lesion, or periosteal sleeve avulsion. This patient is an interesting case, and you can see that this is an Aber position, and in the Aber position showed that it is a labral tear. But also, if you look carefully adjacent to the anterior labrum, you can see that the piece of cartilage has been damaged. And it's very characteristic when you have this kind of acute chondral lesion, whether in the shoulder or in any joint like the knee, you can see that the edges is perpendicular. So this is represent that this probably that this is a chondral, a traumatic chondral lesion. And when you see that something's missing, you have to look where this piece of cartilage went. And most of the time, they go to the joint recess, the bigger recess, either inferiorly or like in this patient, went in the subcoracoid recess. And you can see this patient had this loose chondral lesion in the subcoracoid recess. So whenever you see this cartilage defect, you need to know where the cartilage chondral lesion went, and you have to look for it. It's very important. It really depends and sometimes alter the decision of the orthopedic surgeon, what they can do for this patient, and also the outcome of any surgery, because damage has already happened to the articular cartilage. The inferior glenohumeral ligament is very important to, whenever you report an MRI, to comment on it, to see whether it's torn or not. And by definition, because the inferior glenohumeral ligament is attached to the inferior labrum, so whenever you have inferior labral tear, that means that the glenoid attachment of the glenohumeral ligament of the glenoid attachment of the inferior glenohumeral is involved. So that's why it's very important to look at the other side, which is the humeral attachment. And whenever there is a tear in the humeral attachment, they call it the humeral avulsion glenohumeral ligament with a Hagel lesion. You don't have to call it that, but just all you need to do is to look for it. It's common in the first dislocation, and it's also in people who are elderly or older than 35 years of age. And one of the characteristic appearance is this extravasation of the contrast. A normal inferior recess will look rounded, and you can see there is no extravasation, no leak of the contrast into the axillary pouch. The contrast is contained in the recess. But whenever there is an inferior glenohumeral ligament tear, you can see the contrast leaking along the medial side of the proximal humerus. This is very strong sign to indicate that the inferior glenohumeral ligament is torn. Sometimes it's a stone with a piece of bone, so it can avulse. And this is seen in a younger patient, again, in teenagers especially. And you can see in this patient that the inferior glenohumeral ligament is torn from both sides. And if you look carefully, there is a small, tiny bone here that is avulsed from the humeral head. And this is happening in 20% of the anterior shoulder dislocation. This is another example of avulsion fracture that can happen in both sides. We call it, we call it a floating glenohumeral ligament. And you can see that there is avulsion fracture in the glenoid and the humeral head, and CT show the same appearance. Posterior instability is less common than the anterior, and it happens due to trauma and also due to seizures and electric shocks. Sometimes it happens because of glenoid dysplasia. And with the posterior dislocated instability, everything is reversed. So the Hill-Sachs happen in the anterior aspect rather than the posterior aspect, and the labrum is the posterior labrum rather than anterior labrum. So it is the same thing, but it's mirrored posteriorly. And this is one of the examples that the patient have an impaction fracture of the humeral head with large reverse Hill-Sachs, and you can see that the posterior labrum is torn. Unlike the anterior dislocation or the anterior labrum, the posterior labrum can happen secondary to micro-repetitive trauma. So this is where a chronic instability or micro-stability is common. And this is something that you really not look at it. So most of those patients would present with apprehension and feeling of unstable shoulder, and not necessarily they will report that their shoulder has been dislocated previously. And this is an example of that, one of those patients, and you can see there is a tear here in the posterior labrum, which is happened. And you can see there is like a reverse Hill-Sachs there. Another example of patient who's not representing with the previous posterior dislocation, and you can see in the posterior labrum is torn. One of the things that you need to be careful about it, and those patients sometimes can come without any history, again, with dislocation, they are presenting with pain. And that's why in this patient, for example, we didn't do an arthrogram. And you can see that the posterior labrum and glenoid here is very blunted. And you can see that the posterior glenoid is hypertrophied and there is a tear. This is because of a congenital glenoid dysplasia. And sometimes this can be presented late. Again, this is not an arthrogram. This patient with the joint effusion, and you can have this plastic glenoid and a large hypertrophied posterior labrum. One of the things that you need to look for it is in the X-ray. I think most of this patient can be picked up on the X-ray, and you can see this patient have what we a typical appearance where you lose the neck of the glenoid, and you can see you can have this blunted glenoid, and this is a sign of glenoid dysplasia. It's not something well known, and I can see that this kind of appearance is missed always with some of the general radiologists. So the things, we move on now to the normal variant of the shoulder and shoulder labrum. And there are main three, the sublabral foramen, the sublabral recess, and the buffer complex. And I'll just show you an example because this can be overcalled as a tear. This is a small sublabral recess. You can see that. And as you can see that all variants can happen only from 11, if you look at this as a clock appearance, it happened from the 11 till 3 o'clock only. So anything in the superior or anterosuperior labrum is more likely to be a normal variant and not a traumatic tear. I can see here there is a small labral recess. The buffer complex is congenital absence of the anterosuperior labrum and with missing with cord-like middle glenohumeral ligament, and normally you don't see the anterosuperior labrum. And this is just an example. And just always be careful because this happened in the anterosuperior. So when you're looking at it at the axial, you always make sure that you are in the superior part of the labrum, because this is where you're going to miss the labrum. And you can see here in this patient, there is no anterior labrum. You can see the posterior labrum, but you cannot see the anterior labrum. So always make sure that you are high up in the joint. The other normal variant is what we call the sublabral recess, and is always seen in the superior labrum again. And you can see when you inject contrast, you can see the contrast is flowing towards the glenoid. So whenever you see the contrast is flowing towards the glenoid, that means it's a recess. But when you see the contrast flowing into the labrum, that means this is a tear. So this is how we can differentiate between the labral recess and labral tear. So in conclusion, MRI arthrography is the main scanning modality for shoulder dislocation. Shoulder dislocation is mainly anteriorly, and it's always combined with labral tear and ligamentous tear, and knowledge of the anatomy and normal variant is essential. Thank you very much.
Thank you, Dr. Rami. That was very enlightening. I'm Dr. Asad, one of the other team members here. So before I call the next speaker, I would like to inform you there is a quiz as well. So for attendees here, there are 3 laptops outside. You can whiz through the cases, and we'll discuss them towards the end of today. Yeah, and for online attendees, there's a link that must be shared with you, so you guys can go through the cases as well. So the next speaker, supposed to be Dr. Nadeem Bhatt, but he is on call. He couldn't find a stop, so he sends his apologies. But we've got, instead of him, Dr. Mohammed Zawi. He is a 4th-year resident in SKMC. So I will invite him to come and give his talk about shoulder cases. Dr. Mohammed Al-Zawi.
Hello. Thank you, Dr. Asad, for the nice introduction. My name is Mohammed Al-Zahabi. I'm a final year radiology resident in Sheikh Khalifa Medical City, and I have the honor of presenting these cases at the first MSK conference held here in SSMC and by the MSK Club of Emirates Society of Radiology. I'll be presenting 4 cases, shoulder cases. Some of them are simple, and hopefully some of them will initiate some discussion. So we'll begin with the first case. So the first case is of a 59-year-old golfer with clinical signs of impingement. But before we begin the case, we should look at a bit of anatomy. I know most of anatomy has been covered, so I'll just go over, but we should just focus on the layers of the tendon. So in case some aren't aware, the tendon has 5 layers. Has the first layer is most superficial, 1 millimeter thick, and contains fibers from the craccohumeral ligament, which extend posteriorly obliquely. The second layer, it has densely packed fibers. They run parallel to the long axis of the tendon. Third layer, smaller, loosely organized bundles of collagen, 3 millimeters thick. Fourth layers has loose connective tissue with bands, collagen bands that merge with the fibers of the craccohumeral ligament, and the shoulder capsule is just 2 millimeters thick. But moving on back to our case. So hold on a second. It's supposed to be a video. Oh. Okay, so there is a partial thickness tear of the articular surface of the supraspinatus. We can see an effusion in the subacromial bursa as well. There is central supraspinatus tendinopathy with marked AC joint osteoarthritis. And if we compare that with our illustration on the left, we can see the lower layers of the articular surface are torn. Now, partial thickness tears, as some of you are aware, are usually classified as either bursal-sided, articular-sided, or could be intratendinous. As we described previously, bursal-sided tendons are mostly composed of tendon bundles, whereas the articular side is a complex of tendon, ligament, and capsule. So the bursal side has greater tensile strength when compared to its counterpart, which is about 50% as strong. Now, the etiology of these tears can vary. It can either be differentiated into intrinsic, extrinsic, or traumatic causes. Articular tears are more common because, as we described, they are a weaker side, and they tend to develop from intrinsic causes leading to degenerative weakening of the tendon, whereas bursal side are mostly due to extrinsic causes. Now, if we look at the T1 image here, we can see that there's a large acromial spur with impingement. Now, an acromial spur has many morphologies, can be heel and keel, but one of the largest configurations is described as an elephant's foot, as we see here in this image. And for those of you who aren't unsure what an elephant's foot looks like, I have this image, side-by-side comparison. And this is just a line to help visualize it better. Now, in regards to clinical aspect, what we convey to the surgeon will determine the operative approach and extent. So it's important to note the extent of the tendon involved, which tendon is involved, and the quality of the muscles itself. So this patient was operated on and had the acromioplasty for the large acromial spur. Now, in terms of whether this is the best management, that's a matter for discussion. This case was selected based on its prevalence in society. It's a pretty simple case, but a case of partial thickness tear can be diagnosed on imaging early on and then be treated appropriately. But some practices would go for surgical management rather than conservative initially, but that's another matter of a discussion. But there are studies which show that as you're all aware, some studies show that conservative management is superior to surgical management in some cases. I'll just breeze through these. We can discuss them later. And there's also some conflict in regards to whether acromioplasty is also effective in cases such as these. But I'll move on to the second case real quick. It's of a 75-year-old man with history of fall, severe shoulder pain with inability to sleep. Now, if we see here, this is a coronal MR stir image depicting a full thickness tear with complete retraction of the supraspinatus tendon. And on the next slide, we have a sagittal slice. And we can see the anteroposterior extent of the tear of the supraspinatus with fatty atrophy of the muscle belly as well. Now, full thickness tears are generally described as either being incomplete, complete with traction, or complete with traction and atrophy. It's important to note the size of the tear, presence of muscle atrophy, the shape of the tear, and muscle retraction stage, whether it's close to insertion or at the level of the humeral head. So in this case, surgeons opted for operative management. However, in the presence of fatty atrophy, surgical outcome is considered poor. So post-op shoulder MRI follow-up will focus mainly on repair integrity and change in degree of fatty muscle atrophy. Now, in regards to how we assess for muscle atrophy, we use the tangent sign. We draw a line from the top of the scapular spine to the top of the coracoid process, and if the muscle belly lies beneath that, it's considered positive. Now, in regards to how we classify it, we have here the Gotalier classification of rotator cuff atrophy. There are 4 grades, and increasing stage would indicate a more severe degree of degeneration with poor surgical outcome. And some state that the last 2 are contraindication for surgical repair. This is just in the context of rotator cuff tendon tear. And here is a visual representation of the study of the classification system we've seen before. It's important to note that the classification is based on the fat within the muscle substance itself and not in the space in which it occupies. And studies have have also supported this relationship, demonstrating increased retear rates in patients with increasing staging on the classification preoperatively. Now, we'll quickly move on to our 3rd case, which is of a 63-year-old male, history of fall, presenting with acute shoulder pain and restricted movement. We can see, in addition to an acromial spur, rotator cuff tear, and there's also marked osteoarthritis and a posterior labral tear. And with that, there is a large paralabral cyst extending medially into the spinal glenoid notch, with moderate atrophy and increased muscle bright signal. No abnormality seen in the supraspinatus muscle. Supraspinatus and infraspinatus muscles are supplied by the suprascapular nerve. The branch of the supraspinatus nerve takes off at the level of the suprascapular notch. And in addition, in this case, isolated denervation changes in the supraspinatus suggests that the nerve compression is distal to the nerve supply to the supraspinatus muscle, probably at the level of the spinal glenoid notch. Although the cyst extends to the notch, no evidence of neural impingement is seen there. Now, compression of the nerve at the spinal glenoid notch by a paralabral cyst is a rare but recognized entity. Other nerves that can be involved are the long thoracic nerve, axillary nerve, and musculocutaneous nerve. According to literature, paraganglioma cysts are rare and often underestimated, and they are often seen at a later stage and may have functional consequences by irreversible muscle atrophy. In regards to differentials, it's important to keep in mind other causes of muscular atrophy, as we have seen in this case. Parsonage-Turner syndrome or brachial neuritis is thought to be immune-mediated, with the only finding being muscle atrophy. We would need a combination of clinical history, imaging, and EMG to make the diagnosis. Other causes of compression, such as ganglion cyst, can be considered, as well as traumatic strain. But we'll move on to our 4th case of a 4-year-old male, history of road traffic accident. He was the passenger in the car, pain, tenderness, and restriction of movement on the right shoulder, and previous X-ray shows right shoulder dislocation. It was reduced, however, CT shows residual subluxation. And if we move on to the images, we see here that there's extensive soft tissue edema around the shoulder, marked injury to the joint capsule. There is residual subluxation and rupture of all the rotator cuff tendons, with the ends located in unusual positions. So the supraspinatus tendon passes infraposteriorly to lie at the posterior aspect of the surgical neck of the humerus, with the torn infraspinatus tendon. And the torn subscapularis tendon passes over the anterior aspect of the lower glenoid of the surgical and passes posterior to the surgical neck of the humerus. The long head of biceps passes inferiorly into the joint space. The distal portion cannot be seen, but it's likely torn as well. And we can also see, obviously, there's moderate amount of fluid in subdeltoid subacromial bursa, posteriorly Hill-Sachs lesion with a possible soft tissue Bankart. This patient was operated on, and during in the post-op notes, it was mentioned that the biceps tendon and parts of the supraspinatus was wedged within the glenohumeral space. And after extraction and repair, the head went back into the glenoid. Now, in terms of conclusion, as we mentioned before, MRI plays an important role in imaging of rotator cuff abnormalities. Some studies have shown that ultrasound is comparable to MRI However, some places ultrasound is deficient because it's still operator dependent, and studies have shown that the larger the tear, the less reliable ultrasound is. And there's also issues in regards to visualizing some structures in the subacromial space on ultrasound. Also, many surgeons depend on imaging to assist in decision-making pre-surgical planning. What we convey to the surgeon can affect the operative approach, as well as possible surgical outcomes, as we mentioned before, with, like, for example, the fatty atrophy of the muscle. And of course, it goes to say that proper intervention based on our imaging findings leads to improved outcome. These are references, and thank you for your time. Sorry. So question time will be after.
Thank you, Dr. Alzabi. That was a nice set of cases. The next speaker is Dr. Asad Shah. He is my esteemed colleague, and he's going to talk about elbow MRIs followed by case discussions of the elbow.
Thank you, Vijay. So can we have the first slide, please? Right. So for the next 40 minutes or so, I'm going to take you along with take you along the journey about MRI elbow. I've been giving these talks for the last 5 years, and somehow elbow falls onto my plate. The reason, I mean, the thing is, it's important to kind of to learn about the elbow is because we don't do that much MRI of the elbow. I mean, I was looking at our own data set here in the last 1 year, like 2020. We did 120 CT elbows, but only 20 elbow MRIs. So that just tells you I think it's a selective use of the MR for elbow pathologies, or it could be that most of the time it's traumatic injury. So we do our surgeons or our clinicians, they want CT. And if it's rheumatological problems, ultrasound kind of fills in the space nicely because there are so many common pathologies that you can diagnose with ultrasound. But nevertheless, we're going to talk mostly about MR imaging of the elbow today, pearls and pitfalls. So I'm going to talk, delve for the first few minutes about the anatomy, introduce you to the normal variants because it's important to know the normal variants because these are the pitfalls. If you don't know them, you can overcall things, okay? And then I'm going to take you through the pathologies, and towards the latter half, we're going to go through a few cases, okay? So this is a nice kind of schema, which was published, I think about like, as you can see, 2016, but it just tells you the same thing that if it's trauma, I mean, or for elbow pain, the first line imaging is a radiograph. There is no substitute for that because it gives you an overview of the bony architecture, joint spaces, and calcification, things like that. And sometimes it happened that I'm reporting an MR and I go back to the X-ray, and X-ray, like Dr. Rami was saying, that sometimes the X-ray just kind of clinches the diagnosis. If there's a high clinical suspicion for a tendon problem, then ultrasound, again, for triceps, biceps, brachialis, for common flexor, common extensor tendon, ultrasound kind of is very handy. And obviously, you can use it for image-guided injection. High resolution CT can depict the fractures, for fracture, whether the preoperative planning or to assess for non-union complications like that. The R is the gold standard for evaluation of comprehensive evaluation of the elbow pathology. So if there is somebody who's got, let's say, lateral epicondylitis, but it's not settling, so you need to look inside the joint, then probably MRI is going to be your gold standard. Arthrography, unlike the shoulder, is not done as commonly, even for instability. You tend to just do a plain MRI. And obviously, if there's contraindication, then you can go for CT arthrography. This is the normal kind of position, like a Superman position with a dedicated elbow coil or a knee coil you can use. Okay, this is the position if you're going to go for an arthrogram, you can go from the lateral approach, which is the safest one. Okay, And sometimes, I mean, if you want to assess for the distal biceps tendon, there is this sequence, which is called a FAB sequence, which gives you the full length of the distal biceps tendon to evaluate. Okay. So, I mean, I think most of you guys are aware of these protocols by the ESSR. I think they are very handy, and I think we all should comply with that just to standardize our practice. But the key thing I'm going to say is that you have to kind of liaise with your MR techs to look at the field of view, because most of the time the field of view is large, like 16, 20, something like that. And the larger the field of view, the poorer resolution for the structure that you want to look at. So the recommendation by the ESSR, and this is from seminars on musculoskeletal radiology, the field of view should be 12. For shoulder, similarly, I asked them to do from 12 to 14. There's no need to go for anything more. Okay, slide thickness again 3 millimeters is sufficient. And obviously the other thing is you have to have non-fat suppressed sequences like a coronal T1 and an axial PD, because sometimes the edema and the pathologies are so kind of, they overwhelm the image. There's so much edema there, but when you compare it with the non-fat suppressed, then you can delineate which structure is gone. So always combine your fat suppressed sequences with non-fat suppressed, at least 2 planes. And obviously T1, there's no MSK-MR. MSK-MR can't be complete without a single or more plain T1 weighted images. Right, briefly about the anatomy. I mean, obviously it's the AP radiograph of the elbow, but we should know that there are so many soft tissue structures. And for us, MSK radiology is the anatomy with pathology. And for us, I mean, we tend to see things on X-ray that we can see on MR. So with experience, you build up that kind of understanding that there are these structures there, and then you can localize it. So try to read more into the X-ray, and that will happen if you are good at if your anatomy is up to mark. Okay. Common flexor tendon origin. I mean, that's on the medial side. You've got a flexor mass there, common tendon. And the other thing is, I mean, the other thing I would like to point out is you've got a large it's not working, but you've got a large kind of footprint there. That's the common flexor tendon origin. And deep to that, you've got the capsular thickening, which are called the ligaments. So they are intricate, they are kind of intimately related. Okay? So that's an important concept which we're going to come back to later on. Similarly, common extensor tendon origin, you've got the ECRL, which is the main tendon there. Then you've got ECRB, and then the commonus. And again, similarly, you've got the radial collateral ligament complex deep to that. Okay. And on ultrasound, you can easily see the common extensor and common flexor tendons. You can see the collateral ligaments as well, but I think that needs more practice. Coming to the medial ligaments, like the medial collateral ligament in the knee, I mean, the ulnar collateral ligament is a bit different, but somewhat similar, I would say. If you see, these are 2 images. One is anterior, which the black arrow, the 2 black arrows are pointing towards the anterior band of the ulnar collateral ligament. If you go back, the black arrow is pointing towards the posterior band. And you know that this is the back because the white arrows are pointing towards the lateral ulnar collateral ligament. So you're at the back of the radius. So there's anterior band of the ulnar collateral ligament and the posterior band. And this will only, you'll able to see these if your slice thickness is less and you have done PD and PD fat suppressed images. There's a transverse band as well, which kind of forms the floor for the cubital tunnel, but that's probably not kind of related to the stability. When it comes to the lateral ligament, it's a bit more complex structure. You've got a common origin from the humerus, okay, but then it divides into kind of two bands. One is the radial collateral ligament proper, which is pointing out by this white arrow. This is your radial collateral ligament, and it merges with the annular ligament. Annular ligament is this thin kind of structure that circles like around the radial head. Okay, so the radial collateral ligament attaches at the lateral epicondyle, but then it comes down and merges with the annular ligament. The important ligament that we all have to kind of try to assess on an MR, particularly in the context of trauma or instability, is your lateral ulnar collateral ligament, which kind of forms the posterolateral corner of the elbow. And the image that I always try to find is this one, that you see a structure there, and there's a bit of a sharp angulation, like a flattened band that attaches to the back of the ulna. This is the one which holds the radius from going back. Okay, so this is the lateral ulnar collateral ligament, which is important structure for the posterolateral stability of the elbow. Okay, that about the ligaments. Obviously nerves, I mean, ulnar nerve lives behind the medial epicondyle, and then it passes through the FCU. Ultrasound is very handy. You can compare both sides to see if there's any caliber change, any subluxation, things like that. Okay. Median nerve lives kind of just medial to the brachial artery. Then you can see it's dipping into the pronator teres. Okay. Radial nerve is, again, you start from the radial aspect of the distal arm, and then you can track it down, where it kind of delves deep into the supinator, which sometimes you can find. I think it needs a bit of practice, but next time you look at an axial MR of the elbow, just try to see that fat plane between the two heads of supinator, and you can see that's your posterior introitious nerve, which is the muscular branch of the radial nerve. Tendons, I mean, the three tendons that are important around the elbow, one is the biceps tendon, which is, again, you've got a short head and a long head. And usually they join, but sometimes they can be a bit split. And if you see that schematic diagram, they twist. So the short head is a bit distal and long head is proximal. And sometimes they can remain separate. There is like a fat plane in between, which basically we call it like a bifid tendon. And it can, for an unwary, you can say it could be a split tear, but there is fat usually in between. Okay. And again, ultrasound, you can look at that. Coming to the normal variants, I know this is a busy slide, but I just want you to look at the first row there. This is from literature. The important thing is there's something called a pseudo defect at the posterior aspect of the capitellum. So if you extend your elbow, you can't hyperextend it. So the circumference of the capitellum, the anterior, is like a semicircle. You don't need articular cartilage at the back. Okay, so there is a defect there, which is pointed out by the white arrow there. So this is a pseudo defect. Sometimes you can see some edema there. Sometimes you can see some cystic change there. This is not osteochondral defect. For osteochondral defect or osteochondritis dissecans, you have to assess the cartilage at the anterior aspect. This is the capitellar articular surface. This is not. Similarly, you have got a ridge there, which is devoid of cartilage. This is the trochlear ridge. Again, this is not a defect. Sometimes you can see a bit of T1 hypointensity, some people call it. You can miscall it a fracture. It's a pitfall, so don't go there. This is normal. This is normal cystic change in the pseudo defect. You can have a bit of hyperintensity at the ulnar collateral ligament, origin from the humerus. There is enconius epitrochlearis, which is an accessory muscle. It can stuff the ulnar nerve in the cubital tunnel behind the medial epicondyle. Slight hyperintensity of ulnar nerve is okay, but if it approaches kind of fluid density or there is some perineural kind of edema or any caliber change, then you have to say this is ulnar neuritis. This is the bifid biceps tendon that I was talking about. So from this, I would like for you to just take, the important thing is remember the pseudo defects. We're going to come back to that. Okay. Again, the other thing is plicas. I mean, plicas are common in the knee. Similarly, they are common. They have been well described in the elbow as well. And usually they say 3 millimeter. If anything is more than 3 millimeter, that's kind of significant because that can cause some impingement, particularly in the posterolateral aspect. And they say there's like a pronation flexion kind of test. If that kind of causes pain in the posterolateral aspect of the elbow, you have to think about whether there is a posterolateral synovial plica. Right. Why I'm showing you this. I mean, this is an adult MRI elbow talk probably, but it's important to have this. This is basic kind of medical school knowledge, but it's the basic principles that if we don't kind of remember them, that's a pitfall. So remember that the ossification nuclei in the pediatric elbow, they appear at a predictable sequence, right? So if you see something before something, then it means it is displaced. So that's the moral of it. Okay. And so always count the elbow ossification centers. If in doubt, compare with the contralateral elbow. That's the pearl. That's the kind of, this is a basic thing. We're going to come back to that. Right. So that's about the anatomy and some basic principles. I'm going to take you along the common elbow pathologies. Obviously, we do x-rays for fractures. I mean, radial head fractures are common in adults, supracondylar fractures in kids, but you can also have the epicondylar fractures as well, like a split, or you can have a bit of traction epiphysitis, like a Leaguer's elbow. Radial head can kind of displaced. Okay. And obviously, I mean, the radial head, again, radial head fractures are common, and sometimes you don't see them. You just see elevated fat pad, but then two weeks later, follow-up X-ray, you might see a fracture line. Okay. And I mean, this is a different kind of fracture. So always, if you look for one fracture, always look for the other one. I mean, this lady was on bisphosphonate, and you can see there is a bit of there's a band-like fracture. It's like a non-united fracture. There's a stress kind of fracture in the ulna as well. But why I'm showing you this is a lateral X-ray without any elevated fat pad. But you can see there's a subtle kind of step at the radial head and neck junction. Okay. And then I'm showing you these series of radiographs over about 3 weeks, starting from left to right. And you can see there is some lucency that's appearing at the fracture site. Okay. And it was last month I had it. And then I was a bit worried why there's lucency there. And then if you go back to the first lateral X-ray there's a bit of a lucency there as well. So could it be a pathological fracture? So we did an MR. And MR just shows you these are T1 weighted images, sagittal and coronal. There is fatty marrow in the radial head, just edema, no endosteal scalloping. There's no periostitis or any kind of extraosseous. So this is just a normal physiological response. This is fracture resorption. So it's like a pitfall. This is something which I fell into. I said, there's something there. So like with scaphoid, you do it at 2 weeks to see there's fracture resorption and the fracture becomes evident. This is just a series of radiographs just showing you there's progressive lucency. This is normal physiology, normal osteoclastic activity at work. This is not a lesion. Okay, so that's just a pitfall. So always compare the previous X-rays. And obviously our orthopedic guys, they like to do CTs for acute trauma, or if there is a fracture non-union, you can do CT. Even the reason I put this on, because this is a complicated case with metalwork problems, and this is a volume rendered 3D. And nowadays, with the good kind of CT scanners, we can reduce metal reduction and all that. So CT is very useful in assessing the fracture follow-up or even the pre-op planning. Okay. I know it's a busy slide, but I want to get this point across. There are two pathologies in pediatric elbow which we tend to come across, but there are subtle differences in between. This is Panner's disease, and like Critol, you've got this like the appearance of ossification nuclei. There is a sequence to that, but before the ossification nuclei appear and then they fuse. So before they fuse, usually it's the capitellum, it's osteochondrosis of the capitellar ossification nucleus. That's called Panner's disease. So in this case, what will happen is, if you look at the images there, the ossification nucleus is a bit sclerotic. Sometimes you can see a vacuum phenomena there, some air in it. This is this is kind of affecting the ossification nucleus. But the key point is, the pearl is that the articular cartilage will be intact. So you see these MR images there. There is signal abnormality of the ossification nucleus itself, but articular cartilage is nice and smooth. So this is Panner's disease, under age of 11, I mean, associated with sports and all that, but this is something you'll see in younger population, okay? In contrast, if you go to this etiology, OCD, osteochondritis dissecans, it happens in the second decade of life when the capitellum has ossified. Now it's going to affect the cartilage as well as the bone. So this will have, you see there's lucency there in the capitellum, there's fragmentation. And again, if you see here on this sagittal, we are not talking about the posterior aspect, talking about the anterior aspect. There is irregularity, there is chondral thinning, there is some kind of irregularity there. And then this can lead to fragmentation. This will lead to intra-articular bodies. So wherever you see intra-articular bodies in a young patient, particularly in the kind of late adolescence, this is osteochondritis dissecans. This is not Panner's disease. Panner's disease happens in the younger population and doesn't lead to intra-articular loose bodies. Okay, I mean, that's you can see another example from literature, the lucency there. This is like cystic changes there. In adults, you can have osteoarthritis. I mean, this is osteoarthritis. You can have post-traumatic. I mean, we see it intra-articular fractures. They lead to early osteoarthrosis or primary osteoarthritis of the elbow. And that can also lead to loose bodies, secondary kind of synovial osteochondromatosis, you can say. But that can be seen even on ultrasound. So, or even osteochondritis dissecans, if it's not picked up in the adolescent, it can lead to osteoarthritis and mechanical problems in early adulthood. Okay. 70% of patients that come to our clinic, I would say, with kind of elbow pain. They have got either medial epicondylitis or lateral epicondylitis. This is the commonest kind of problem that we see. And I'm showing you these different kind of images there. And ultrasound is good because that you can compare it to the other side. You lose the normal echo texture. You can see some calcification like here on the X-ray and vascularity. But on MR, obviously, I mean, it's a tendon. So tendons and ligaments, we all know they're tightly packed collagen, hypointense, on dark on all sequences. If there's any kind of hyperintensity, whether it's fluid or less than fluid, then you can say this is, or even thickening in chronic cases, this is epicondylitis. But there's a wide differential for these. Occult fracture, I mean, obviously somebody, you can have, in kids especially, you can have epiphysitis, you can have occult fractures of the coronoid process, things like that. You can have ligamentous injury. Okay. Or sometimes, I mean, the other thing is when somebody comes to me with medial-sided elbow pain, two things I always think. One is medial epicondylitis, the other is ulnar nerve. That's the basic thing. When I'm doing ultrasound, when I'm looking at MR, these are the two things, because they're going to present mostly with medial-sided elbow pain. Similarly, okay, well, I'm showing you this just a mimic, just to add a bit of spice to that. This is a patient who has got elbow pain, but if you see the medial epicondyle, there is a bit of fraying to it. Okay. And then there's the hand X-ray. This patient is on dialysis, and this is secondary hyperparathyroidism. So you can have that subperiosteal resorption that you see normally in the hands. You can see it in the medial epicondyle as well. So just think outside the box sometime as well. Okay. Lateral epicondylitis, similar kind of thing. You can see some calcification ultrasound. You can see some edema, some intrasubstance high signal there. You can have a partial tear sometimes. And there is, again, osteochondritis dissecans is of the capitellum. Capitellum is on the lateral side. So lateral elbow pain, you have to think about these things. And the other thing is, lateral synovial plica. That, again, can mimic lateral epicondylitis. Okay. Taking you quickly through these, because we're going to go through the cases later on. I know I'm kind of halfway through now. So the ligaments, I mean, like the medial collateral ligament in the knee, I mean, you can have ulcer from the humeral side, or you can have ulcer from the ulnar side. Okay, you can have a partial thickness tear, you can have a complete thickness tear. And sometimes you see this in chronic kind of cases. You see if there is a fluid, or do arthrogram, then you can see this kind of a T sign. It peels off. So this is again saying that there had been a tear before. Radial collateral ligament, commonly it goes from the common origin from the humerus. Like here, this is a full thickness tear from the humeral attachment. Okay. And sometimes it can kind of insinuate in the joint as well. Okay, this is again other kind of imaging there. You got edema there. You can't see the ligaments. This is the lateral and collateral ligament. So again, different kind of different examples there from literature. The other thing is annular ligament. I mean, we know the nursemaid elbow, usually we don't do any kind of imaging for that, but sometimes you do encounter it in adults as well. And the key thing is to look for that thin line that runs around the radial head. And if there's a defect there, that tells you there is an annular ligament tear. But one image I want you to take home is this image. This is from literature. Whenever you see synovial plica going into the anterior aspect of the radiocapitellar joint, always go back to your axial. And if you see something like a thick cord-like structure, this could be an annular ligament that has the anterior part of it that is flipped into the joint. This can mimic, and this will present as lateral elbow pain. It's rare, but it's a pitfall. So always don't kind of discount this is synovial plica. No, go back to the axial and look for the annular ligament. Okay. Again, this is the other thing is you've got radial head fracture. You can have some edema in the intraosseous membrane. Somebody got a distal radius. Somebody got a radial head fracture quite smashed, and they've got a bit of pain at the wrist. Always think about Essex Lopresti lesion along the intraosseous membrane. So that's something we don't tend to look at. So always look at the intraosseous membrane. Okay, dislocation, common posterolateral, capsular injury, but you can have associated fractures and ligamentous injury, making it complex. Okay. Again, the other sign on X-ray is called a drop sign. So if somebody, if you see a post-reduction X-ray and there's a bit of incongruency, and this is kind of widening of that, you know this patient has got significant ligamentous injury. So that's why with the weight of the arm, the forearm, it's just sagging down. So that's an important sign to look for. And obviously, we don't do MR. Thankfully, we don't do MR for this because that would be a mess, basically. But you see a lot of edema. You see the complex kind of full thickness tear of the radial collateral ligament. Okay. This is again dislocation. You can see there is edema at the radial collateral ligament injury, and there is a partial thickness tear of the ulnar collateral ligament as well. And then obviously there is bone bruising. Yeah, this is similar kind of thing. You can, but in this case, you've got the annular ligament. There is no annular ligament behind it, so it's a multi-ligamentous injury along with anterior probably brachialis muscle strain. Terrible triad, there are all these triads described. Terrible triad in the elbow is fracture dislocation of the elbow with radial head dislocation, with radial head fracture, with a coronoid process fracture, and ligamentous injury. So always look for coronoid process fracture. That is an important thing. Sometimes you can see it on a good X-ray, lateral X-ray as well. I know it's a big topic. My talk is not about instability of the elbow, but the key thing is remember these two, the first line there. Lateral ulnar collateral ligament and anterior band of UCL, ulnar collateral. These are the two things, lateral ulnar collateral ligament and ulnar collateral ligament anterior band. These are the two things which are most important static soft tissue constraints. And MR, you're good at picking up 100% of full thickness tears. Partial thickness tears can be tricky. Again, post-traumatic laxity is usually because of LUCL injuries. And this is another image. I mean, this is another pearl I want to get across to you is that the soft tissue, because the common dislocation is posterolateral. So it's going to affect the lateral ligament complex first. And then as the injuries go around, they're going to affect the medial collateral ligament. So the circle of Horry say that it starts from the lateral and then it travels medial, and then you can have associated capsular injury as well. Okay, tendon pathologies, you can have tendon tears, biceps tendon tear on ultrasound, you can see a wavy kind of tendon. On MR, you can see edema and thickening, and all that. And you can have brachialis muscle strain as well. Okay, and you can have triceps avulsions or triceps enthesopathy. Okay, I know well, thankfully I've got time, so I'm okay with like 15 minutes to go. So again, joint problems. I mean, it's a synovial joint, and sometimes the thing is, elbow is particular in a way that people sit on it. And by the time they present to you, they have got gross destruction or there's so much synovitis. I mean, you would be amazed at how this patient has presented this late. Okay. Unless you've got a good rheumatology survey, which we have thankfully here, then you pick up things, somebody who's got rheumatoid arthritis, they present with a swollen elbow, you do an MR or you do an ultrasound, you see there is fluid, but look at this. This is synovitis. This is significant synovial thickening in the posterior recess, in the interior recess. This is much more than synovitis. This is from literature. This is tenosynovial giant cell tumor. This was a patient we had 2 weeks back, 17-year-old girl, known to have a rheumatological condition diagnosed as a child, then off treatment, then she presented with multiple joint pain. We scanned her elbows, knees, and wrists and hands, right? Okay, so these are the two elbows there. You can see again fluid, but look at that. I want you to appreciate that gray kind of lobular synovial thickening. This is synovitis. This is not just a simple effusion. And look at the edema in the muscle there as well. And look at the axial again. Look at this. This is florid synovitis. If we give contrast, it will enhance. So you do an ultrasound, it will be hyperemic. And the other thing you notice here is because it's been there for many years, look at the olecranon. I know it's a bit different kind of level, but there is a bit of scalloping of it as well. There is some pressure effect there. This is her wrist extra. We don't do that much kind of hand and wrist MRs for synovitis. I know my colleagues in CCRE, they do a lot of these. But you can see there's effusions. There are effusions in the MCP joints, PIP joints, in the wrist, in the distal radial joints. So this is a multi-systemic inflammatory arthropathy. This is juvenile inflammatory arthropathy. So always think about that. This could be PVNS, yes, okay, but these are gradient echo images with significant blooming. This is hemocydin deposition, hemophilic arthropathy. So the X-ray I want you to put across is this. If you see this, these patients are really young. If somebody 30-year-old have got this kind of picture with flattening of articular surfaces, some cystic change, you have to think, have they got sickle cell disease? Have they got hemophilic arthropathy? Have they got hemophilia? Something underlying, because, or had they had previous injury? So whenever you see significant arthritis which is disproportionate to patient's age, you have to think about trauma, infection, or any underlying kind of hemoglobinopathy or things like that. Okay, ulnar nerve. I mean, cubital tunnel. It's the commonest thing we see. You can sometimes see a ganglion. You can see denervation edema. So sometimes we don't see problem in the nerve as such, but you see the effects of it. The ulnar nerve, it's for my radiology colleagues, I mean, I like to see it on axial as well as on the sagittal. And on the very kind of last images towards the medial side, when you see the medial epicondyle, you can see the ulnar nerve. And you see sometimes you can see flattening, you can see a bit of hyperintensity, which is different from the proximal and distal. So this is a good sequence to look for. And similarly, you can see the accessory and coneus epitrochlearis as well. Okay. And the key thing is for us to diagnose this before you get kind of any nerve conduction problems, because then you can kind of, you don't want to end up in this area, because then the functional outcomes will be poor. So this is a good paper. I know they talk about signal intensity, which I don't kind of buy, but the key thing is that your surface area, they say that if the surface area is 0.12, then when using a size of 0.08, sorry. So like for the median nerve at the wrist, we use 0.12, but for the ulnar nerve, it's 0.08 at the elbow. Radial nerve, you can have ganglions, which can press on the pin, and you can have edema with that. Right. Bursae. So, and it's more common electron bursitis than we think. I mean, you look at the X-rays, say soft tissue swelling or pain, and people tend to don't look at the soft tissues at the back of the elbow. So always, if there is swelling there on an X-ray, say it could be chronic or it could be acute, like electron bursitis. Sometimes we have to do MR to see if there's any deep extension, any osteomyelitis, things like that. So this is a sagittal stir image for you, showing extensive edema with pockets of fluid above the fascia. It's a subcutaneous bursa. Okay. The other bursa, which we don't see that often, but it's important to know about it, is called the bicipitoradial bursa or cubital bursa. And it basically, it's like I would say it's similar to your source bursa anterior to the hip. So it's usually along the biceps tendon, distal one, because the biceps tendon, the distal biceps tendon, as you would know, it doesn't have any synovial sheath. But just like the Achilles, it has got just a loose connective tissue. So just to kind of to help it glide a bit more, there is an adventitious, there's a bursa that usually is not kind of distended, but it can have any synovial pathology, rheumatoid infection, things like that. So whenever you see a cystic mass related to the distal biceps tendon, think about bicipitoradial bursitis. Okay, so I stop here just to take you back to that schema of imaging, and then for the next 10 minutes or so, we're going to go through the cases. Okay. I'm going to take a sip of water. So we're going to leave the questions towards the end. So I start with the first case now. So we've got an 11-year-old boy, fall and left elbow pain. Okay. So obviously, I mean, we're looking for any fracture. It's 11-year-old, so you would look for the Critol thing. Okay, so you can see that there is, you can see there is the capitellum. All right. Okay, so C is there. R is there, okay, trochlea is there, olecranon is there, lateral hasn't appeared yet, okay. But where is the eye? You see, it's quite flat there, okay. And then you see there is another thing which is sitting here. This shouldn't be there. But if we are not sure, we compare it to the other X. I've flipped it for you, all of you. So this is the right side, this is the left side we are looking at. So if you see here, this is your this is your medial epicondyle there, okay. But over here, it's not there. So it must have moved. This thing that you are seeing here, that's a displaced medial epicondyle. And on CT, you can see it there as well. The patient had an MRI, and then we started getting ulnar claw deformity. And you see there, this is the ulnar nerve. This is the ulnar nerve just being kind of hitched, just being kind of splayed over by the displaced medial epicondyle fragment. And for the astute eye, you can see there's a fluid-filled linear kind of line in the olecranon as well.
Sorry, Asad, we can't see your pointer on the screen.
Okay, yeah. I didn't realize that. I thought, oh, yeah, there we go. Sorry, it's coming. It doesn't go across. I can see it on my screen here, the mouse. Sorry, okay, well, I mean, if you look here, this is on the MR, you can see that this, the last image there is, oh, there we go. It's not moving. Or should I use this one? Yeah, great. Okay. Yeah, there we go. Yeah, okay, good. Thank you. Thanks, Ravi. So if we go back, I think let's go back. So you can see that this is the normal elbow side, right? Okay, so this is your medial epicondyle, it's displaced. Okay. And then on the MR, you can see that this is the displaced fragment. This is the medial epicondyle that has gone into the joint. And this structure there, the line, this kind of cord-like structure, this is the ulnar nerve, which is being pulled over it. Okay. And then this is basically medial epicondyle avulsion with olecranon fracture, and that was fixed later on. So it's important to count. There's no harm in kind of counting the ossification nuclei. If you're not sure, get a contralateral elbow X-ray, and that will save a lot of misery for the patient as well as yourself. Okay. Next case, similar on the similar kind of note, I'm showing you this. Again, this is a much younger child. Okay. You can see there is the capitellum is ossified, C is there, R is there, but there is a little dot that you are seeing there. That shouldn't be there. It can't be the olecranon, it's in the joint. Okay. So this is again the ossification nucleus of the medial epicondyle because it's big cartilage lump, and that is the tip of the iceberg. There's a big cartilage lump sitting with it that has displaced into the joint. Okay. So no matter how small or how big it is, any ossicle at the joint line is abnormal, regardless of the size. So always kind of try to look for these. Okay. I know I'm showing you X-rays, but I mean, I think elbow X-rays are interesting. So this is a 25-year-old patient. And as you can see, this is a grossly deformed elbow. I mean, this could be rheumatoid arthritis. Yeah, I mean, rheumatoid elbows can be like that. But if you look there, I mean, this looks like there is the inferior kind of dislocation of the humerus on the lateral radiograph. But the one thing I like you to look at is look at the shape of the olecranon fossa. Look at the shape of the articular surface of the ulna. It looks like, particularly on the AP, if you see, it looks like there is something that is causing this remodeling. There is something that is living in the joint and is causing these kind of pressure erosions over time. This has happened, must have happened over years. This is chronic deformity of the elbow. PVNS, tenosynovial giant cell tumor, can do that. Okay, but this is a rare one. This is, I mean, I've probably seen it once. This is Niemann-Pick disease, which is basically a lipid storage disease that can affect multiple joints. So it's a rare one, I know. But the point I want to get across is, if you see scalloping, think about there is something sitting in the joint that is causing these pressures. Okay, okay, this is relatively easy. So 22-year-old guy, painful elbow, AP and oblique lateral radiograph. I mean, obviously you can see there is some abnormality in the capitellum. I mean, this is not the right age for osteochondritis dissecans, but you can see there's a lucency there. Could it be a fracture? We'll see, okay. But the other thing is, if you see there's some soft tissue density on the medial side. And if you come to the lateral X-ray, there is some periosteal reaction, radial neck. And the other thing is, if you see there are these soft tissue nodules. So there is something happening to this joint. There is a reactive change. There are these nodules as well. Okay. So we did ultrasound, but I don't think I've got ultrasound here, but I'm going to show you the MR. So this is a sagittal stir image. So it shows you there is edema in the capitellum. There is edema in the radial head and neck. But there's all this like a dumbbell-shaped synovial thickening. Okay. So it's a joint-based problem probably, which has secondarily affected the bone, or it's a bone-based problem that is spilled into the joint. That's always the question. Is it a joint-based problem or a bone-based problem? So I show you this image, and I think most of you will have picked this. I mean, this is a post-contrast image. And you can see that there is this subcutaneous collection there. Sorry, this mouse is, let me just take it out. This one. But the important thing is the capitellar abnormality that we were seeing, it's like a defect, but there is an enhancing wall to it. It's like an erosion. So this is, to me, or to all of us, we should think this is an acute, this is an angry joint. This is septic arthritis, probably osteomyelitis of the capitellum, and then secondary spillage into the joint. Okay. But I'm going to show you more images. Sorry. Okay, yeah. So the diagnosis is there, right? Okay, there we go. Septic arthritis with Mycobacterium tuberculosis. But I have put the 1-year follow-up X-ray for you there. If we see that X-ray, you would see this has got erosive arthropathy. You got erosions where the capitellar osteomyelitis was, and you got this kind of scalloping on the lateral, on the medial side as well. So whenever you see this X-ray, whenever you think about erosive arthropathy, go back, because septic arthritis, sickly septic arthritis can mimic an erosive arthropathy. Okay. So too much about the joint-based problem. So getting to a bit of trauma. So this patient had elbow dislocation, and we did a CT, and we did MR subsequently. So you can see on the sagittal CT reformat, there is a minimally displaced coronoid-based fracture. The MR shows you edema. And then now we need to look at the ligaments. And I have put these two images. I know, I mean, in normal practice, we don't have the luxury of comparing it with the normal kind of normal anatomy. But first, let's look at this kind of normal elbow. I mean, obviously, this patient has got some lateral epicondylitis. But the thing is that arrow is pointing towards the ulnar collateral ligament. See how sharply it bends. It's taut, it's sharply bending. But when you compare to the MR image next door, you can see that there is that tight structure is gone. There's a wavy contour to it. This is how we diagnose a lateral ulnar collateral ligament injury. And then obviously you look for the humeral attachment. You can see there is edema there. So there is at least a high-grade tear towards the humeral attachment. Okay. And obviously there is bone bruising and the edema at the coronoid fracture. So always look for this. If you get a wavy, like the MCL, if the MCL is torn, it springs back. Okay, a few more cases, just a few more minutes. Okay, this is, I mean, you can see there is edema in the lateral common extensor tendon region. This is like a partial thickness tear. For these, if you are scanning them, I won't put steroids there. I think these are the candidates for PRP. So common extensor tendon origin, partial thickness tear. Okay, right. Oblique X-ray, young patient, okay, pain. But I'm going to show you the AP, and all of you are going to see what I'm showing you. So there is a large lytic lesion in the medial humeral condyle. Okay, these are over the last kind of like a series of X-rays. This was treated, cemented, then it recurred, fractured, then you got sclerosis and all that. So diagnosis, excellent. And what is it being treated with? Denosumab. So whenever you get this kind of sclerotic appearance in somebody with a lytic lesion, they are on denosumab. Denosumab is a rank ligand inhibitor. It leads to osteoclastic kind of dedifferentiation and all that. So it leads to imbalance. So there's a lot of osteoblastic activity. And usually they are on it if it's an irresectable GCT in the sacrum or in a large joint, things like that. So always think about GCT on denosumab. Last case, 60-year-old female. You can see this is a sagittal T1. You can see an iso-intense lesion with endosteal scalloping of the distal humerus on fat suppressor. It's bright X-ray. So 60-year-old with a lytic lesion. You can see there's a bit of periosteal reaction there. This is metastases or myeloma. This is not a primary bone lesion in that age group. And then the patient fractured through. This is the MR after that, so plasmacytoma. So think about bone lesions as well. We do see bone lesions around the elbow. And that's all. Thank you for your attention. We've got time for questions. All right. Any question for Dr. Rami, myself, Dr. Zabi?
Well, first of all, thank you. Thank you very much. What a fantastic session, actually, covering the shoulder, elbow, and being my specialty. So it was, I found it very, very interesting. Thank you, Dr. Rami, for coming from Oxford and giving your talk. I can't see you there. Yes. So thank you so much. And I said it was very comprehensive elbow coverage. And again, the cases from Dr. Mohammed was very interesting too. So I have, well, if nobody else has a question, I just wanted to ask a couple of things. Dr. Rami, yes. So, well, I was just looking for your ever position for MRI scan in the glenohumeral instability. So as an orthopedic surgeons, we know actually that is the position where patient feels very unsafe if they have anterior instability. So what else can you do to, if you can't get, you said that a forced external rotation, anything else you can do to get your images? Because patients are probably not comfortable in that position.
As I said in my presentation, it's a very good question, by the way, because a lot of those patients have pain and they put the shoulder in the abduction external rotation position. So we try to do that. However, these days we do more of a 3D acquisition with the new scanners. And we can adjust and reconstruct and reformat the images where we can see the labral tear. So I think this is, another option you can offer the patient. But again, this is really depends on the scanner, because this 3D images acquisition need at least, I think, the 3T, which will give you better images. I'm not I think again, it depends on the expertise of the reporter. I don't think, in my opinion, the ABR add much information as compared to the normal, good quality, in a normal position MRI. The ABR was done something in the old days when the quality of the MRI was low. And I think maybe we start thinking of not using it and dropping it, because I think in my own practice, I can see most of them we can get it, but we have to include it in the presentation, because if I didn't include it, people will ask about it. So, but in my personal experience, I agree, we don't need to use it in all patients routinely.
Thank you. I think I agree with Dr. Rami. I think in our kind of in SSMC, we don't use routinely the ABR thing. Mostly it's just a standard MR shoulder 3T. If there is suspicion for SLAP or labral injury, then obviously you go for MR orthogram. But ABR for selective, if you don't see anything and you still want to see a Perthes lesion or something, then you go for ABR, isn't it? But if it's, I mean, most of the time, I would say 9 out of 10, we get away. We use very selectively. It's not a routine thing that we use. And I think you're right. The patients are not able to do that, let alone they don't like fitting in the scanner. So you don't want to annoy them any further. Yeah.
Probably in those cases, maybe you will be needing orthopedic surgeon to come and reduce the shoulder dislocation in MR suite. Exactly. Thank you. Anybody else has questions to all three speakers?
I have one question. But first of all, I would like to thank all three speakers, Dr. Rami, Dr. Muhammad, and Dr. Asad, for your excellent presentation. Before I ask my question to Dr. Rami, I would also like to especially thank you, Dr. Rami, and dear colleagues. Thank you very much for being here, and thank you very much for the continuous support for the society and the radiologist community in UAE. For those who doesn't know, Dr. Rami is the global ambassador for RCR, and he's played a really very good role in organizing the first global RCR conference in UAE, Dubai. So thank you very much for all your support. My question is regarding would you do MR arthrogram for all suspected cases of labral tear? And they have two scenarios, and you can tell me if you will do in one of them, both of them, or the first scenario, if I have, especially if we're using a high definition 3 Tesla MRI, and you have completely normal MR with normal labrum, And the second scenario, if you have an obvious labral injury that, like the one you shows in the last case of yours. So which one would you do MR arthrogram in both of the scenario, on one of the scenario, or what is your intake on that? Thank you very much.
Thank you, and thank you for the introduction. It's always my pleasure to come to the UAE and have collaboration with the UAE Society, and whether in Abu Dhabi or Dubai or any other Emirates. So it's always a pleasure. Answering your question, I think still MRI arthrogram is the gold standard in the shoulder. It's not just the labrum, as I demonstrated in my presentation. Sometimes, yes, I agree. Sometimes we can see the labral tear without arthrogram, but still we need to comment on the state of the articular cartilage. We need to comment on the state of the other ligaments, like the glenohumeral ligaments. And I think even with the 3T MRI, we cannot see this appropriately, because without this tension of the shoulder, we cannot separate, especially the inferior glenohumeral ligament. We didn't see the leak of the contrast into the recess. And again, like the example I showed you in my presentation about this articular fragment, it will not appear like this. It will not appear and floating unless we distended and injected the contrast. You might argue whether do we need the contrast or just injecting saline. This is another argument which I don't know the answer for it, but I think I don't think till the moment, till current evidence, I think we need to distend the joint with contrast. I don't think the 3T has replaced. I can have a different argument with the hip, for example, and wrist, which we don't use it routinely, but till now, I think with the shoulder we need contrast. We need distension.
Thank you, Rami. For the RCR Gopal conference, this is exactly the talk Rami gave me. Arthrogram, do we still need it? And for that, I did a survey, and the outcome of the survey was for the shoulder. Yes, the arthrogram, most people felt that arthrogram has still got a role, but the other joints, it can get away, but the shoulder was the, especially problem solving for the labral tears, predominantly for the instability. So yeah, that is interesting question. Thank you, Rami, and thank you, Asad, for wonderful cases and presentation. Any more? There are a couple of more cases, questions on the online. Does T1 sequence axial for shoulder labrum other than T2 fat sat or spur help? I didn't understand the question. And there is another interesting question. Does standalone diagnostic center in UAE allowed to do shoulder MR arthrography? Maybe Dr. Rumaiti can answer.
I think I can answer the first question, but the second question is for you guys to answer. Yeah, I think we use T1 sequence because T1 sequence can show the bone cortex and the bone very well. We can argue whether we need other 3D sequences. So when we do a 3D sequence, we do the T1 vibe sequence, which is very, very good in showing the bone details. And we are currently testing whether this 3D T1 vibe can replace the CT, because we can reconstruct it and show the bone fragment very well. So yeah, I think it's still needed. And I prefer it from, if I compare it for T2, I prefer the T1 in my own practice. I prefer to do the T1, or it's one of its variants.
Thank you. The second
Can I
question.
weigh in on the second question?
I really don't know the regulation about this in the Abu Dhabi or outside, but personally, I don't see why not. But according to the regulation, I'm not 100% sure of what.
Can I weigh on the second question? Is Dr. Nadeem here? Can you hear me?
Hello, Dr. Nadeem. Yes,
Can you hear me?
yes.
Fantastic. I do not know who asked the question, but it will be a matter of two things. One would be the matter of skill and equipment. If a particular center has what is required to do the arthrogram, so either like Dr. Remy said, that they prefer to do it on ultrasound and then take the patient to MRI, or they do it under fluoro and then they take the patient to MRI, and whether they have an orthopedic surgeon who can actually recommend and then act upon that information. If they go it under a normal private center, and they will have to decide the revenue model, that if the revenue model is through the insurance, then insurance probably will not give the permission to do that. But if they are going to do it on the international tourism patients or cash patients, then technically there's nothing stopping them legally doing it. But it is a matter of fitting it in the current revenue cycle management framework, as well as patient's clinical outcome, whether patient will benefit from that or not.
Thank you.
I'm not sure how well you can hear me.
Yeah, it's very clearly heard. Thank you, Nadeem. There are more questions popping in, but we don't have so much time. I think we'll have a quick coffee break. We'll grab some coffee and come back, and we can answer the questions online, some of the questions. And if there is no questions from the on-site delegates, then we'll take a quick break. There are quiz laptops outside with Dr. Asad has put a lot of effort creating the quiz. So please have a look, and there will be at the end, the answers will be discussed. And before going for a coffee, if we can have a quick group picture, I would invite everybody to come on to the stage. Thank you.
Welcome back, everyone. You're gonna Ready? Welcome back, everyone, for the second session, which is again, it's about wrist, hands, and hips. So I would like to. Well, we've got the moderators here, Dr. Usama Bastaki from DHA Rashid Hospital, Dubai, and he's a consultant radiologist. And we've got Dr. Amin Al-Hilou. He is our esteemed upper limb orthopedic surgeon from SSMC. So thank you. So my first speaker, I'm going to give me pleasure to invite Dr. Rami Mansoor again, and he's going to give us a talk about wrist and hand MRI pitfalls and tips. Dr. Rami, please.
So the first slide, please. So this is the first presentation of the second session, and it will be about the wrist and hand. And again, they will focus in my presentation, will focus on the TFCC injuries and how we diagnose it. The articular cartilage of the TFCC, the anatomy of the TFCC is very complex, and it's very important to know the anatomy. And it is basically composed of fibrocartilage and a different ligament. It comprises 8 components that includes the triangular fibrocartilage, which is the central disc, as you can see in the diagram, and also in the anterior and posteriorly, there is, or the in palmar or dorsal aspect, there is the radioulnar ligaments. There is the what we call the ulnomeniscal homologue, and anteriorly there is 2 ligaments, which is the ulnotriquetral and the ulnolate ligament. The ulnar collateral ligament is on the side, and the sheath of the extensor carpi ulnaris tendon is also part of what we call the triangular fibrocartilage complex. The function of the TFCC is it acts as a cushion or a shock absorber. And as you can see in the literature, they say that 20% of the axial load is transmitted through the TFCC. It also allows the side-to-side sliding of the carpal bone over the radius, and it can stabilize the function of the wrist, especially in pronation and supination. So it's very important function of the wrist for the TFCC. The best view or the best plane to assess the articular fibrocartilage is the coronal and sagittal, where we can see the central disc as a black structure filling the space between, I think the arrows also doesn't appear. So how we can show it here? The thing is, I can see the arrow in my screen, but not on the projection. Okay. So as you can see, the articular fibrocartilage is best seen in the coronal and sagittal plane. So the central disc, it looks like signal void like this, is black, and the ligaments of the tendon looks with the older signal, and this is normal. And you can see that this is the way we can see the central disc in the coronal and sagittal planes. And also we can identify the different ulnar attachment, which is the styloid and the foveal attachment of the TFCC. So now I lost the control from this. So which one I need to use? Both of them? Okay. And as you can see in the coronal images, we can see the arrows, we can see the TFCC, and we can see the ulnar attachment of the TFCC. And there is 2 ulnar attachment. The one that is attached to the ulnar styloid, we call it the styloid attachment. And the one which is attached in the fovea, as indicated by the arrow on the left side, is the foveal attachment. So, and you can see both of them cannot be seen in one plane. You have to go through the coronal plane to see both of them. The other ligament, the ulnotriquetral and the ulnolate ligament, is very difficult to see, and sometimes, most of the time, you need to do an arthrogram to be adequately to see this ligament, and they can see seen anteriorly. And you can see in this patient here, as the arrow shows, we can manage. Sometimes we can manage to see the ulnotriquetral ligament but the best view is the sagittal. And you can see in this images is the 3D reconstruction. So it's very difficult to see those kind of anterior ligament in the normal patients. That's why we struggle to identify when they are torn. So TFCC injuries, I think there are several ways someone can injure their TFCC. The most common one is trauma, when someone fell on outstretched hand, and this can injure their TFCC. And the other cause of injuries is sports. Weightlifting, because of the twisting, another sport like cricket or tennis or volleyball, all this kind of sports can injure the TFCC. Unfortunately, especially with the sports type of injuries, most of the patients are represented with vague, non-specific pain on the under side of the wrist, which could be for different causes. Still, MRI is the only and the gold standard way of scanning the TFCC. Ultrasound and other imaging is not really good in showing the TFCC. And this is one, as we discussed, the arthro in the shoulder. This, again, it depends on the expertise of the unit. You can use arthrogram, or if you have a 3T scanner and you're expert in anatomy, so you might not need an arthrogram. So this is where arthrogram might not be routinely used. In some institutions, they use CT arthrogram to combine the anatomy of the bone and the soft tissue. But in my institution, we don't really use it routinely, the CT arthrogram. And as I mentioned in the shoulder presentation, the new sequences with the 3D and the T1 vibe, you can have a similar images to the CT by just using the MRI. Plain radiograph is necessary when you're looking for the acute injuries. So when you're looking for a patient with suspected TFCC injury, this is what you need to look at and assess on MRI. You need to look at the fibrocartilage, the TFCC. You look at the cartilage surface of the lunate and the other carpal bones and the distal radius. You want to look at the distal radial ulnar joint and different intrinsic ligaments like the lunotriquetral, ulnolunate, and the ulnotriquetral ligaments. In the literature, there is a classification, what we call the Palmer classification with an E, not an A. And this is just a way of describing the different types of the TFCC tear. Again, like any classification in the MSK, you don't necessarily need to use it. All you need to is just describe what you see. But again, it's up to you. The most difficult one that we struggle to see is the type C, where the tear is in the anterior ligament of the ulnotriquetral and the ulnostyloid. So I'll show you some examples of different type of articular fibrocartilage. So this is the type affecting the central disc, which is the type A. And you can see it can be easily seen in the arthrogram of CT, and also can be seen in the MRI. And the other type is the type D, where the tear is very close to its radial attachment. And again, you don't really need to remember all this kind of classification. I personally don't mention it at all. All you need to describe is where is the tear and whether it's complete or incomplete. This is another type, and this is probably my only example of the lunotriquetral and ulnotriquetral ligament tear. And you can see here in this patient, there is disruption between the fibers that connects the TFCC and the lunate bone. So this is an example of radiolunate ligament tear, which is described as Palmer C. The other classification that is used for the styloid, the ulnar attachment, is what we call the ATSI classification. And again, this is another more complex classification of the TFCC tear, and it describes different variation of tearing of the ulnar attachment to TFCC, whether it's incomplete or complete, affecting the both attachments, or as you can see, is affecting the foveal. It's very complex. And this is, again, depends on the hand surgeon you have in your institution or your hospital, whether they are keen or have the skills to repair this type of lesion or not. So if they don't repair, probably they will not ask to comment on this type of injuries. But it's commonly seen, and if you know about them and you carefully look for those lesions, you will probably see it in those patients. And you can see this patient didn't have an arthrogram. So we did inject the arthrogram, and this is just a normal 3T scanner. And you can see in this patient that there is a tear that it is represented. Again, I'll try to show you on the screen. I don't know if you can see it there. I can see the arrow showing a tear through the ulnar attachment of the TFCC, which is complete. This is another example of a complete tear of the ulnar attachment TFCC, which involves the styloid and the foveal attachment, and you can see it's completely avulsed. In this patient, you can see that the tear is only involving the foveal attachment, and the styloid attachment is intact. It's very important when you're looking for those patients, because the orientation of the TFC is just oblique. So it's very important to look at the different slides and scroll through your coronal images to make sure that there is no a styloid or a foveal attachment, because you can start overcalling those kind of injuries. And of course, if you're not sure and you're not have the expertise to comment on that, the best way is to inject the arthrogram and see if there is any extravasation of the contrast outside the joint, the best way. And this is just an example of one of those patients that we didn't really need an arthrogram in the beginning. You can see that in the plain X-ray, it didn't show much, but on the MRI, showed there is effusion, and there is also bone contusion and tear of the ulnar side of the TFCC. And here another example of TFCC tear with the ulnar attachment. And in this instance, we injected contrast, and you can see that the leak of contrast is through the ulnar side. So it really depends on your expertise and the availability of arthrogram or not. Sometimes the ulnar side injury is more complex and can involve even the ECU sheath. And like this patient, the patient have contusion of his ulnar styloid, and you can see there is bone injury here, injured the ulnar attachment. And at the same time, you can see that the ECU tendon has subluxed anteriorly. And this is more of a complex injury to the ulnar side of the wrist. problems of the TFC can only be degenerative, not just traumatic, as we mentioned in the beginning. And this is mainly because of the overuse. And again, it's classified by Palmer and it, as you can see, if you look through the different classification, A, B, and C, D, it's just an indication of the progression of the injury and degeneration of the fibrocartilage. It can start by degeneration, then tear, then cartilage degeneration, and so on. And let's just show you a different example. This is how it starts. Most of the time, the degeneration of the TFC starts in the ulnar side. And you can see here, we injected contrast in the distal radio-ulnar joint, and we can see there is irregularity of the ulnar side of the TFCC. Whether to inject in the carpal, the proximal radiocarpal, or the distal radio-ulnar joint, this is really depends on the hand surgeon, whether this person is happy to repair those lesions or not. And most of the time, they will direct you to which joint to inject. Sometimes they are not sure, and they will ask you to do both, whether to inject the distal radio-ulnar joint or the radiocarpal joint. But this was a tennis player, and the clinical examination and the suspicion was a chronic overuse injury of the TFCC. That's why we started by injecting the contrast in the distal radio-ulnar joint. And he was correct, the hand surgeon, that there is a degenerative change there. For those patients, you can do it with a CT arthrogram, can also give you similar appearances. And this can happen in two situations: when the patient doesn't, there is any contraindication for CT, for MRI, you can use CT as an alternative. And in this patient, you can see that the TFC is irregular, the ulnar surface. There is even damage to the articular cartilage over the ulnar styloid, and there is a tear of the TFCC. So you can see that CT arthrogram is really very nice in showing this, the TFCC abnormality. This is a chronic patient with a chronic pain, and he had an injury a while ago, like a couple of years before he does this CT. And you can see in this patient, there is a tear of the central disc, but also there is a small avulsion fracture of the ligament between the lunate and the scaphoid, which is a kind of indication of a chronic scaphulonate ligament. And you can see here, again, it's not showing, I don't know if you can see the tiny, bone fragment here in the place of the TFCC. So this can be injured also with the articular fibrocartilage. The ligaments can be injured and can be seen in your arthrogram. And this is another example of the lunotriquetral ligament injury. You can see that the contrast is leaking into the space between the lunate and the trochleatrium, and the CT images and the MRI images confirm the same diagnosis. So the TFCC injuries is common, especially in sports, as we already know. The anatomy is complex. And all you need is to look at the different anatomy structure, whether it's the ligaments or cartilage there, and just comment on it. MRI or MRI arthrogram, both of them can be used. Depends on your scanner and the local expertise, which one to use. And MRI and CT can be also useful in some patient. Thank you very much.
Thank you, Dr. Rami, for such a detailed presentation on TFC complex pathologies. So we're going to go to the case discussion session now. So I'm going to invite Dr. Sara Zishan. She's a consultant MSK radiologist in HealthPoint. All right, okay. Dr. Ahmed Hamza's name is there as well. He's also a consultant in HealthPoint. So Dr. Ahmed Hamza, please. Thank you.
Hello, everyone. Thank you for the invitation. My name is Dr. Ahmed Hamza, one of the musculoskeletal radiology in HealthPoint. So I'm going to present some interesting cases. Some of these cases are debatable. I might provide some discussion. I've got some 3 cases. Thankfully, none of them has got any TFCC injury. Thank Dr. Rami cases. So the first case is a 24-year-old man. He was involved in a road traffic accident. He's a motorcycle against a car. He was in a motorcycle. Sustained injury to his left hand. He's got swelling, bruising over the thin eminence and hyperthenor, and it was tender on the anatomical snuff box. So his initial concern was that he got any scaphoid fracture. Oh, sorry. So this is the radiograph. He's got a frontal and lateral radiograph X-ray. I think on the initial, there was nothing really to see there. They did a scaphoid view, which we couldn't see any fracture. So next thing, he had an MRI scan. I will just try to play it here. How do you play it? How do you play the video? No, if you go back. No. No, you want to play the video. I can't see it here. Okay, so how do you play the video? Is there any way of controlling it? I can't. I want to control the. How do you pause it? Can someone help me? You can't do it with the mouse. Okay, so this is a coronal radiograph, so coronal MRI scan. So what's sensitive? PD FAST-SAT. So it's going from the volar aspect to the dorsal aspect, and if you can see, it's got this high signal at the hamate, and it shows got hook of hamate fracture. It's also got TFCC, also looks abnormal. But the interesting part, if you look at the scaphoid at the radial dorsal aspect, there is some irregularity there. Can you see that? Yeah. But there's not much signal changes in that area. So we've done then, if you look at the next slide, the axial. Can I do it from there or? No, so next one. Sorry. So next slide. Okay, thank you. So this is the axial sequence, again, going from distal to proximal. So this is the hook of hamate fracture here. And then if you look at see this high signal fluid the dorsal aspect. And then again, you can see there's irregularity at the dorsal radial aspect of the scaphoid. There's some line there. So this is a case who suspected patient has got an extrinsic ligament injury of the dorsal intercarpal. So I don't know if you can see. It's probably gonna be. Shall I just come there then and do it? Do you control it or? Oh, can I move the mouse? Okay. Okay. So it's a very small structure, so it would be difficult to see. So if you see here, abnormal thing here has got this large fluid around this area, and it's got fluid between the scaphoid and the capitate here. And then if you go, I'm just trying to show a small structure. So there is you get the extrinsic dorsal ligament. So first you get the radiotracheal ligament, which is thickens, goes all the way. Sorry, I can't. It's not very smooth to see. Yeah. So the so we got the radiotracheal ligaments coming across, and then like a V shape. Then you've got this the other ligament, which is here. This is the part of the dorsal intercarpal ligament, which is here, and then there's a irregularity here, and it's going all the way to the scaphoid. So this was thought is going to be a dorsal intercarpal ligament. I don't know if anyone can see that, or probably don't believe me. Yeah. So this is the images here. So you can see it looks abnormal. Normally, you don't see much fluid in this area, and you see there's a bit of gap between the scaphoid and the capitate. And then here you've got this fragments coming across here. So this is part of the extrinsic ligament injury. Sorry, so many devices. So this is a dorsal intercarpal ligament injury. It's got hook-up hamate fracture with a false fragment of the scaphoid. And then, so this is the ligament. So in the MRIs, we are more common looking at the intrinsic ligament, which is mainly the scaphoid lunate, the lunate tracheatum, and the TFCC. But there are other ligaments which are important, especially the what's it called? There's intrinsic. There's also the outside ligament, including the dorsal ligament. So dorsal ligament of there are dorsal intercarpal ligament and the radial tracheatal ligament. They make a V shape, as you can see here, and this ligament is attached to the dorsal aspect of the tracheatum and goes all the way to the scaphoid. You also attach to the lunate, and there's another attachment to the scaphoid lunate and the lunate tracheatum. So it acts like a stabilizer. So it stops any scaphoid lunate dissociation or rotational. And in 50% of people, they got attachment to the trapezium. Any question, first case? Sorry about the glitch. So this is trying to show a normal scan. That probably is going to be difficult. So this is a normal MRIs just to compare. So normally you don't see any fluid. This is this is a good example here. So this is the dorsal intercarpal ligament. It's very thin, nice ligament. You see all the way across, which in that case was thick. And then when you come down, so it's not. So yeah, you can see it here. Okay, any question, first case? No. Okay, so second case is 16 years old girl. She's an amateur golf player. She had a high velocity injury while playing golf. She was swinging the club and then she hit the rock. She's got this pain on the radial aspect of the wrist with loss of power on the grip. So initially she had an x-ray. This is the frontal x-ray and lateral. It was pretty unremarkable, no obvious fracture you can see. And then she had an MRI scan. So just to show you other abnormality now we don't see often in the wrist. So the MRI initially we look at it. This is the coronal PD fat side of the wrist. There's no obvious fracture we could see, but what you can see here is there is this high signal at the trapezoid and also the capitate, and there's lots of joint space between them. Also, there is some high signal at the articular surface at the third CMCJ. If I can bring it here. So here, and also maybe the base of the third metacarpal. So this is a case of a coalition of the capitate trapezoid, and this is the axial sequence. So again, going from distal to proximal. So the top is the vol aspect and the bottom is the dorsal aspect. So this is an external scansoid quality. But so this is the capitate. So this is the trapezoid and the capitate. There's lots of the space here, and then you've got this high signal, and there's a cyst within it. So this is a coalition of fibrocardiac coalition in this case. So this is a rare case of carpal bone coalition. We see many carpal bone coalition, mainly at the lunate tracheotomy. It's about 90%, but about 4% you'll see capitate trapezoid coalition, and it does cause secondary OA. The reason is because there's loss of the cartilage in between, and you got the fibrocartilage in between them. So it will act like an OA, but that's why you got degenerative changes. It'll also affect the biomechanical change of the wrist, and you can have a secondary CMCJ degenerative changes. So this is other causes of the pain in the wrist that maybe think about it. There's a few classification based on plain film radiograph. There's type 1, which is there's no fusion, only fibrocartilage. There's type 2, which is partial osseous coalition. Type 3, complete coalition. Type 4, complete osseous coalition with other abnormality. Type 1 is susceptible to trauma. So in her case, she had high trauma, and this is caused the pain. And then with the repetitive movement playing golf, developed degenerative changes around the joint, and also secondary changes in the other joint due to the biomechanical changes. Okay. Any questions? Second case. So the third and final case is an interesting case. So this is 25 years old. He had a 1 month history of left little finger swelling and discoloration. He was seen at the hospital, and he had an external plain film radiograph. This is the frontal and the lateral, and they picked up there's some cortical defect at the tip of the left little finger, which was because of the history of infection. The thought here, this is an osteomyelitis. So he was started on antibiotic, and then he was referred to us, and then he came, and then he had an MRI scan. And in the MRI, we didn't see much really changes there. We just saw some tiny signal changes in the bone marrow, but not, and some subtle soft tissue changes, but otherwise there was no evidence of osteomyelitis. And then, so we said, and then this is a T1. Interestingly, didn't show any changes, didn't even show the changes that we saw in the radiograph. So they did a follow-up with the plain film radiograph and ultrasound. The ultrasound showed some collection under the nail bed. It was diagnosed with a paronychia, and at the same time, we did the repeat plain film radiograph, and you can see now the tip of the little finger is resolved. So you compare it with the previous one, and there was no changes at all. So the reason, probably picked it out now, is there's an overexposure of the plain film radiograph, because you can see on the left, you can see the soft tissue, but on the right, you can't see the soft tissue. Can you see that? Yeah. Yeah. So it was a paronychia, it wasn't an osteomyelitis, and that's the final case. Right. Thank you very much.
Thank you, Dr. Hamza, for in these interesting cases. Thank you, Asir, for helping out. Yep. Next is I would like to invite Dr. Sara Zishan, consultant MSK radiologist from HealthPoint, and she's going to take us through the hip MRI pitfalls and tips. Dr. Zishan, please. Yeah, first slide, please. I use this more this time, so.
Good morning, everyone. I'm Dr. Zishan. Thanks for inviting me to speak at this meeting. I'm, I think, privileged because I'm sharing the podium with Dr. Amin Mansoor, whom I once trained with in Oxford. So it gives me immense pleasure, and I feel a bit, overwhelmed that I am here speaking at a musculoskeletal conference where once I trained under Dr. Mansoor when I was in Oxford doing a fellowship in that region. Can you all hear me? Is this? Yeah.
You can use the microphone.
We can't have two meetings. Hello, hello. Better? Sorry about this technical glitches. Okay, so my talk is going to be very simple. It's going to be very practical aspects of how I read an MRI hip. I'm not going to go too much into details of FAI, MR arthrograms, hip arthrograms, and all that, because I think it will take too much time, and it's a topic in itself. So let's start. So I don't have any financial disclosures to make. Not working. Pointer. So objectives, I'll go through the MRI technique. Simplest form, if you're new in MSK radiology, what essential sequences we need for diagnosis. Anatomy is key for any musculoskeletal interpretation of images, and what pathology we can see, a few cases we'll go through. So technique-wise, to make it very simple, all MSK scans need a T1 and a fluid sensitive sequence with fat saturation. So in several planes, and you can mix and match the planes. For hip, coronal T1 and STIR or PDFS sequences. As you can see here, so this is T1 coronal, this is PDFS coronal. And then we do an axial, we can combine that with a PDFS axial as well. So any fluid sensitive sequence like STIR or PDFS should be fine. And then depending on what type of pathology you're looking at, if there's particular concern or question about hip, a particular hip joint, then you do dedicated axial small field of view images, 3 millimeter slices of axial oblique running through the, which will go through very quickly as well. So axial oblique and true sagittals can be added in different sequences. So axial oblique, or it's also called axial sagittal, some people call it sagittal oblique, but basically it's used to look at the labrum and the version of the acetabulum, and it runs through the mid of the neck of the femur, and this is what you get. So it's called the axial oblique. It's nice to look at the acetabulum, the labral pathology, to look at the femoral head neck junction, to look at the, the extra capsular ligaments that reinforce the hip joint. And true sagittal, which is here, this sequence shows the marrow looks at the greater trochanter in detail and the attachments to the greater trochanter. Okay, so I'm going to go through a little bit of anatomy. Okay. This is a little tricky to run the videos. Let's have a plan how we're going to do this, because I can't see the video button here. So I have to look at the screen here and then scroll. Okay, so I can't click here. Yeah, fine. So basically on the coronal images, this is a PDFS. What I start looking at is, obviously we're concentrating at the hip joint, but we have to look at everything else. So coronal, it gives a good overview. It gives a very good starting point to see where the abnormality is and where the money is. And we start looking closely on the other sequences at that region. Okay, so here we can see there's this, I know the hip joint is here, but it's important part of the pelvic bone, which is the ilium here, which forms part of the acetabulum. This is the acetabulum, which is formed by 3 bones, essentially. Anteriorly, there's the pubic bone. Posteriorly, there's the ischium, and then ilium as well, which forms part of the anterior and posterior columns, forming the acetabulum. So acetabulum forms the part of the ball and socket joint, which is the hip joint, which is a ball and socket joint. So it's a femoral head is 2/3 of a sphere. It sits nicely in the acetabulum. So we have to bear in mind that acetabulum has 3 bones to it, and there are several attachments which help reinforcing and stabilizing the joint. We have the joint capsule, we have the extracapsular ligaments, and this is a deep socket. So it's unlike a shoulder joint, which is a little unstable in itself, because glenoid is not as deep as the acetabulum. This is stable in itself. So dislocations of hip joint are uncommon, and posterior dislocations are more common. Okay, so we have to bear that in mind. So on coronal, as I go through, so now I've started looking at the ilium there, iliac blade. So there we have the SI joint, the sacrum is coming into play. And as I'm going more anteriorly, and I'm looking at the greater trochanter, I'm looking at the lesser trochanter. So greater trochanter, what attaches? There's gluteus maximus, medius, and minimus. So those are the abductors of the hip joint. Okay. And lesser trochanter, we have the iliopsoas muscle, which runs like that and comes and attaches to the lesser trochanter, which is a powerful hip flexor. Okay. So now as I'm coming through, now I'm looking at some other spaces as well as I'm going through here. So concentrating again. So this is the acetabulum still. And then we start seeing the pubic ramus. And as I'm going through more anteriorly, yeah, here we go. It's coming more anteriorly. This is the pubic symphysis. It's an important part of assessment of the, I know it's hip joint talk, but most often referral is groin pain, hip joint pain. The surgeons have some idea, but most often the clinical history we get is pain, groin pain, hip pain. So they don't know what exactly they're looking at. So it's not only the hip joint we are looking at, we have to look at everything else here. So pubic symphysis and attachments to this area are also important. So pubic symphysis, we'll go through the detailed anatomy later on as well. So that's what I look at on coronal. So we'll go to the next slide and see. Okay, so on the axial again, anatomy is important. So T1 and a fat saturated fluid sensitive sequence I have. So basically going through this very quickly, again, we're looking at the acetabulum, the ball and socket appearance. Here, I'm going to stop here. This is a very important place. So this is a normal anatomical space here, which is called the acetabular fossa, which contains fibrofatty tissue. And also you can see that there is a little indentation in the head of the femur here, which is the fovea, which gives attachment to the ligamentum teres. So this is also an important stabilizer of the hip, and it has a artery which supplies a part of the femoral head here. Most of the arterial supply of the head comes from the trochanteric region. So that's why if there are injuries to the subcapital injuries, we worry there can be avascular necrosis, and quickly it can lead to non-unions. But there's a small supply of blood coming from the foveal region through the ligamentum teres. So every time you look at the joint, it's important that you assess this region as well. Okay. And as we go through, so you look at the acetabulum, a version of the acetabulum, anteversion and retroversion. So anteversion is basically the anterior column of acetabulum is located medial to the posterior column. So if you draw a line along this margin, if you draw a line, essentially a straight line. So this anterior is more medially lying. So this is in an anteversion. And then look at the labrum. Again, we have the lesser trochanter and we have the posterior pillow of acetabulum here. So important muscles come into play here. So this is the abductors, gluteus maximus and medius. And what we have here is, this is the greater trochanter. So greater trochanter has an anterior facet, lateral and posterior facet, where the gluteus minimus, medius attaches, and gluteus maximus has more wide attachment. It goes into the iliotibial tract and lower down into linea aspera and the proximal femur. Okay, so here we have the anteriorly we have some very important muscles we have to look at here as we see. So this is the iliacus and iliopsoas muscle, and coming more anteriorly, yeah. So we start seeing the, and we can see it goes and attaches to the lesser trochanter there. And we have the tensor fascia lata, there is rectus femoris. There is also the sartorius there. So where does rectus femoris attach? Rectus femoris attaches to the anterior inferior iliac spine. Oh, I don't think so that's covered here, but it attaches here. So this is the rectus femoris origin. There's a direct head and indirect head, and that's where it attaches. So in important anatomical delineation of all the structures is very important when we start off. So, and this is the adductor muscles. So adductor muscles attached to the pubic ramus and the pubic bone. So we have the longus, brevis, and magnus in that order. Okay, and the bed is formed by pectineus here, a small muscle. So these are also from the adductors of the hip joint. So let's go to the next slide. So that's a little bit of anatomy, what we're looking at the hip joint. Let's see if it lets me progress to the next slide. Okay. Oh, it's just. Sorry about this. Okay. Now we'll come to the acetabular. We'll go through a few cases which show some acetabular pathology. So what are the normal variants that we are looking at? We know how acetabulum looks like. I've just gone through it. And then what is under coverage and what is over coverage of the acetabulum. So we looked at the the acetabular fossa, which is normal. It's medially located. It's fibrofat to tissue containing area, which does not have cartilage in it. But right in the midline, this is a normal variant where you can see this little bone remodeling and the appearance of a cartilage defect. It lies right at 12 o'clock position. This is a normal variant. It's called the supraacetabular fossa. And sometimes you also see that there's sometimes a cartilage defect like appearance, but lies slightly medial to the 12 o'clock position. And there's not much bony remodeling around it. This is a stellate crease, again, a normal variant. So we have to be mindful when we are looking at it and not call it cartilage defects, okay? So acetabular overcoverage. So it's easier to pick it up on a coronal MRI or usually we get a plain film before an MRI is asked for. So you measure the lateral central edge angle. So basically from the center of the femoral head, the angle that forms from the lateralmost border of the acetabulum is the lateral central edge angle. Greater than 40 is acetabular overcoverage. And this leads to pincer type of impingement, or in femoroacetabular impingement, labral pathology, because there's too much of impingement of the acetabulum as the femoral head rotates in it, so it can lead to labral pathology. So we have to be wary of that when we are doing an assessment of the acetabulum. So other things to look at are coxa profunda and protrusia acetabuli. These are abnormal findings. And again, this is causes acetabular overcoverage. So what is coxa profunda? Coxa, so this is the ischial line. So this straight line running across here is from the ischium to ischium is the ischial line. So if the acetabular roof rises medial to this line, this is called coxa profunda. Again, leads to acetabular overcoverage. Here, there's also an intertrochanteric fracture, which is which we are not looking at just now. Okay, so on this side, this is called protrusia acetabuli. What is protrusia acetabuli? It's basically medial projection of the acetabulum into the pelvis. So this is the acetabular roof. It is projecting medially into the pelvis and takes the femoral head more medially. So the femoral head as well is lying medial to the ischial line here. So this is just the acetabular roof lying medially. Here, both acetabular roof as well as the femoral head is lying more medially. So this is protrusia acetabuli. Again, it causes impingement. It causes advanced degenerative changes and leads to labral pathology and pain. Okay, so acetabular undercoverage. So we see most often under the setting of development dysplasia of the hip, where the acetabulum is shallow. It's not as deep. It's vertically oriented. And you can also see that sometimes there's subluxation of the femoral head out of the acetabulum or the hip joint. Okay, so other causes of acetabular undercoverage are if the acetabular roof as such is shortened. So it's not shallow, but it is not as wide. So then there is acetabular undercoverage as well. And what happens is the lateral central edge angle in those cases will be smaller than 20 degrees. So there are two types of acetabular undercoverage. One due to developmental dysplasia, where the acetabulum as such is dysplastic. The other is just because it is a bit shortened and there is lateral central edge angle is small. In those cases, again, this develops labral pathology and something called acetabular impingement, because the labrum becomes hypertrophied. It tries to compensate that there's not enough acetabulum to cover the femoral head. So it's trying to compensate this hypertrophy of the labrum, then leads to blunting sometimes, and then leads to various things like paralabral cyst, degeneration, and advanced degenerative changes more quicker than usual process. Okay, so next slide here. So we have dealt with some of the acetabular pathology. So what else now we are looking at? So here we have a coronal image which is showing that there is hyperintense signal right at the lateral edge of the acetabulum/labrum, and there is a fluid multilobulated cystic structure here on the superior aspect on the coronal view. And as I see on the sagittal view, I see that there is this multilobulated structure and the labrum appears a little hyperintense. So what is this? This is a paralabral cyst. So we have to report these on a normal non-arthrographic hip joints. If we see paralabral cyst anywhere around the acetabulum, sometimes they can be detached as well, not leading into the labrum. But if you see these, you have to closely look, make it big, look at the labrum. This is from a labral tear. So if you've not done an arthrogram, if it's not a 3T scanner, we might miss the labral pathology. So paralabral cysts are a clue that there is labral pathology, along with all the assessment of, cam morphology, pincer under coverage, over coverage, all these. Okay. Next case. So I showed you the acetabular fossa, where it is. And I showed you the ligamentum teres, which is a nice and smooth looking, it attaches to the fovea capitis here and goes into the acetabulum. And it basically arises from the transverse acetabular ligament, which basically lies on the inferior aspect of acetabulum. So ligamentum teres arises from here and goes in attached to the fovea capitis. In this area, in this case, you can see that there is edema at the fovea capitis and there is edema in the ligamentum teres. So this is a ligamentum teres strain case. So we have to closely, I think before we never used to comment. When I started my training, 10 years ago, we didn't much comment on it, but there are recent papers saying that we have to comment on ligamentum teres as well, because it's important supply, blood supply comes from them. And also it's an important stabilizer. It helps the joint to be stable. And before FAI surgeries, usually orthopedic surgeons are looking at the ligamentum teres as well. Okay, here's another case. We are going into pathologies of the femoral head, what we are looking at now. So this is a case here. This is a fluid sensitive sequence, coronal image. You can see there is intense edema. There's lots of edema in the femoral head. It's going into the neck region and into the neck region. And this is the T1. T1 complements the stir. Stir helps you pick up and quickly go through to point to where the pathology is, but to confirm and to exactly identify the etiology of a cause is T1 is very important, because it will show you the anatomy, where it's coming from, and it will sometimes, it will point towards the etiology. Here you can see that there is a very subtle but T1 hypointense line, which is running parallel to the femoral head. So this is a subchondral insufficiency fracture. So most often there is doubt, is this subchondral insufficiency fracture? Is this AVN? Yes, in some stages of AVN, we do get subchondral insufficiency fractures. But the most important thing is for AVN, there should be a geographic T2 hyperintense serpiginous line in the femoral head. So subchondral insufficiency fracture happens in the stage 3 of AVN. So it's not the first stage of AVN. You can't say this is AVN, this is subchondral insufficiency fracture, put both into differential diagnosis. Be firm. Subchondral insufficiency fracture is seen as a part of AVN staging, but it's seen in the third stage. You do see the T2 serpiginous line first, and then it progresses to subchondral collapse. At that stage, you start seeing subchondral insufficiency fracture. But this case is not AVN because we don't see the serpiginous T2 hyperintense double line sign, which is very important, published in literature for ages. Here you see just paralleling this, there is a T1 hypointense line. So this is subchondral insufficiency fracture. In what age group we see and what kind of patients we see this? It's usually normal patients 72, above 7th decade of life. But in osteomalacia patients, renal osteodystrophy, where there is already weakened bones, you can see it earlier. So lesser age groups as well. Here in UAE, because of osteomalacia, you see it in lot young patients, 30-year-olds, 40-year-olds, even males come with subchondral insufficiency fractures. And we see this very commonly in our practice. So now coming to avascular necrosis of femoral head. So this is a very good case. So where here you see abnormality, there is collapse, there is remodeling deformity, there's subchondral cystic change of the left femoral head. And on the right, there is this subchondral lucency, and also sclerosis. So this bilateral avian of femoral head, okay, bilaterally, these are affected. So if one joint is affected, if you see some kind of abnormality, you put it on your radiograph, please request an MRI. So we pick up avascular necrosis in the other joint as well, because more than 80% of cases are bilateral. So you can't just sit on it and say this is just one-sided pathology, okay? Because avascular necrosis most often is not, it can be due to trauma, likely because, if there's a femoral neck fracture and there's no blood supply, it can lead to, avascular necrosis, but it's later stages. You look at the femoral head fracture, neck fracture, you diagnose that, and then it starts developing to avian. But this is not the case. So in cases where it's de novo avian, there'll be a systemic cause like, steroid use, alcohol abuse, obesity, sickle cell. All these are systemic causes that we have to look at. Okay, let's go through some cases here. So I'm going to show you, this is a fluid sensitive sequence where you see this coronal here. I just want to show you. So here you can see there's a T2 serpiginous line in the femoral head region. This is avian. You can see similar pattern in this region, but there's intense edema here on the left femoral head neck region, but there's not much edema. There's edema there as well, but not much. So this is stage 3 of avian. There's avian bilaterally, and this is stage 3 on the left side because it's starting to develop subchondral insufficiency fractures within it. So going through it very slowly. So here we go. You can see that this is subchondral insufficiency fracture and collapse happening with a lot of edema in the femoral head neck region. So along with avian, if you see a lot of edema, that means it's going to stage 3, that there is subchondral insufficiency fracture along with avian. It's just not avian. Okay, so it's important to mention these points. Most often they use this FISCAT and alert classification of staging. It's based on plain radiographs, but you can kind of, translate into MRI as well, where you don't see any changes. You start seeing changes in stage 1, stage 3, you start seeing this collapse. Stage 2, you start seeing T2 and T1 changes, and stage 4, where there is, advanced changes of osteoarthritis developing as well.
Dr. Zishan, 1 minute, please. Yeah.
Oh, is that too much time?
Yeah, 1 minute. Yeah, I think you're overrun already. So
Ooh.
my apologies. Just
Stop.
yeah, I mean, you can just like 1 minute if you can close down.
Oh, one more minute. Okay, so very quickly, I'll go through this. This is interesting. So pubic symphysis is also an important assessment. So there's edema in the pubic symphysis, and you can see this T2 hyper intense line running deep to the pubic symphysis, and there is some changes in the adductor tendon. So this is the adductor tendon attachment. So this is pubic symphysis, case of athletic pubalgia, osteitis pubis, along with tenoperiosteal disease of the pubic symphysis. So sometimes it's overlooked and missed in the scans. So this is an important area when you're assessing the groin. Oh, there's lots for me to talk. So muscles and tendons around the hip. I will go through a couple and then we'll start winding up. So gluteal tendon assessment, I'll play it. So there is this, as I mentioned to you, attachment, you have to look at tendinosis of these tendons. I can see here, again, attachment of gluteal tendons, this calcification, look closely, there is also interstitial tearing along with calcification. This is calcific tendinitis of the gluteus medius. So rectus femoris tears are also important things that we need to assess, because chronic rectus femoris tears lead to subspine impingement, it is called. So compared to the FAI, that is femoroacetabular impingement, this also leads to impingement, but it is slightly lower down compared to the femoral head neck junction impingement that is caused by labral and cam morphology. So chronic rectus femoris damage or tear can lead to that because there's acetabular rim pathology that develops. So this is a case of rectus femoris tendinosis. Very quickly, I'm running through. So again, another case of adductor tendinosis.
I think you are running on to the next speaker's time,
okay.
So I have to
I
be a bit stern with that, please.
Yes.
Yeah.
I will stop there. So adductor tendinosis, and that's it. Can show you more cases later on if you're interested. We'll stop there.
Yep, thank you.
No, please.
Sorry about that, but I think we need to just stick to time. So the next session is about case discussion, hip cases. So I would invite Dr. Siddiq Ahmed, who is another colleague from HealthPoint, and he'll be showing us a few cases, and then Dr. Rami Mansoor may join him later on. Dr. Siddiq Ahmed.
Hi, good morning, everyone. My name is Sadiq from HealthPoint, and I've been given 10 minutes by Vijay to present a few cases. So I've got 2 cases. So very quickly, it's nearly lunchtime. I'm sure you all want to get off and have some lunch. So first slide, please. So I have nothing to declare. So the first case is a 50-year-old lady, and she's presenting with 2-month history of right hip pain. And this is the plain film radiograph of the patient. The clue is in the radiograph, but I will come back to it in a minute. So here we have got a coronal T1 of the pelvis, and on the side we've also got the PDFS of the same patient. And I'd like you to go through these images carefully. Okay, now I'd like you to log into menti.com. Take your phones, log into menti.com, and put in the code 26889385. And if you just switch off the screen, please. The code is there, 26889385. And if you could choose the diagnosis or what you're seeing, is it transient osteoporosis? Is it stress fracture? Is it AVN? Is it both stress fracture and AVN? Or is it transient osteoporosis as well as stress fracture? We'll give you about 30 seconds to answer the question. Okay, so we'll stop the voting now. So we've got about 8 responses for BNC, which is stress fracture and AVN. Yeah, that's the correct answer. Well done. Okay, so here on the coronal T1, you're seeing a small geographic area of low signal on the right side, and on the corresponding PDFS is showing extensive bone marrow edema. And as we scroll down, there's just too much edema going down the femoral neck. And when you carefully look at the T1, there's a black wiggly line which is going across the trabeculae. So this is the stress fracture. And along with that, you've got the avascular necrosis of the femoral head. Now, if you draw a line across the capsular attachment, so any fracture which is intracapsular increases the risk of having avascular necrosis. So anything above the line, you tend to get avascular necrosis, whereas below the line, you're less likely to get avascular necrosis. So continuing with the same patient, I'll show you more images. So same patient, where you've got axial T1 on the left and PDFS on the right. and just carefully look. Okay, you've already seen the AVN and the stress fracture, so there is some additional points we picked up from the axial images. So what are you seeing? Is it, can you see a gluteus minimus tear? Can you see a ligamentous teres tear? Do you see signs of FAI? Or is it both A and B or B and C? Can we switch to the mentee, please? Okay, I can scroll back. Sorry, they want to see the images again. Okay, so if you could log in on your phones to Menti and try and answer the next question, please. So the next slide, please. This is coronal images. So if you go to the next, yeah, that's the one, axial images. And if you can start voting. Great. So a few more votes coming through. So we've got 6 votes for B and C, which is ligamentum teres tear and FAI, which is the correct answer. Well done. I've lost my screen now. Yeah, can I go back to my presentation, please? Yeah. Yeah, that's the correct answer. B and C, maximum votes. So going on to my next slide. Yeah, so here you see the fovea and the attachment side of the fovea. That you see that the ligamentum teres is missing from the place. It's just an empty space. And as you scroll down, the femoral head has lost its sphericity, and you're seeing a femoral head-neck junction bony bump. And you're also seeing a intraosseous cyst at the femoral head-neck junction, also called sometimes a synovial herniation pit or Pitt's pit, which is compatible with CAM type of femoroacetabular impingement. Just scrolling down again, you see fovea. You can't see ligamentum teres anymore. Keep scrolling, you still can't see it. So it's completely gone. So diagnosis, FAI, and ligamentum teres tear on the axial images. So this is a sagittal oblique image of the same patient, and is continuing. Have a look carefully because I'm going to ask questions. I'm not going back this time. You're getting. Okay, we're back on. Okay to take over? Yeah, great. So there's something, okay, fine. So I'll just go slightly back. We'll start from there. So look carefully. So I'm going from medial to lateral. And this is a sagittal oblique PDFS of the same patient. So you might see some findings which have already been discussed, but I'd like you to concentrate on some new findings. Okay, so if you can log into Menti again on your phones and vote, please. So what are you seeing? Are you seeing a gluteus medius tear? Are you seeing an acetabular labral tear? Or are you seeing a transverse ligament tear? Or is it both A and B or both B and C? So if you go on to here, quickly, we're getting late for lunch. I'll give you about 10 seconds more. Okay, so what have we got? B and C, 8 responses, 1 response, gluteus medius tear. Okay, yeah, B and C is the correct answer. Just going on to the presentation, please. Perfect. Yeah. So that's the thick black band which is extending across the acetabular notch, and it turns it into a foramen. So that's your transverse ligament, which is seen inferior to the femoral head, and it's one of the stabilizers. And it's also the attachment site across to the ligament teres. So there is this tear of the transverse ligament. And there you're seeing posteriorly, you've got the normal labrum, which is dark, black, triangular, smooth. Whereas anteriorly, the horizontal arrow is showing you the anterior labrum, which is toned, and it's got a cleft running right through it. And as we scroll through, you're also seeing, along with the tear, there is an intraosseous cystic lesion right adjacent to the labrum. Now, some authors believe, some experts believe that this is an intraosseous extension of a paralabral cyst. So if you see that close to the labrum, suspect a labral tear. So here you can see a fluid cleft between the condyle cartilage and the labrum. The labrum is completely separated. And also you can see the other findings, which is the FAI. Okay, moving on quickly now to case 2. You also got the plain film there. The 62-year-old man is complaining of left hip pain for the last 3 days and started after a period of prolonged walking. So I'll show you some PDFS images. So you've got the coronal on the left, to my left, and the axial on the right. So you just carefully look at the images now. Oh, sorry. Too quick. So if you could log into Menti and answer this question, please. Do you see a maximal tear, medius tear, minimus tear, or is it both A and B, or is it both B and C? The next question, please. Yeah. Okay, great, brilliant. 3 of you got the right answer. Okay, yeah, that's the correct answer. Gluteus medius tear. So you can see the gluteus minimus, which is more anteriorly, and the medius is posteriorly. So minimus looks intact, it looks normal, thin band, black band of tendon tissue. Whereas posteriorly, you can see the medius, which is looking rather unhappy. It's fragmented, and as I scroll down, you see it's starting to disintegrate. Lots of edema around it. And coronal image is also very useful. On the right side, you can see the normal tendon, which is thick black band attached to the bone quite snugly. On the left side, you see it's all fragmented, lots of edema, and there's also retraction. That's again the abnormal gluteus medius tendon. And you can see the normal gluteus minimus tendon, which is, it's not completely normal, it's slightly thickened, and is attached to the anterior aspect of the greater trochanter. Okay, thank you for listening.
Thank you, Dr. Siddiq. I would invite Dr. Rami Mansoor to share a few cases as well. Thanks. Dr. Rami Mansoor.
I'm conscious of time, so I'll be very, very quick. I'm like anybody, I'm feeling hungry like everybody. So I will present few cases, just 2-3 cases. All this hip theme of what we call acute lateral hip buttock pain. So first patient is 52-year-old male, presented with a severe right buttock pain and hip pain. He's diabetic, no history of trauma, and no history of fever. And MRI showed this is massive, not massive, I mean, some soft tissue edema in the right buttock and the gluteus medius tendon. So they were worried. As you can see, he works in he's one of the generals in the military, and they were worried about whether he torn his gluteus muscle. So it was a typical VIP patient. And they thought maybe this is infection or muscle tear. But if you look carefully, yeah, you can see here there's few low signal spots there. And I'm sure when you see this in the shoulder, it's an easy diagnosis. We call it calcific bursitis or calcific tendinopathy. So it can happen in the gluteal muscles also. And you can see to prove it, either you can do plain X-ray or CT, of course, and you can see the CT will show the calcium very well. So this is just a case of acute calcific deposition. And you see it regularly. So this is another case. This is different patient presented with exactly the same presentation. Acute, sometimes they even admitted in the A&E as a query infection because there's severe pain because of the way they presented. And you can see in this patient, again, a tiny spot here of calcium and massive soft tissue edema. And this is a typical of acute deposition of calcium in the bursa and the gluteal muscle. This one is a bit trickier, but it's the same concept. You can see patient have pain. This time, everything looks, in the gluteus medius minimus, we cannot see any soft tissue abnormality or edema. But here, down here, you can see there is another spot of low signal there. You can difficultly see, and you can see it's surrounded by a small amount of soft tissue edema. Again, as you already know, that the gluteus maximus muscle have a further insertion in the behind the femur. And to confirm, you can just ask for further imaging like CT. This is the axial view. You can see thickening of the gluteus maximus tendon as it goes into the linea aspera of the femur. And again, to confirm the diagnosis, all you need is just to do CT or plain X-ray. You can see there is a little spot there. So it is something that we come across in the hip or the gluteal muscle. We more commonly we see it in the shoulder, but it can happen and also in the gluteal. It's for unknown idiopathic. We don't know why this why this calcium deposit can happen around the tendon bursa, but it do happen and presented as a diagnostic problem. The other side, other than the shoulder and the gluteal, can happen in the adductor tendons and the quadriceps. But by far, the most two common places is the shoulder and the trochanteric bursa and the gluteal muscle. The other causes of acute hip pain is something that sometimes we come across is a common side effects or complication of total hip replacement. And like in this patient, again, represented acutely with pain. And you can see here, there is a bone fragment. I don't know if you presented very well. And this is really crucial to see it on the plain X-ray, because when you do MRI for those patients, especially when it is chronic, the bone fragment will have this fatty appearance that looks very similar to the fat around it. So what basically happened, this patient has pulled his gluteus medius. And this is something, a common side effect or complication after total hip replacement because of the trochanteric bursa. The clue always here is how it's the fatty atrophy that you can see in the gluteal muscle. Same kind of presentation, but here in a different patient without total hip replacement. But you can see here the gluteus medius tendon is torn and just is not connected to the muscle, and you can see there's again fatty atrophy of the gluteus muscle. So the clues always look at the muscle and the tendon. The difficulty with this patient is the gluteus medius tendon is like the rotator cuff, have a wide insertion. So sometimes if you're scrolling through from coronal, you can see some of fibers is intact. And the gluteus medius tendon have insertion in the lateral aspect, but also have insertion here on the top of the greater trochanter. And the best, in my opinion, the best way or plane to look at it is the axial, because you can see here in this in the axial view that part of the tendon is very thinned out, and also the sagittal, because you can see here the posterior fiber is intact, but the anterior one is completely gone. So this is a high-grade partial tear of the gluteus medius tendon. Another patient with acute pain of the lateral side of the hip. And in this instance, in this patient, you can see the gluteus medius is intact, the minimus is intact, but this patient have a sprain of his tensor fasciae lata. So again, this is one of the causes of acute lateral hip pain that we can come across in some of the patient. The most, of course, the primary diagnosis of lateral hip pain that is we always see is the greater trochanter or the greater trochanter syndrome. And the reason I'm showing this case because it shows the whole spectrum of the disease. You can see in this patient, you can see the subgluteal bursa is inflamed. The trochanteric bursa is inflamed, And also you can see the tendon itself is inflamed with some erosion. So this is a true tendinopathy or a true enthesopathy of the greater, of the gluteal tendon. And this is the whole spectrum of the disease there. But sometimes you can only see the fluid in the bursa, and this is just a bursitis rather than a tendinopathy. So this is the differential diagnosis of acute lateral hip pain, and this is what you expect to see on this patient. Thank you very much.
Thank you, Dr. Rami, for showing us those excellent cases. So I think the one message that we should get across is that we should think about these gluteal tendons as the cuff of the hip. So like Dr. Rami said, you have to think about, so whatever pathologies happen in the shoulder, you can see the same one here. And yeah, decalcific tendonitis is something you think about. Once you think about it, then you can spot these things, and usually x-rays come very handy. One little thing I would like to add was I've seen one case of lateral hip pain, and the patient had a small neuroma. There was like a nerve sheath tumor. It was just sitting there. Again, just thinking there was a lesion there with the split fat sign, and it was just a nerve sheath tumor. So that can, again, just to complement what you said, but excellent cases for all of us. So the floor is open for questions, and I think I will start from the online question asked by Dr. Manar Al-Isawi, and he's asking, I think it'll be for Dr. Zishan. She's around. Yeah, she's there. Yeah, it says, I think you've touched upon it, but I think probably they want you to clarify a bit more. It says the question is how to differentiate the subchondral hypointensity line related to AVN from subchondral fracture. I think that's the question. I think how to differentiate subchondral fracture from AVN, because both can have subchondral hypointense lines.
They will not hear you online.
So as I explained to you earlier on, so subchondral insufficiency fracture is a part of AVN staging process. So first stage is there's no abnormality, just some marrow edema. Second stage, you start developing this T2 serpiginous lines. So that's the stages. And then in stage 3, you start developing the subchondral collapse or subchondral insufficiency fracture. So subchondral insufficiency fracture as such can be a part of AVN process. But just line, if it's there and it's a different age group where there's osteomalacia and renal osteodystrophy and there's no AVN, then it's subchondral insufficiency fracture standalone. So hope it clarifies.
Dr. Rami, would you like to add on that?
I mean, yes, adding to what Zishan said, clinical information or clinical data is very, very important, because avascular necrosis does not happen idiopathic. The only idiopathic avascular necrosis we know is the typical age with what we know Perthes disease. And this has happened with a specific age group, teenager, and this is the idiopathic one. But the other avascular necrosis that we see in adults is the vast majority is secondary to something, either steroids, either blood disease. So there should be a primary cause of this avascular necrosis. So I would be very, very careful, even if I'm not sure about the MRI images. If an adult to call this as a vascular necrosis, I need to know why this happened, because it's very, very unlikely to see a vascular necrosis in a healthy adult. Okay, so for me, whenever I see marrow edema, massive edema irregularity in a patient with no cause of a vascular necrosis, I would call it, of course, most likely it would be a stress fracture rather than a vascular necrosis. The only difficulty is if the patient is on steroids, because patients on steroids can have both, because they can be osteopenic and at the same time can cause a stress fracture, insufficiency fracture, and at the same time they can have a vascular necrosis. And so it could be either or actually it could be mixed, mix of both. So this is problem. This is the only time I can. It is a difficult diagnosis.
I think I will. I mean, the way, from my personal experience, I would say that I think if you see a lot of edema, if the edema is exorbitant, if this is like the cases you've shown, if the edema extends to the neck, then you think about subchondral insufficiency fracture more.
Exactly.
And usually it follows the contour of the head. It'll be parallel to the curve of the head. That's what happens in the talar dome or in the talar neck, talar head, things like that.
100% I agree. But what I'm trying to say, if someone is 60, for example, no steroids, and no primary disease, and you see this massive edema, so why would call it avascular necrosis? What is the cause of avascular necrosis? So it's more likely, even from the clinical point of view, it's more likely to be insufficiency fracture. Then, so this is always my starting point. Okay. Then I look, of course, at the MRI, and as you correctly said, always fracture is you see a tiny lesion, and marrow edema is quadruple or multiple times the size of the lesion. A vascular necrosis will not give you this massive edema because by definition, there is less blood is going to the femoral head. So we expect to see less marrow edema.
Thank you.
Thank you so much.
I have a quick question to Rami. Do you routinely measure alpha angle, and how much weightage do you give to alpha angle? For example, hip pain, alpha angle.
Can you repeat the question, please?
FAI.
FAI, yes.
Alpha angle, do you routinely measure the alpha angle?
See, alpha angle.
Alpha angle. Oh,
Alpha
sorry.
angle.
Yeah, I'm here you now. No, I don't really measure the alpha angle routinely. I look at it is a subjective, and I look at the femoral neck, and again with the 3D imaging and or the annular type of imaging, you can tell whether the waist is gone or still that. But no, I don't routinely measure the alpha angle. Just comment, I know that we are late, but comment on angles and measurement in radiology, the general radiology. It is something that helpful, definitely, but it is not always a cut-off. In my experience, for example, when I submit my research to be published, I cannot simply say, the femoral neck looks like that, or this ligament measure is swollen. I have to provide evidence, which is the measurement. And if you look at all this research, there always an overlap, and it is always a continuum, a continuum of measurement. It's not a cutoff. So that's why it's very difficult to just depend on just a single digit or a couple of digits to say this is definitely an alpha angle. So it is a continuum of measurement, is a spectrum of different changes. Okay.
Thank you. Thank you so much, Rami, for the lovely cases. And now we'll take a break for lunch, and we'll come back. I think we lost some time, but we'll come back at 1:40. Thank you, Dr. Sama Al-Bastaki, and for Dr. Amin for moderating. We'll see you back after the lunch.
No need to have camera.
Hello?
Hello. The session is about to start. Dr. Asser. Dr. Asser.
Welcome back. So I think we're going to start our third session, which is on knee, foot, and ankle imaging, chaired by Dr. Rashid Al-Sharhan from Mohammed bin Rashid University, Dubai, and Dr. Esat Memisoglu, who's a consultant radiologist in Cleveland Clinic, Abu Dhabi. And the first presenter will be my colleague, Dr. Vijay Papineni. He will be giving us a talk about MRI knee, pitfalls, and tips. So over to Dr. Vijay.
Good afternoon, everybody. Can you all hear me? Yeah, knee MRI is a huge topic. So mainly focusing on menisci, cartilage, and ligaments. If you find time, I can go through all the images. Learning object is to identify the pitfalls and learn some pearls to overcome the pitfalls. As I said, layout of this talk is going to be meniscal, going to look at some mimics or meniscal pseudo tears, and then look at types of meniscal tears and some pitfalls, articular cartilage, and mainly ligaments. I'm just focusing on ACL and PCL. First, a little bit of meniscal anatomy. You should know the differences between the medial and lateral meniscus, the basic differences. The medial meniscus is an open C-shaped meniscus. It's important to know the how they are oriented to each other. And medial meniscus, the posterior horn is much chunkier than the anterior horn. This is important when you're looking at the images. And the medial meniscus is closely attached to the capsule, and it is closely attached to the capsule. Hence, it is less mobile, and hence it is more prone to tears. Coming to the lateral meniscus, is a closed C-shaped, as you can see here. It is a more closed C-shape, and posterior horn and anterior horn are of similar size, and it is very loosely attached to the capsule, so it's more mobile and less prone to tears. So these are the basic differences that you should know when you're reporting MRI. There are several mimics or variants that can mimic pathology. There's a list of them. I will go through one by one. The first important mimic is commonly seen is an anterior transverse intermeniscal ligament, which is a band-like structure anteriorly between the two menisci. You can see it's a dark band anteriorly on the axial image. This can be sometimes misinterpreted as a tear, especially when it is closely interposed to the anterior horn or the root of the lateral meniscus. And this can be misinterpreted as a tear, especially if you're just started reporting. This should not be misinterpreted as a normal interface. The other interface that can mimic a tear or a pathology is the interface between the popliteus tendon or the lateral aspect of the lateral meniscus. I can see the popliteus tendon here, and this is the lateral meniscus, and this interface can mimic a tear. So you should be aware of that and should not call it pathology. The other interface that can also mimic a tear is a cord-like structure, which is posteriorly seen, posterior to the PCL, and it is attached to the posterior aspect of the lateral meniscus. This is called Wisberg's ligament or meniscofemoral ligament, and I can see that it's a cord-like structure posterior to the lateral meniscus, and you can see it on this sagittal image posterior to the PCL, and on the axial image also you can see it running towards the lateral meniscus. So this is a normal variant, and sometimes this interface on the sagittal image can be mistaken for a tear, and it should not be mistaken for a tear. However, when there is multi-ligament injury and a lot of force, this ligament can rip the lateral meniscus when there is enough force. And this can cause what is called as a Rysberg's rip. This diagram nicely represents the Rysberg's rip. When there are enough forces, it can extend into the lateral meniscus, extend further into the lateral meniscus. Here you can see that. Sorry, I'm getting these pop-ups. This Rysberg's ligament, which you can see it extending more laterally into the lateral meniscus, and it can be seen on here. How do you actually? I will show you a video. See, hope it works. Just scrolling through. This person has got multi-ligament and medial meniscal injury as well. You can see that the ACL is gone, PCL is gone. Going to the posterior aspect of the PCL, you can see that cord-like structure posterior to the PCL. If you follow that to the lateral meniscus, you can see that it is the Rysberg's ligament, and there is a gap between them. It's filled with fluid. Still, it extends into the lateral meniscus, and it extends more than 1.4. You can see that there is a tear of the lateral meniscus even when it is coming more laterally. So this is a Rysberg's tear. So how do you kind of differentiate? And usually there is a 1.4 centimeter from the lateral margin of the PCL. So this is the PCL on the axial images. If the Rysberg's gap between the lateral meniscus extends more than 1.4 centimeters, then you should suspect that there is extension. Another structure which is a oblique meniscofemoral ligament, which extends anterior to posterior obliquely. This is a normal anatomy. It can mimic pathology. It can, on a coronal image, it can mimic like a displaced meniscal fragment, or it can mimic a bucket handle tear, which is an example I've shown here. Is a meniscal fragment, displaced meniscal fragment from the medial meniscus. And this should not be misinterpreted. The key is to look at the axial images to identify the normal anatomy. This can be sometimes chunky, not always seen, but when it is seen, it can sometimes get confusing. Another normal variant is an anterior horn of the lateral meniscus. Usually has this high signal changes, and it has striated appearance, and this is normal appearance and should not be misinterpreted as degeneration or tear. This is because it is very closely lying to the distal attachment of the ACL, and there is interwoven fibers between these two, between the anterior attachment of the lateral meniscus and the ACL. So that's why it has that appearance that is normal. Meniscal flaunce is a normal variant. It should not be misinterpreted. It's basically a ruffled appearance of the margin of the meniscus. It can be seen now and then. And it's basically redundant medial meniscus, especially seen when knees is slightly more flexed, and should not be mistaken for a tear or pathology. In children, they have more blood supply, and the blood vessels can make it look high signal within the meniscus, and this should not be misinterpreted as a pathology. It's normal for in children to have high signal within the meniscus. It's not completely low signal. And there are, in general, there are 3 zones that you should know of: red zone, pink zone, and white zone. Because of the blood supply, the tears in the red and pink zones heal better than the white zone. So usually if the tear is more peripheral, it is better healing than a tear in the white zone. So those are the mimics. coming to the meniscal tears, as you know, MRI has high sensitivity and specificity in diagnosing. The two criteria you should the two criteria to diagnose a meniscal tear is a linear intrameniscal signal, which is exiting either superior or inferior articular surface, and then change in morphology like a truncation or absent meniscus or displaced meniscal fragment. These are the two criteria to diagnose a tear. So on the whole, if you remember that there are mainly two types of tears, vertical and horizontal. These are the basic type of tears. And there's a complex, which is a combination of vertical and horizontal. So we'll now a two-slice touch rule is a look at this study which was done. They found that when the meniscal tear is seen touching the joint surface at least two slices, the positive predictive value for a tear is significantly increases compared to when you see the meniscal tear reaching the joint surface on only one slice. This one slice, two slice rule can be either in the same plane or in a different plane. So it has to touch the joint surface in two planes, in the same plane or two different planes. So it is very good to use this rule to increase your positive predictive value. So as I said, there are two basic types of tears. Vertical tear can be a longitudinal vertical tear along the long axis of the meniscus, or a radial vertical tear, which is perpendicular to the long axis, or an oblique tear, which is oblique. So there's basic three types of vertical tears. So radial tears are the worst type of tears one could have, because they compromise the what are called as circumferential fibers, which give the integrity to the meniscus. And when they are involved in a radial tear, as you can see in this image, they significantly cause compromise of the meniscus, and this also compromises the osteochondral unit and leads to subchondral chondral loss and subchondral insufficiency fractures and early OA. So these are something we should not miss, and these can be complete or incomplete radial fractures, radial tears. Horizontal oblique tear, either it's reaching the superior articular surface, so it's self-explanatory, it is in the horizontal plane, either it is reaching the inferior surface or superior articular surface. And these are usually associated with, not always, but sometimes associated with parameniscal cyst. So when you see a parameniscal cyst and the tear does not follow a two slice touch rule, and if you see a parameniscal cyst, as in this case, this is not reaching the joint surface on two different images, but there is a parameniscal cyst. So this increases our positive predictive value or certainty with which you can say that there is underlying tear. As I said, complex tears, when it is multi-directional tear, both having vertical and longitudinal radial components, I call it a complex tear. The different signs associated with meniscal tears. So I'll go through one by one just to. So a cleft sign is basically the cleft is the tear, and it is that's how it is seen, and you can see in the diagrammatic picture as well. So a vertical cleft is seen in longitudinal radial tears and longitudinal and oblique tears. So it's always very important to review the axial images when looking at vertical tears, because it is important on the axial images, you can differentiate the types of vertical tears. Horizontal tear is basically a horizontal cleft reaching the joint surface. So as we said, it's good to follow the two slice touch rule and look for a parameniscal cyst. So marching cleft sign is basically, again, it's a radial tear. You can see that when this is seen when there is the tear is at an oblique angle to the imaging plane, especially when the tear is at the junction of the anterior horn on the body or posterior horn on the body. And you see that the tear is going to the periphery of the, in each slice it is moving to the periphery of the meniscus. So this is called marching cleft sign. And this can happen in either in a radial tear or even in a parrot beak tear. So that's why very important to review the axial images. I can see that this is a radial tear and this is a parrot beak tear, clearly identified, but both can have marching cleft sign. So remember that important to review the axial images in especially in radial, when you're looking at radial tears. Truncated meniscus sign, you can see that there's a partial radial tear of the body, and you can see that there's a part of the meniscus is missing. And there are several causes of the truncated appearance of a meniscus, as you can see here. Partial radial tear, parrot beak tear also can give the truncated appearance. Meniscal tear with migrated fragment like a bucket handle tear can also give truncated appearance, or a partial meniscectomy previous surgery can give that appearance. So as I said, whenever you are looking at a radial tear, always look at the axial images to get the proper anatomy or the orientation of the tear. Ghost meniscus sign. So when the actual imaging plane goes through the tear, complete tear, you see that there is absent meniscus. As you can see in the consecutive images here, the meniscus is seen here and meniscus is gone, and again the meniscus appears in the next slice. So this is called ghost meniscus sign. This is ghost meniscus sign is also seen in when there is a root tear, which are very important tears that we shouldn't miss. This patient had a root tear repair in the past, which failed. Now you can see that there is no meniscus here. You can see the anterior part of the meniscus, but there is no meniscus here, and you can see the root tear, a big gap in the medial attachment of the medial meniscus. And when you see the extrusion of the medial meniscus out of the joint, you should always prompt you to look that if there is a root tear or not. This is important finding that it should prompt us to look for a very occult or subtle root tear. Now, displaced meniscal signs, there's some fancy signs, apostrophe sign. So when there is for example, a parrot beak tear like this, it can displace to any of these places, and especially when it displaces to the superior meniscofemoral recess or inferior meniscofemoral recess, it can be given these fancy signs of flipped parrot beak tear. So when it is on the top in the superior meniscofemoral recess or it is called apostrophe sign. When it goes down into the meniscotibial recess, it is called the comma sign. So it is just something you should know, that these tears can flip and can be positioned anywhere. But when you see this kind of appearance, you can see this in the image, you can see that there's a truncated meniscus in both patients, and there is a meniscal fragment, displaced meniscal fragment superiorly. The same time as a parrot beak tear, a horizontal tears can also flip, and they can be lodged superiorly or inferiorly like this. And again, you can see that there's a small meniscus and there's a displaced meniscal fragment here. Again, you can see that meniscus is small and you can see a displaced meniscal fragment. So always look for, when you see that this meniscus volume is small or doesn't look right, and there's always look at these meniscofemoral or meniscotibial recesses to see if there's any displaced fragment. Bucket handle tear is a type of radial tear which is displaced fragment medially into the intercondylar area and giving a bucket handle appearance. And this is the double PCL sign, classical of bucket handle tear. You can see a big displaced fragment anteriorly as well, but this is the classical double PCL sign. Now, when you have again a parabeak tear or a flipped meniscal tear, like this diagram here, you can have what is called as a double anterior horn sign or a large meniscal sign. So basically, it's a flipped fragment lying on top of each other and giving abnormal or a huge, big meniscal. It can happen posteriorly also. The flip can happen posteriorly also. But this is something you should be aware of, that when you see this kind of appearance, you should always look on the axial images and examine it on all three planes. And this is basically a flipped meniscal fragment. So that is the few pearls about the menisci. Look at some cartilage abnormalities. Usually I like the PD FATSAT sequences. Sorry. So it gives a nice interface between the joint fluid and the surface of the cartilage, and then the good interface between the cartilage itself and the subchondral bone. And if you see the MRI, there's a grading of cartilage abnormalities, and if you see the grading, grade 1 is intersubstance change within the cartilage, and grade 2 is fibrillation of the surface of the cartilage, and grade 3 is partial thickness loss. And grade 4 is this full thickness loss or a deep fissuring reaching the subchondral bone plate, and then there is subchondral bone marrow edema as well. So this is it can be applied to any cartilage, and this is mainly described for the patellofemoral joint as grade 0, which is normal cartilage. Grade 1, you can see high signal changes here and there. There's a grade 1 change. Grade 3, you can see a subtle fissures, fibrillation of the surface, there's minor irregularity of the cartilage. And grade 4 is partial thickness loss, but there is no associated bone marrow edema. When you see associated bone marrow edema with full thickness loss, then that is grade 4. So the same thing can be applied to other cartilages as well. You can see that there is loss of thinning of the cartilage and subchondral bone marrow edema in this knee, and again in the tibia as well. So this can be classed as grade 4 cartilage abnormality. Other pitfalls that can happen is a magic angle. Magic angle not only can affect the tendons, as in this patellar tendon here, you can see that there's a unusual high signal within the patellar tendon. This is because of the angle at which the fibers are oriented to the magnetic field. Not going into the physics of it, but you see the enlarged image of the same knee. You can see that there is different, the cartilage thickness is different than the cartilage thickness here, and you can see that the cortex appears abnormally thickened or unusually thickened compared to here. This is because of magic angle effect, because of the angle of the scan, the angle at which it is oriented to the magnetic field, and this can be misinterpreted as loss of articular cartilage. So this is basically magic angle effect. At the same time, like a magic angle effect, this is also similar. You can see that the cartilage anteriorly looks thinner than the posterior cortex, and the subchondral bone looks more thicker here, and you can't really appreciate the subchondral bone here. This again is not pathological. This is a chemical shift artifact. Again, I don't want to go into the physics of it, but this is very commonly seen. Even in the SI joint also, we see this quite often. So that is the chemical shift artifact. Some age-related endochondral ossifications of the femoral condyles can mimic pathology. You see here, it looks very pathological, but this is normal variant. Again, there is fragmented appearance of the posterior aspect of the femoral condyle. Again, this is all normal appearance. You can see these appearances on the pictorial diagram as well. So these are age-related endochondral ossification of the femoral condyles, and it's a normal variant. So how do you differentiate? Usually these are posterior in location and intact overlying cartilage. This is the most important thing. Then there is no associated bone marrow edema and presence of multiple ossification centers like here. So this is a normal variant and should not be misinterpreted for pathology or osteochondral defects. Dorsal defect of the patella is another normal variant. Usually a well-defined defect in the articular side of the, you can see it is on the articular side of the superior lateral aspect of the patella, superior and lateral aspect of the patella. This is how it looks on the CT scan. And yeah, on the MRI scan, you can see that there is a punched out lesion. So this should not be misinterpreted as osteochondritis dissecans. Again, how do you differentiate? There is overlying cartilage is intact. There is no associated bone marrow edema. So this is how you differentiate the dorsal defect of the patella. This is a normal variant.
5 minutes, Dr. Vijay.
5 minutes. ACL anatomy, quickly, bit of ACL anatomy. So the ACL is has a smaller footprint proximally and a bigger footprint distally, and it has two bundles. And usually it has it fans out as it attaches distally. It's got like a fibrillar appearance, which is normal, and can have partly high signal in the lower images because of its spanning out of images. I can see those two bundles, and distally you can see the bigger foot plate. So it's very important to look at ACL in all three planes, not to miss the pathology. Just showing you some direct signs of ACL injury. This is a normal ACL. Here you can see the complete rupture of the ACL discontinuity, and you can see that the normal ACL attachment is gone here on the axial. And this is a replacement of the ACL. This is like a hazy appearance, and there is loss of normal orientation. And this is like a hematoma within the ACL rupture. And this is another chronic case where there is no visualized ACL at all, completely gone. So these are the direct signs of ACL rupture that you can see. However, there are several indirect signs one should be aware of. So when ACL happens, ACL injury happens, it's usually the pivot shift mechanism of injury, and there is valgus forces, and medial compartment, lateral compartment contusions happen when the twisting injury happens. And this is the commonest areas, the lateral femoral condyle, there's bone marrow edema, and posterior aspect of the tibia, there is bone marrow edema. And again, sometimes the medial tibial condyle also can have enough force, and there is a posterior translation. It can impact. This is basically a post contusional injury, and that is how they depicting the post bone marrow edema. And sometimes when the impaction injury happens, there is what is called as a lateral femoral notch sign, or a sulcus terminalis, where there is a dent, which can be also seen on the plain film, and there is a little bit of associated edema. So this is something we should not miss, lateral femoral notch, which is again because of the impaction. So indirect sign, again, the angle between the ACL and tibial plateau should be usually 45 degrees. And when it is, when there is loss of normal orientation, it decreases. So you can measure this angle, but it is quite obvious here. And other indirect sign is a question mark or a buckled PCL sign. Whenever you see that, ACL is probably you should suspect ruptured ACL. So this is another sign, and this is anterior displacement of the tibia more than 7 millimeters. So when you measure the posterior, when you draw a perpendicular line posterior to the femoral condyle and posterior to the lateral tibial condyle, this should not be more than 7 millimeters. This is another indirect sign that this is probably not very reliable, but when you see usually the lateral collateral ligament is oblique, it extends posteriorly, and sometimes when you see that it is on the coronal image, it is seen on one slice, it can be an indirect sign of ACL injury. So when you see a fracture, which is called Sigon's fracture, you should always suspect other injuries, especially ACL injury. And you can see that there's a small avulsion fragment here. This avulsion fragment, this is important to mention size of the avulsion fragment. Sometimes it may be feasible to repair it. And Sigon's fracture is basically a avulsion fracture from the iliotibial band. And I'll just show you an example. This is multi-ligamentous injury, and you can see that ACL is completely gone, PCL is ruptured, and there is avulsion fracture from the anterior femoral condyle, and then you go laterally, there is fracture from the avulsion fracture from the lateral aspect of the tibia. So this is a Sigon fracture. Although it's a very small fracture, there is a lot of associated pathology. So you should immediately get a MRI scan. Other fracture that can be associated with ACL injury is arcade fracture. This avulsion injury from the lateral collateral ligament or the biceps femoris avulsion fracture. It was also associated with ACL injuries. O'Donoghue's unhappy triad is a fancy name when there is, when you see that this patient is a footballer and he had been tackled from the side, and you can see there's bone marrow edema, there's avulsion, complete rupture of the medial collateral ligament, and there's complete ACL tear. And then he has a meniscal injury as well. So when you see these three together, it is called O'Donoghue's unhappy triad. So these are all associations. Partial tear is a diagnostic challenge. Sometimes it is tricky. When you see thickening and a lot of high signal, you worry about partial tear. Mucoid degeneration is the fibers still look intact, but it looks expanded. There is diffuse high tissue signal giving like a salary stick appearance. So that is a mucoid degeneration. Another example showing mucoid degeneration, there's cystic changes within the ACL, and there is a ganglion cyst as well outside. So this is a mucoid degeneration of the example of mucoid degeneration. Almost there. PCL, again, PCL also has two bundles. It's usually uniformly black, unlike the ACL. And it's a few examples of complete tear of the ACL. PCL, you can see that there is complete rupture and it's hanging in the air here as well. And usually PCL is associated with other ligamentous injuries like ACL and multi-ligament injuries, because it is a stronger ligament and needs a lot of force. When you see when there's avulsion fragment at the posteriorly at a attachment of the PCL, you should always measure it, and it is very useful for the orthopods when they're planning to fix it. either on the CT or plain film. This example of isolated PCL tear, usually PCL tears are associated. This is an example where ACL is intact, but PCL is torn. This is mucoid degeneration. I'm aware of the time. Take home message, know your anatomy, very important. Know the normal variants and mimics. Always examine the menisci and ligaments in all three planes. Follow the two-slice touch rule to improve your diagnostic positive predictive value or diagnostic accuracy of meniscal tears. Always review axial images. If you see a radial tear or if there's suspicion of a radial tear, always review the axial images. Look for direct and indirect signs of ligament injury. Always review the plain films if they're available. Sometimes fractures like second are very subtle and sometimes can be missed on an MRI scan. So always review the plain films. Review the previous imaging. Previous imaging is the radiologist's best friend. They always come handy. And if you're not sure, talk to orthopod, pick up the clinical notes and look through it. Always there are some clues. And avoid search of satisfaction of search. That's my talk.
Thank you, BJ. Thank you, Dr. BJ. Now I would like to invite Dr. Abdulrafi Khan, who's a consultant musculoskeletal radiologist here at Sheikh Shahbout Medical City, to take the podium and share some MSK knee cases.
Thank you very much for giving me this opportunity. Thank you, Dr. Vijay, for your detailed talk. That was very informative. I've got a couple of long cases. I've got some meniscal tear injuries. I'll skip the meniscal tear injuries. Dr. Vijay nicely covered that aspect of the talk. So just moving on quickly now. So first case, I'm just going to take you through the journey of two patients, hopefully both of them, but at least one of them. So Dr. Asad can kind of let me know if I'm running over. So this is a 20-year-old male, and he was seen in orthopedic and rheumatology clinic. He had intermittent left knee pain and swelling for 15 years, which means he's been symptomatic since the age of about 5 years, so for a very long time. So he's not had any trauma, and he's had multiple presentation in wheelchair, which means someone who's very debilitated for a person of this age. So coming into wheelchair a number of times, seen in various places, probably not had a proper follow-up, and was given, pain relief and sent home and with some advice, but did not manage to follow up this patient into kind of tertiary care setting. There was some history of other small joint pain, so there was a question about whether he could have some rheumatological disorder. But there was no other features, no systemic features of any other disease causing joint pathology, no rashes, bleeding tendency, or bowel disorders, and negative family history for any rheumatological disorder. Examination in the clinic, when he was seen in our hospital in the rheumatology and the orthopedic clinic, it was very painful for him to bear weight. The knee was very tender, there was an effusion there, and there was limited restricted movement. So just think about, we're talking about 20-year-old chap who since the age of 5, he's been very debilitated. And rest of the joints were okay, just that one isolated knee, that was his main issue. Did a baseline workup, which involved a rheumatology screen, which was negative. CRP was normal, so no inflammation apparently. Biochemistry normal, uric acid normal. Did screening for chronic infections, again that came out negative. HLA-B27, again that was negative as well. So coming to imaging, the most interesting bit. So he had a plain radiograph as we normally do when we start off with any patient. We can see over here. Let me see if I can get my pointer working. Yeah. So we can see he's got some fullness in the suprapatellar fossa. So he's got an effusion over there. So when you get an effusion in a young chap, debilitated long term, you're thinking about some maybe joint-based pathology. So we straight away jumped onto an MRI scan, which kind of makes sense in this scenario, that we want to get to the bottom of what's happening with this patient. So MRI scan was very abnormal, very revealing. So he's got lots of, so this is a PD fat cell. It has strands of thickened high signal soft tissue. And again, if we look on the T1 sequence, he's got, all that is hypointense. There are a bit of intervening areas of fat. Again, we can see a bit of intervening areas of fat which have been expressed over here. Again, the axial kind of shows the same thing. So very abnormal MRI scan, which was mentioned to the patient as well, that your MRI scan is very abnormal, needs appropriate workup. The first thing we did was to see how much of that is fluid. If there is fluid, maybe we can get some fluid off, send that for sampling. The ultrasound showed that there was not fluid. It was all thickened hypoechoic synovium. And if you kind of have a look, it does have maybe possibly some cystic areas. And if you think about someone who's very debilitated, who's got such thickened synovium, you would wonder about whether they would have synovitis. But it wasn't very inflamed. We did Doppler. So Doppler showed that there was not much activity. And based on the imaging we've got so far, so the thought was, could it be chronic inflammation? Other was, is he having recurrent, hemorrhages into the joint, which is causing chronic synovial hypertrophy? But we did not see particularly hemocysteine deposition on the MRI scan. Could it be a tumor? Could it be a benign tumor? Or was it something like a lipoma, arborescens? Again, a benign pathology. And the other thought was, could it be chronic indolent infection, which has just kind of lingered on and on? Although we have a negative, screening for common chronic infections. Sinister pathology, that seemed unlikely based on the fact that it's almost a 15+ year history. So it's unlikely to be something malignant. Moving on. So the management plan at this stage. So we're thinking about chronic synovitis of uncertain etiology. And the plan was to get him to oncology orthopedic center. So we can biopsy this synovium and get to the bottom of what's happening with the patient. This was what was recommended to the patient. However, when you kind of talk about, invasive procedures to patients, sometimes they get put off and they want to get second opinions, or they don't come back to you. So this is what happened to this patient as well. It probably happened to him a number of times. You can imagine a 15-year history presenting at various places. He was lost to follow up. When he did present, ultimately, he said he had visited a number of hospitals and he had multiple opinions, and they were not getting to the bottom of what's happening. Family was thinking maybe it's evil eye. It's nothing physical. It's just evil eye. So let's just kind of, sit it out. Then he finally presented back to our institution after 2 years with a fresh MRI scan. Now, that imaging of that, again, we see that, very abnormal synovium. Maybe it's grown a bit compared to the previous scan. So it is again high T2 signal, fronts of thickened soft tissue, and low T1 signal, again, fronts of thickened soft tissue with intervening fat. Just looking at the axial carefully. So axial does have something revealing on that. So you've got T1, T2, and PD fat set. So if you look carefully, I see straight lines over here, straight line. Come over here again, there are straight lines over here. So that's fluid level. So something very abnormal which has fluid levels. So what should we do next? The patient had the MRI scan, then we said, let's just give him contrast, get him back. So it was not done in, this was, the patient came in with the CD, it was done in a different hospital outside. And I would give them credit for this actually, post-contrast scan. So if you look over here, so this is pre-contrast, this is post-contrast. So very heterogeneous enhancement of whatever that soft tissue thickening is. And they said, okay, that looks very abnormal, patchy abnormal enhancement. Let's just wait a bit and do another scan. It continued to fill in. So more and more filling in. Now, if you think about, if I told you this was a liver MRI scan, normal, fills in, and continues to fill in, you would say, yeah, it's a hemangioma. So yes, so this was the thought that was given on the report, and we agreed with that. This is a synovial hemangioma. So this was the provisional diagnosis for this patient. And we did kind of ultimately get to the bottom of it. And management plan, again, it was discussed with the patient. We do need a biopsy just to prove that it is truly a synovial hemangioma. Tumor board discussion, we thought maybe embolize that. So again, it was done in our local oncology center. So embolize it and then do a curettage. So that was the plan discussed with the patient. This time they came in, they wanted to get this thing sorted out. And one of my esteemed colleagues who's over here as well, he happened to do this procedure. So he did embolize the main feeders of this hemangioma. So this is the angio runoff. And if you do delayed imaging, it kind of fills in this, little bits of areas of contrast over here. It's all filling in. Very nicely embolized. All the feeders were embolized, or as many as we could embolize. And again, run after that showed that most of that filling in of that hemangioma had stopped. There were very little. Then he went into curettage, surgical curettage, and then again presented after a few months for clinic review, and we had a repeat MRI scan. We could see that hemangioma was totally gone. It's been curated out, and there is some post-surgical changes. So, but most of its, primary pathology that has been dealt with. So, common pathology, hemangioma, but unusual place. So that was the thing which kind of gave it away. And again, if you have skin hemangiomas, they're very evident. You see them. They kind of, tell you themselves that I'm a hemangioma, deal with me. So this was hidden in the joint. So it took us a long time to get to the bottom of it. It did not help that the patient was not very compliant. So imaging feature just kind of to hammer this point in that, if you see this, how do you say it is a hemangioma on MRI scan, even without post-contrast? They would have phlebolyths, not always, but they can have phlebolyths, which would be, maybe low signal areas, maybe something there, maybe bits of over there. Then they would have thick hypointense septi. So this is a hypointense septum. Again, thick hypointense septum over here and a few over there. And the main thing, I look for are fluid levels. So fluid levels in hemangiomas, they're there. They would be there in, skin hemangiomas or soft tissue hemangiomas elsewhere. Not always, but they can be there due to recurrent hemorrhages. They would have these fluid levels. And again, they would have that heterogeneous enhancement and they would continue to fill in. So that is the classical imaging features of a hemangioma. The differential that we thought about initially was something called a lipoma arborescens. So that is fatty infiltration of the synovium with fronds of thickened synovium. We saw that ultrasound which had very hypoechoic synovium, but this, if you look at lipoma arborescens, this is fronds with hyperechoic synovium, which is fat. Fat is always hyperechoic on ultrasound scan. And then they've got fluid over there. And again, on MRI scan, you would see these on T1 weighted imaging, lots of fat in the synovium. Okay. Other differential to consider would have been maybe, recurrent hemorrhages, like someone who's got a bleeding diathesis, like hemophilia or something. They would have, this is probably a 25-year-old, but the knee looks like that of a 90-year-old. They've had recurrent hemorrhages, they've got hemocyte deposition, they've got secondary osteoarthritis. So these are maybe some of the differentials to consider in addition to maybe PVNS as well. So this was one case. So I'll just quickly go through this second one, then we'll stop after that. So this is a 53-year-old female who presented after had a road traffic accident and then was taken to her local facility, then later on transferred to our hospital. So this is the scanogram. So when I start to look at trauma scans, one of my trauma surgeons, he said, when I sit in the control room, I look at the scanogram. I said, we normally skip that, we just go to the CT imaging. Then I start to look at the scanograms, I found it very useful. Number of pathologies, it would kind of give you an overall view, pneumothoraces, surgical emphysema, and long limb fractures or long limb dislocations. You would miss it unless you look at the scanogram. So if you quickly eyeball this, is there something? Then if you have a closer look, yes, brilliant, whoever said that. So there's a dislocated knee on the right side. Okay, so what we picked up one pathology just on the scanogram, which is a significant emergent pathology. So they did have a CT scan of that knee as well, which nicely demonstrated on the 3D imaging that there is dislocation. Now, if I move forward, okay, so you try to do a closed reduction always, and it's an emergent thing. It's an emergency. You want to reduce it. So it was nicely reduced in the local facility, and then they did the right thing. Whenever you get a knee dislocation, worried about two things: is there a vascular injury or is there a nerve injury? Vascular injury is the one which I'm most worried about in the acute setting. is there a vascular injury or not? I need to act on it now if there's a vascular injury. So the patient had a CT angiogram, and if we look at the artery nicely lights up. There's contrast flowing in it. But if I have a careful look, what is this? This doesn't look normal. This is not an artery, but what is this? This is a vein. And if I look at the reconstructions, there's a filling defect in the popliteal vein. So normally you get arterial injury, but sometimes you can get a venous injury. So this is a thrombus in the popliteal vein. Now you think, okay, fine. So thrombus, so how do I deal with it? Anticoagulate. So that would be the thing we do whenever we see a thrombus in the vein. However, it's a patient who's had a trauma. So it's not one injury, they've got multiple injuries. They've got a skull fracture, they've got hemorrhages, and a couple of days down the line, they've got edema developing, midline shift, and then they end up having a craniectomy because there's so much mass effect. So there's craniectomy. So we've got that thrombus, but we got so much other things happening. So how do we deal with it? We put an IVC filter. So IVC filter was put for this patient. And at some stage, the patient, because of that many intracranial injuries, they had to come down for MRI scan of the brain. We said, okay, let's do MRI scan of the knee as well at the same time, see what's happening with the knee. Kind of the intracranial injuries obviously took priority, but we are still looking at the knee as well, what we could do for that. So this, knee dislocation is not like a simple shoulder dislocation. You put it back, you send the patient home, and they come back to the clinic and they look at it. It's unstable or not, what to do for that. So knee dislocation, they have significant vascular consequences, potential vascular consequences. They can have significant neurological consequences, and they can have multi-ligamentous injuries. So the knee can become very, very unstable. So I know it's not, dynamic, so I can't demonstrate that very well, but they've got ACL and PCL is gone over there. And if you look over here, there's no MCL, it's all gone. And all that joint fluid is, leaked out, seeped out, it's in the subcutaneous soft tissues. If I look at the lateral collateral ligament, it's avulsed off, come off from the femoral condyle. If I look at the medial patellofemoral retinaculum, it's totally gone. There's nothing there. All the fluid from the joint is getting out. The lateral head of the gastrocnemius, that was gone as well. Can't demonstrate that very well on this static image. Popliteus was gone. Patella was fractured. So the knee is a mess. So multi-ligamentous injury. So in the acute setting, so what you could do, you're dealing with other things, you kind of stabilize that. So it was initially external fixation, so the knee was fixed just to stabilize, to prevent any further vascular or nerve injury and to maintain stability over there. And patients slowly after months and months got better, and they had their cranioplasty, and their external fixation was taken out. They were put in a splint, and then again they were transferred for neuroengineering rehabilitation. You do deal with the ligament injuries. You don't kind of ignore that. And they were planned for, after they've had the rehabilitation, they can have the ligament reconstruction later on. Of course, it does vary how you plan the management based on, what kind of injuries they've had. If it is isolated knee dislocation with multi-ligament injury, it's a previously young active gentleman or a lady, then you would want to, get them through the acute phase, and within 3 weeks, preferably, you operate and do a multi-ligament reconstruction. If it is someone who's elderly, then you kind of not go down the route of reconstruction, but you just stabilize them and manage them conservatively. So I'm just going to stop there for the sake of time. I'm not going to go into details of.
Yeah, 1 minute.
Yes, no, I'll just skip that. Just meniscal teeth. I know Dr. Vijay nicely covered everything. So I'm going to skip a lot of this, and I'm just going to show you something which I kind of struggled with myself. So, but if I can get to it. Yes. Root tears. Root tears can be tricky. So if you look at the meniscus on this side, you can follow it, and maybe if I scroll through it, I could see it's going down. So the lateral meniscus is attaching its root over there. But if I look at the medial meniscus, it is very blunted, and there is a bit of fluid over there. And if I look on the sagittal, I'm exactly at this level where the tear is. There is nothing there. I should have a bit of the root coming over here. There's nothing there. And if I look at the axial, then there's a cleft over there. That's a posterior root tear of the medial meniscus. Okay. And one kind of take point home from here, we've struggled every now and then with radial tears or root tears. And we found that if you do axial thin slices, they're very useful. So PD, axial fat sat, they tend to pick up they can characterize the radial tears and the root tears as well very nicely. So it would be useful to add to your practice. Instead of doing thick slice, do some thin slice PD fat sat. It gives you a lot of useful information. I'm just going to stop that. So thank you very much.
Okay, so our next lecturer is Dr. Asir Fargal, who is going to talk about the foot and ankle MRI, its pitfalls and tips. Dr. Fargal.
Thank you, Mr. Chairman. Good afternoon, everyone. I'm sure the best time to have a lecture is after lunch when everybody wants to sleep. So I'll try to keep it entertaining as much as I can. So I was given the talk of foot and ankle MRI by my colleague Vijay. Thank you, Vijay, for that. So it's a long talk, really, two subjects in 20 minutes. It's almost impossible to cover everything. So I'm just gonna talk only about ankle and hind foot, not the entire foot, just to be clear. So the objective of this talk, I'm just going to go through a systematic review of the ankle and the hind foot MRI. This is the way I do it. This is not, what you should do it, but just the way I tend to look at MRI ankles. I'm going to review some important ligamentous anatomy and some tips in detecting various ligamentous and tendon injuries. And then we're going to go through some case examples. So let's go first. How do I review MRI ankle? I tend to go with the ankle in a methodical way, so then I don't forget anything. So I tend to start from the inside of the joint, going outside. So start first in the bone contours and the bone marrow. And when I finish that, I look at the overlying articular cartilage, either in the talar dome or the subtalar joint. Then once I finish that, I look at the joint effusion, so the fluid around within the joint. Then I look outside in the ligaments, then outside even further at the tendons, and then I look at the two important structures, which is the sinus tarsi and the plantar fascia. The most common used sequences in the ankle are the sagittal T1 and T2 fat sat, and these are useful for bone marrow, joint fluid. You can assess the talar dome. You can assess also the subtalar joints, the Achilles tendon posteriorly, and then the sinus tarsi and also the plantar fascia. The coronal images, the coronal PD and PD fat sat, again, you can look at the talar dome and you look at the marrow signal. It also gives you access to the medial ligaments, which is the deltoid ligaments. You can also look at the tendons of the arch of the foot. You can again review here the plantar fascia, the three components of the plantar fascia. And then you can also troubleshoot the ligaments that you've picked up on the sagittal view. The axial view, again, it's useful for marrow edema, T1 and T2 fat sat. And then you start to see the anterior and posterior tibiofibular ligaments. And then as you go distally, you can start seeing the lateral ankle ligaments. You can also see the deltoid and spring ligaments on the axial view. And then you can start seeing the various tendons, the anterior group, posterior group, medial and lateral group. So let's have some quick review of the ligamentous anatomy. So ankle is one of the joints that has a lot of ligaments, unfortunately, for us. So let's start from the lateral group. The lateral group starts first with the interosseous membrane. Now, the interosseous membrane is quite difficult to see in MRI. You only see it when there's a problem with it. So when there's an edema or something wrong with it, you start to see some
problem with the interosseous membrane. As you come down, you see the anterior and posterior tibiofibular ligaments. You come down further, you have the anterior talofibular ligament and posterior talofibular ligament, and then finally the calcaneofibular ligament. So let's have a look at some of these. So here is an axial view, and you can see the anterior inferior tibiofibular ligament. And this ligament is not a horizontal ligament. It's actually quite oblique ligament. And as you can see here in the coronal view, it's an oblique ligament. So you have to really scroll the images up and down in order to see the entire ligament in its entirety. Similarly, the posterior inferior tibiofibular ligament, exactly in the same orientation, oblique. So you have to really have a look in both planes to be sure that there's no problem with it. As you move down, one of the most important ligaments in the ankle is the ATFL, or the anterior talofibular ligament. And here it is. You can see it in the axial view. It should be thin structure, not thick, doesn't have any fluid, doesn't have any alteration of signal, and is one of the most common ligaments to get injured in an inversion injury. This is the posterior talofibular ligament, and it has a slightly different orientation or slightly different shape. It's a fan-shaped like ligament, so you wouldn't expect to see a band, but it's slightly broadened ligament. And here it is on the coronal view. The third ligament is, as you go down, is the calcaneofibular ligament. Again, one of the commonest ligaments that get injured on the inversion injury. As you can see, it starts from the lateral part of the calcaneum. As you go up, it goes medial to the fibula, to the peroneus longus and brevis tendon, and then it will go and insert into the fibula. This is an axial view. This is the origin of it. And as it goes up, as you can see, it's more medial to the peroneus longus and brevis tendons. What about the medial group? So medial group is mainly the deltoid ligament with its two components, the superficial and the deep components. The superficial component has four components, starting posteriorly the tibiocalcaneal ligament, then the tibiospring ligament, and then anteriorly the tibulonavicular ligament. And then the deep component has anterior and posterior group. So let's have a look at the deep component first. The deep component acts like a sheet. It's quite it's a strong ligament, and it has like a fan-shaped appearance, as you can see it here. This is the posterior tibiotalar ligament on the coronal view. And on the axial view, you can see that's the anterior component. It's quite thin when you compare it to the posterior group. So that's the anterior group, and this is the posterior tibiotalar ligament. What about the superficial group? So the superficial group, as we said, has three different components. So starting posteriorly, you can see here, this is the tibiocalcaneal ligament. And the coronal view, as you move forward a little bit, you get the tibiospring ligament, which is a ligament arising from the tibia, and it will insert into the spring ligament. And as you move forward, again, this is the tibiospring. Then you start to see the tibulonavicular ligament. Again, here and here, and it will insert into the navicular bone more anteriorly. This is it. Again, the tibionavicular ligament anteriorly starts from the tibia, and it slides down to insert into the navicular bone. The next important ligament is the spring ligament. The spring ligament is a complex structure which is composed of thick band of tissue connecting the sustentaculum tali to the plantar aspect of the navicular bone. And it acts as a sling. It's basically a sling underneath the talus bone, and it stabilizes the medial part, the medial arch of the foot, and supports the talar head. You can see it's three components. Superior medial band, the medial plantar oblique band, and the inferior plantar longitudinal band. Now, the tibiospring ligament is not part of the spring ligament. It is actually part of the superficial component, as we discussed, of the deltoid ligament. Some people mention it here when they describe the spring ligament. So let's have a look at the superior medial band. Here it is. This is an axial view, more distally. It's the most medial part. And as you go further down, you can see it slides down here to insert into the navicular bone. On the coronal image, you can see here, that is the superior medial band of the spring ligament. Now, the top end here, this is the tibial spring ligament. Again, part of the superficial band of the deltoid ligament. The second ligament from the second component of the spring ligament is the medial plantar oblique band. And again, a little bit more lateral to the superior medial band. You can see it here in the axial view. Again, this is in a different patient. More laterally, you have the inferior plantar longitudinal ligament. You can see it here in the axial view, and then here on the sagittal view. That's the tibial spring ligament, as you said here, and here down here, if you scroll down, you're going to see the superior medial band of the spring ligament. Okay, so let's have a look at some of the tendons. So tendons, I tend to group them anteriorly, posteriorly, medial, and lateral groups. The anterior group, not too many mnemonics. The mnemonic I used to is Tom, Harry, and Dick. So tibialis anterior tendon is the most medial one. And then extensor hallucis longus tendon. And then you have the neurovascular bundle, and then the extensor digitorum longus tendon. The medial group, the other way around. So Tom, Dick, and Harry. So tibialis posterior tendon, very closely related to the posterior part of the tibia, and then more as you move laterally, flexor digitorum longus tendon, then the neurovascular bundle, the posterior tibial nerve and vessels, and then the flexor hallucis longus tendon. This is the medial group, if you wish. The lateral group composes of two tendons, the peroneus longus and brevis. So peroneus longus is the lateral one, and peroneus brevis closely related to the bone. So easy way to remember the brevis and bone close to each other. And then posteriorly is the Achilles tendon. And Achilles tendon should be a thin band, should be a smiling tendon to you. If it is not, if it is biconvex, then there's a problem with the tendon. So next is the sinus tarsi. It's a potential space between the talus and the calcaneus, and it has two important ligaments, which is the cervical ligament and the interosseous talocalcaneal ligament. It has also some of the insertion of the inferior extensor retinaculum, which has three bands. So you get the medial band, intermediate band, and the lateral bands within the sinus tarsi. It's a fatty containing structure. So that's how we recognize is it normal or abnormal from the MRI. So let's have a look at the structures. The first thing is the cervical ligament. Here it is on the sagittal view, and on the coronal view, and on the axial view. As you move a little bit more medial, you can see, and posteriorly, you can see the interosseous talocalcaneal ligament. Here is on the coronal view, this is on the axial view, and here is on the sagittal view. And if you scroll, you can see, you start first seeing the interosseous talocalcaneal ligament. This is the medial bundle of the inferior extensor retinaculum. As you move forward, you get the medial bundle, and then here is the beginning of the cervical ligament. Here it is, and then this is the intermediate band of the extensor retinaculum, and as you go laterally, this is the lateral band of the extensor retinaculum. So let's move to the forefoot. So the forefoot that I'm going to discuss is the Shupper joint complex, which has two joints, two main components, the calcaneocuboid joint, which is the lateral column, and the talonavicular joint, which is the medial column. So this, the function of this joint complex, it works in conjunction with the subtalar joint to invert and evert the foot. It also provides a pivot motion of the hind foot while the foot remains stationary. It also stabilizes the midfoot during the push-off phase of the gait cycle. Here it is. So the talus articulates with the navicular, and the calcaneum articulates with the cuboid, and this is how it looks like on the DP view. There are 5 groups of important ligaments that connects these joints together. The first one is the talonavicular ligaments. This one on the top here stabilizes the joint, which is arising from the dorsal aspect of the talar neck to the dorsal aspect of the navicular bone. The second ligament is a bifurcate ligament, which has two components. Again, it starts from the lateral process of the calcaneum, and it has two components, one that inserts into the navicular bone, the other one that goes into the cuboid bone. That's why it's called the bifurcate ligament. Then the third ligament is the dorsal calcaneocuboid ligament. Then we have two groups of ligaments, the short plantar ligaments and then the long plantar ligaments. The short plantar arises from the anterior calcaneal tubercle to the posterior plantar surface of the cuboid. The long plantar ligaments have a slightly longer insertion, which they go into the second to the fifth metatarsal bases. This is these ligaments on the MRI. So this is the calcaneocuboid ligament. You can see it here. This is the extensor digitorum brevis tendon. This one is the long plantar ligament. And this one is the short plantar ligament. Let's have a look at the bifurcate ligament. Here it is. This is arising from the lateral calcaneal process, and it has two components, one into the navicular bone and the other band into the cuboid. Here it is in another patient, has two main components here. So let's review some tips in detecting various ligamentous injuries in the hindfoot and the ankle. One of the commonest tips is to pick up the bone marrow edema pattern. And there is certain bone marrow edema patterns that will guide you and help you to pick up these ligamentous injury. So let's have a look. The first pattern is if you get a bone marrow edema of the lateral aspect of the talar head, the plantar aspect of the talar head, you would expect the tear to be to also involve the bifurcate ligament, which was here. It will also involve the calcaneocuboid ligament and the spring ligament. So always when you get edema in that location, go and search for these ligaments. The second location, if you have edema at the dorsal part of the talar head, look at the calcaneonavicular ligament. There must be a problem there. The third location, if there is edema at the lateral anterior calcaneal process, look at the calcaneocuboid ligament or the bifurcate ligament. There will be some abnormality in these ligaments. And finally, if you have edema at the medial part of the calcaneocuboid joint, look at the short plantar ligaments. There will be some problem in there. So let's have some examples. Here is a patient, a 64 years old female. She fell, she had an inversion injury. This is the X-ray. You can see there's a small avulsion fracture here at the top part, at the anterior part of the talus and the navicular bone. And when you look at the MRI, you can see the avulsed talonavicular ligament. Same patient, if you look closely, you can see the edema here at the plantar aspect of the talus. So then you go and look at the calcaneocuboid ligament. You can see there's a torn ligament there. Next case, 32 years old male with an inversion injury. And here it is, that's the MRI. You can see there's a bit of bone marrow edema here at the calcaneal process with a non-displaced fracture. There's also some edema at the plantar talar head. So when we have these two components, you go and look at the attachments of these ligaments. So one of them is the bifurcate ligament. You can see there is a tear of the lateral calcaneocuboid ligament, which is part of the bifurcate ligament. And again, here is a tear of the calcaneocuboid ligament. Third case, 77 years old female with insidious onset of pain for 1 week. And you can see there is a bit of the plantar subluxation of the talus with some tearing of the calcaneonavicular ligament. You can see there's a bit of bone marrow edema here in the talar head as well. Again, when you look laterally, you'll see there's a tear of the calcaneocuboid ligament. Same patient as well has some edema also at the talar head. When you look closely, you'll see the torn spring ligament. That's the superior medial band or bundle of the spring ligament. This is on the coronal view, and here it is on the axial view. Case number 4, 34 years old female with a history of twisting injury. So when you look at the X-ray, you can see there's a small fragment here. The MRI shows exactly that area, which is the attachment of the calcaneocuboid ligament, again, a valsed ligament with a small avulsion fraction. Same patient had a bit of edema at the cuboid bone, which is the medial aspect of the calcaneocuboid joint. As you remember, we discussed that. So when you see this, look at the short plantar ligament, and this is torn short plantar ligament.
Dr. 1 minute. Yeah.
Same patient again with the edema at the dorsal part of the cuboid bone. Again, the plantar part of the talus, you can see the torn medial calcaneocuboid ligament, again, part of the bifurcate ligament. Same patient. Again, here the edema at a different location. This is the insertion of the ATFL, and again, torn ATFL. On the medial aspect, there's some edema in the medial malleolus. Here you can see the abnormal signal within the deltoid ligament. So always the bone marrow edema will guide you where to look for the ligaments. If you remember the anatomy where the ligaments are attached, you will be able to pick up the abnormality. With this, I'll thank you very much. Hopefully I wouldn't have gone so much.
Next up, we'll have case examples of foot and ankle pathology by Dr. Vijay and Dr. Wissam.
Good afternoon, everybody. Okay, I have three interesting cases. If I have time, I will show the third one as well. Sorry, it's the wrong one. Vijay. Okay, the first case is a 73-year-old gentleman from Saudi Arabia. He's got a progressively increasing painless diffuse foot swelling involving the right foot and to some extent the ankle. He had it for a long time, almost 15 years. So on examination, he had multiple discharging sinuses were seen. His inflammatory markers were elevated. And you can underline the painless diffuse swelling. So it's a chronic thing going on for ages. So when he had a plain film, it looks like there's multiple lytic lesions, punched out lytic lesions throughout the foot. You can see that the third metacarpal is completely resolved almost. And there is a fusion of the bones. There's a bit of periosteal reaction you can see. And There is sclerosis as well associated with this, which is telling us that this is a long-standing abnormality. As a T2 fat site, sagittal and axial, you can see there's a lot of bone marrow edema, and there are focal lesions with a central low signal with a surrounding high signal. These are multiple of these involving several bones. You can see them here as well. This is a pre and post contrast images showing significant soft tissue and bone marrow enhancement. You can see several focal lesions that we have seen like before. Just for what do you think is the likely diagnosis? Excellent. Yes. Recently, I think an article was shared in our group. So I'm sure you're all very well. So this is mycetoma foot or Madura foot. And can anybody tell what is the classical radiological sign shown here? The central low signal with a surrounding high signal. By the way, some of these are made up, they don't exist. Yeah, dot in circle sign. Yes, very good. Excellent. So this is a classical dot in circle sign that you see in a Madura foot. Basically, coming to the pathology, the central low signal is a fungal grain. It's surrounded by a granulation tissue, and there is in between these granules, there is fibrous matrix. So this is a key imaging finding in Madura mycosis. And it can also be seen on the ultrasound scan. These are the fungal granules surrounded by low signal granulation tissue. So the epidemiology, very important to know. Mycetoma pedis or Madura foot is a chronic granulomatous condition of the dermis and epidermis, and it can be caused by bacteria, atypical bacteria, actinomycetes, or by fungi, which is called eumycetoma, actinomycetoma or eumycetoma. It was first described in the Indian district of Madura in 1800, and that's why the eponym of Madura foot. It mainly involves the foot, and usually these patients are farmers working in the fields, and they have a thorn, and then it gets inoculated and slowly spreads to. So it's usually the legs, lower legs that are involved. Other hands and head and neck and chest cases have been reported before. Males usually are more prone, and it's a chronic infection. It inoculates into the skin and spreads to the other tissues. So this is the most important slide for this condition. So how do you differentiate if it is fungal or bacterial infection based on the imaging findings? The fungal usually have fewer cavities. The actinomycetes or bacterial infection has numerous cavities, like in our case. The size of the cavities is larger in fungal infection, smaller cavities, like in our case, in actinomycetes. Moth-eaten appearance is rarely seen. It can be bone destruction, but moth-eaten appearance is not common in fungal infection, but 25% of the cases show moth-eaten appearance. So there is actually a classification staging the involvement of various structures and how many rays are involved. So this is something you can grade the extent of the involvement using this table. Some references. Next case. This is a 33-year-old gentleman. He had a lateral foot pain, lateral ankle pain for last 1.5 years. Pain radiates down to the foot. So he plays football, and he never had a major injury, but it is a lateral aspect of the foot swells up on and off. Examination, he has thickening of the peroneal tendons posterior to the malleolus. And there is snapping sensation when he moves the ankle in certain direction. On the X-ray, you could see a little calcific density on the lateral malleolus, and there is soft tissue thickening over the lateral malleolus. So patient first had an MRI scan. It shows that peroneal compartment, there's fluid distension, a lot of thickening. This is the peroneus longus and the peroneus brevis anteriorly. I can see this, this is inframalleolar and this is posterior to the malleolus. And there is another structure here, which is also like a cord-like structure. And there is another small tendon here. So this is a longitudinal tear of the peroneus longus, which can be traced into the foot. And this is the peroneus quadratus tendon, which you will see that it will attach to the calcaneum. Sorry, this is the, you can see that this is the superior peroneal retinaculum. It is slightly loosely attached. It's not, it looks a bit lax. I'll show you the video. So this is the superior peroneal retinaculum. And you can see the anatomy here that this is the peroneus quadratus, which is a normal variant. It attaches to the retrocochlear eminence on the calcaneum. So I'll just show you this video. So you can see that the peroneus longus divides into two bundles. This is a longitudinal tear of the peroneus longus. It's got intrasubstance changes. This is the peroneus quadratus, which is a normal variant. And there is fluid distension. And then we're going down, and you can see that peroneus longus, again, there is a longitudinal split as we go further down. The peroneus quadratus attaches to the medial aspect of the calcaneum. So after this, patient came for an ultrasound scan, which showed again this similar anatomy, showing the peroneus brevis, peroneus longus tendon, marked Doppler hyperemia, and peroneus quadratus as well. So the reason we did the ultrasound was the our foot and ankle surgeon wanted to know if there is snapping and dynamically evaluation of the tendon. So this is the lateral malleolus. You can see the tendons in the retromalleolar groove here. If you see the this is the retinaculum, superior retinaculum, which is thickened and it's a bit lax. And when the patient moves his ankle in certain way, it comes on the top of the lateral malleolus and then slides back. So this is how this is very important, and he's going to have surgical repair. So peroneus quadratus is a normal variant. Superior peroneal retinaculum injury can cause instability and subluxation of the peroneal tendons from the retromalleolar groove. Dynamic ultrasound helps to diagnose the instability, and treatment is surgical. Okay with time to show the next one. Yeah. As 51-year-old male patient, 6 months history of medial foot pain. On the plain film, didn't show any abnormality apart from a type 3 accessory navicular. His bloods were normal and never had any history of injury. Here you can see that where he had pain, the spring ligament, we didn't see any significant abnormality in the spring ligament, but there was some fluid around the distal tibialis posterior. So ultrasound scan was suggested to look for Doppler hyperemia, and ultrasound scan was performed. And you can see this is the tibialis posterior tendon. Deep to it is the spring ligament, and you can see a echogenic deposit with no acoustic shadowing within the spring ligament. You can see that again here. So differential diagnosis of crystal arthropathy, and we wanted to exclude possible gout. So we did a dual energy CT, which showed calcific deposit, and there was no gouty deposit. You can see that this is the same attenuation as the arterial calcification here, and you can see that in the dual energy CT also. You can see the only calcium is isolated involvement of the spring ligament by calcific deposit is very rare, and dual energy CT is a good non-invasive way of identifying, diagnosing this. And so patient underwent ultrasound guided barbotage, and see the barbotage procedure, and then injected some steroid around it. And it's been like 4 months now, and there's been significant improvement in his symptoms. And there is that this thing. So I'll stop here.
So next is Dr. Wissam. She is a third-year resident in SKMC, and she's going to share a couple of cases as well. Dr. Wissam.
Hello, thank you for the opportunity first, and special thanks to Dr. BJ. I'll present 2 cases. Okay. So the first case is, so the first case is a 50-year-old female, previously healthy. She presented to the clinic with on and off pain for the past 5 years and her left big toe. She doesn't recall any history of trauma, swelling, or redness. On clinical examination, there was tenderness over the nail bed and interphalangeal joint of the left big toe. Her labs were normal, and we performed a foot X-ray. So these are pictures of her foot and first digit. And as you can see, it's basically normal. There are no bone or soft tissue changes. The patient directly was investigated with a non-contrast MRI of the foot, and it showed a small, well-defined lesion as depicted with the red arrows in the dorsolateral aspect of the distal phalanx. And it has associated a mild scalloping of the underlying bone. The interphalangeal joint was normal. And on STER images, there was no bone edema. And on the T1 images, the bottom image on the middle, it was iso-intense to the nail bed of the first toe. So we raised suspicion of a specific differential that happens specifically in this region, the subangular region. But if you want to do one further test to confirm your diagnosis, what would you do? An ultrasound scan. It's a superficial lesion, and it can give you the vascularity of the lesion itself. It's lagging. Okay. So her ultrasound showed a well-defined hypoechoic oval lesion that was in the nail bed of the first toe. This is comparison between the right side and the left side. And when we put color Doppler, the lesion was highly vascular. So in this region, the subangular region, with this appearance on MRI and ultrasound, it will literally leave you with one diagnosis, which is, yes, glomus tumors. So glomus tumor, or as called glomeruloblastoma, it's a tumor from the glomus body, which are basically arteriovenous anastomosis that regulate, that's responsible for thermoregulation. They're present all over the body in the stratum reticularis of the dermis, but they are more numerous and concentrated in the digits, palms, and soles of the feet. That's why 75% of them, they occur in the hands and specifically in the subangular region. 2.3% of them, they're multiple, and they present usually between 30 and 50 years of age, and there is a female predilection. Clinically, they present with on and off intense or pulsating pain, and usually you see a reddish or bluish mass under the nail. Ultrasound is a very good tool, and it depicts tumors as small as 3 millimeters. The treatment of those tumors is surgical, but up to 50% of them, they recur after surgical excision. So that was a simple case. My second case is a 46 years old male that had a minor trauma to the foot, and he presented with swelling and pain. His labs were normal, and this is his foot x-ray. So there is a lytic lesion in the third metatarsal. So when you see this, you have to ask yourself questions. So what is the age of, was this turn on? What's the age of the patient? He's above 40, he's 46. Does it look aggressive or non-aggressive? It's expansile, there is no destruction, no peripheral reaction, and there is no soft tissue extension. It has a narrow zone of transmission, and you have to see if it's single or multiple lesions, and look for pathological fracture, especially in the context of trauma. So what is your likely diagnosis based on the X-ray? Okay, so you basically have to consider all differentials of a lytic lesion of the bone. And this is a nice mnemonic that involves them all. And there would be differentiating points like age or the location and the appearance of the lesion. Our patient is above 40. So with the appearance on the X-ray and the age, it will leave you basically with possible fibrous dysplasia, multiple myeloma, hyperthyroidism. Infection is always there, but the presentation was less suggestive. And in chondromas, usually they present in younger patients, but it's still kind of differential. So what would you do next? MR? Where's my next slide? Okay. So you do an MR? Yeah, you do nothing. So you do not, at least for now, you do nothing. So as radiologists, the usual practice is that we see the patient's file and we go back to previous images to look for hints that would help you direct your diagnosis. Of course, always investigate. So remember, previous imaging is your best friend. So that's what we did in this patient. So these are his X-rays of the pelvis and lumbar spine of different time points. So what you can see in those pictures. Yes. So sclerotic end plates of the vertebral bodies. Yes, the joint is widened, and the pubis resorption, symphysis pubis resorption. So this is the resorption, widening of the SI joints, and the rugged dorsal spine, or the sclerosis of the end plates. The patient also had a skull X-ray and multiple brain scans. And as you can see here, sorry, with the manipulation of the slides. So it has a skull X-ray and CT scans. And you can see there are multiple small lucencies in the skull vault with mild thickening. And this is what we call salt and pepper appearance or pepper pot skull. The patient also had a bone scan, and you can see that there is diffuse bone increased uptake in the bone relative to the soft tissue with absent normal distribution in both kidneys. And we call this a super scan. And last, he had a SSMC scan that showed increased uptake at the bilateral inferior poles of the thyroid lobe. And this is suggestive of bilateral parathyroid hyperplasia. So do you have your diagnosis now? Yeah, so brown tumor. So with all of this previous imaging, the lesion that was seen in the foot is likely a brown tumor, and you don't need to investigate it. And in the power chart, the patient was CKD as well. So these are appearances of the brown tumor on the CT. You would find lytic lesions, and this patient has resorption of the SI joint as well. And the density sometimes is of blood because they have hemorrhages within. On MRI, they are ISO to low intensity in both T1 and T2, and the granulation tissue would enhance on post-contrast. And on the left image, you can see transplant kidney. So brown tumors, they're called brown because of the appearance of the tumor itself and because it has internal vascularity and hemorrhage. It's called ostitis fibrosa cystica or osteoclastoma. Histologically, they are identical to giant cell tumors, but brown tumors, they are a reparative cellular process due to hyperthyroidism rather than neoplastic. So when this osteoclastic activity happens in a focal region with hemorrhage and repetitive granulation tissue, it forms a brown tumor. They are more common with primary hyperparathyroidism rather than secondary, but because secondary hyperparathyroidism is far more common than the primary, so most of the lesions we see are in association with secondary hyperparathyroidism. The common sites are mandible, clavicle, ribs, and pelvis. So I'll end it here so you can enjoy your coffee. Thank you.
Thank you. I think we're gonna break for coffee for about 10 minutes and then reconvene the meeting in the last session at 3:40. We're gonna start. Yeah. Okay. Thank you very much to the speakers, and thank you for moderating the session, Dr. Esat and Dr. Rashid. Any burning questions? No question. Right. Okay. think they put it here. Wait. I don't know. It was a link they sent. Welcome back. We are in the last session of today's meeting, and it's about soft tissue and bone tumors. So I'm accompanied by Dr. Faris Al-Malla. He is consultant radiologist in HealthPoint. So we're going to invite Dr. Rami Mansoor again, and he's going to enlighten us about imaging of soft tissue tumors, pitfalls and tips. Dr. Rami Mansoor.
So this is the last session, and it will be a tumor session. And I will start the first presentation about imaging of soft tissue. There will be lots of slides about the background of soft tissue and how we diagnose it, which is very important. So there'll be more talk and less imaging. Let's start. Bone sarcoma is soft tissue sarcoma is extremely rare. So if you work in a general hospital and you're practicing general radiology across your lifetime, you will come across 1 or 2 confirmed soft tissue sarcoma. So it's not a common findings. It depends, of course, where you practice radiology. By far, if you come across a soft tissue tumor, it's more likely it would be benign, not malignant. And this is the latest WHO classification. They classify the soft tissue depending on the tissue of origin. It could be depositic, so lipomas and fatty tumors, or a blastic tumor, whether it's fibroblastic or myofibroblastic, and fibrohistiocytic tumors, tumors from the smooth muscle cells, from skeletal muscle cells, nerve sheath tumor, and undifferentiated tumor. So you can see there is a long list of tumor with the now with the development of immunohistopathology and genetics, that even they have subcategories and subtypes. So it is a long list of tumor. So that's why it's really difficult for us as a radiologist to identify and can characterize all of this tumor when we assess them on the ultrasound or MRI. To make life easier, so this is a list of the 7 common soft tissue tumor, which constitutes 70% of lesion. And you can see most of them are benign, and they either will be lipoma, fibrous histiocytoma, nodular fasciitis, nerve sheath tumor. So this is the 7 most common diagnoses you need as a radiologist you need to make. And you can see what we call the other tumor, which is what I call pseudo tumors or non-real tumor, like ganglion, myxoma, or synovial chondromatosis and glomus. They constitute 32%. So if you add the lipomas and the ganglion and cysts and others, so you're talking about 50% of the soft tissue. So this is what you probably all of us see on our weekly and daily practice. This is what we come across. However, what we don't want to miss is this, the true malignant. And this is why we scan those patients. And this is the list of the 7 common malignant that constitutes 70% of the malignant tumor. And you can see the most common are the myxofibrosarcoma, liposarcoma, and the leiomyosarcoma. So you're more likely, if you feel this is a malignant soft tumor, would be one of these top 3 tumors. Clinical history, as always, is very important. You need to know patient age, and you need to know clinical history, and whether there is a past history of trauma, change in size, is it single, is multiple, and so on. Just a quick comment on our referral guidelines. There is a strict NICE guidelines, the National Institute of Clinical Excellence in UK. They say advise the GP or any general clinician if you come across a lump which is increasing in size. The size is more than 5 centimeters. It's deep lump, so we have to refer this lump for a scan. So it is malignant till proof other way around. So, and this is how we get referral of all these patients to us. Age. The good news is any child who's less than 5 years of age and presented with the lump, it is very, very rare to be malignant. It's more likely to be a benign lesion. So this is something is very important to know. You can see on the right side of the screen, this is a mass, a fatty mass that you can see behind of the ankle, which turned out to be a lipoblastoma. So age is very important. Malignancy is more common than 5 years of age. So why we scan those patients? What we want? So as we understand, it's very difficult for us as a pathologist to identify exactly the histology. However, we can help a lot by scanning this patient. First of all, if this one of the aim of this scan to prove is it really tumor, because we come across of lumps that is not really lumps in place. We scan them and it turns out to be just abnormal fat, or it's just a area of fat necrosis or contusion, or just a chronic unnoticed or undiagnosed muscle tear or a muscle hernia. So they're not really a lump in the first place. So first of all, scans need to confirm that this is a real tumor. And if it is a real tumor, of course, the ultimate goal, we need to tell the patients and the clinician, is it benign, is it malignant, and so on. And of course, the size and if possible, tissue characterization. So this is the goal, the ultimate goal. In the UK, we always, whenever there is suspected tumor, we start with ultrasound, okay? And because we agreed, as I just mentioned, we can diagnose 30 to 50% of those patients. Either this is a lipoma, cyst, so we can tell. And after patient, we vet this patient and we do ultrasound, then we can decide whether we move on to MRI or CT or radiography. So most of these patients will present it to our department for ultrasound in the first instance. And this is what we need to diagnose with ultrasound. Is it ganglion? Is it lipoma? Is it hemangioma, AVM, or is it foreign body tumor? So we can confidently, with ultrasound, make this 4 diagnoses. So if we couldn't, then we refer to MRI to proper characterization for the location of the patient, of this lesion, and whether we can say this is malignant or benign. Okay, so this is the MRI protocol. All of us knows that whenever you do MRI, you have to put a skin marker, and it's very, very important because we as radiologists, we don't know where is the lesion is. We don't see the patient when we do the MRI. So it's very, very important to put the skin marker. Okay, so this is a way to try to identify the nature of this lesion through MRI by looking at the location. Okay, and again, it's very important. We just mentioned, depending on the location, you can tell. Have an idea with this type of the lesion. Look at the signal characteristic, again, multiple or single, and we can tell if there is any calcification. So I'll show you some examples of tumors that just by simply looking at the location, you can tell which type of this lesion. And this is, we should diagnose those kind of tumor. So for example, if it is close to the joint, probably it will be a giant cell tumor of the tendon sheath or PVNS. If it is in the posterior chest wall, it will be elastofibroma dorsi, and so on. Okay. So, for example, this lesion is seen in the anterior abdominal wall, rectus femoris, and you can see in the ultrasound might looks very suspicious and because it's ill-defined, but just depending on the location, we know that this most probably will be a desmoid tumor, regardless of how it looks, because of just basically because of the location, we can tell this probably would be a desmoid tumor. If this lesion very close or on the course of the nerve, so we can tell this probably will be nerve sheath tumor. Okay, and you can see it is in the course of the popliteal tibial nerve. And of course, if this looks more irregular, they can suggest this might be a malignant nerve tumor, but at least we know this is probably will be a nerve tumor. Okay, another characteristic is placed in the nail bed. So if you have a painful lesion in the nail bed, it will be possibly another desmoid tumor of the nail bed. Okay, and this is how it looks. Even if it looks ugly, if it looks very suspicious, at least simply by looking at the location, we can tell. Another typical location, a lesion around the nerve, around the tendon, so it would be giant cell tumor of the tendon sheath. And this is very common. All of us should know that. A lesion deep to the serratus anterior and the posterolateral aspect of the chest wall, so it is elastofibroma dorsi. So location, as they say, is very, very important. Another lesion in very close to the plantar fascia, and so it is plantar fibromatosis. So after the location is the signal intensities, and this is the possible signal intensities of any soft tissue lesion will come across. If the lesion is high in T1, low in T1, and high in T2, or low in T1 and low in T2. So this is the variation, different variations that will come across. So we'll start by the high T1 soft tissues, which is probably will be fat. So we know all of us, we learned that anything which is high in T1 is probably fat. And the other possibility would be blood, but of course the most common lesion or tissue that is presented as a high T1 is fat. And of course the most common one is lipoma. We all, it's a very straightforward diagnosis. It is high in T1, and with the fat suppression sequences, it's suppressed. Okay. So again, whenever we see that is lipoma, and there is a lot of other lipomatous variant like angiolipoma, lipoblastoma, hybernoma, melanoma, all of them look fatty. And this other variation is just is histological diagnosis, and sometimes is also depending on age. And this is some example of lipoma. And I know that there is size criteria, and people say, if it is more than 5 centimeters and is intramuscular, it's most likely to be liposarcoma, which is not necessarily true on all of the patients. I think, in my opinion, it always depends on the characterization of the fat. So, for example, if you look at this lesion, and you can see this is a big lesion, but look at the fat, and look at and compare this fat to the subcutaneous fat. In your opinion, which one is more complex? You can see here the subcutaneous fat is even more complex than the lesion itself. So if the subcutaneous fat is benign, so this is most probably, or 99% it is benign. So this is if you measure it, it's more than 5 centimeters, but in my opinion, this will be still a simple lipoma and turn out to be a simple lipoma. And again, so look at this lesion in the rectus femoris. You can see it is a bit complex because of the muscle, but compare it and compare to the fat around it. Still, it's even simpler than the subcutaneous fat, completely suppressed in stir images or the fat suppression images. So it is again simple lipoma. When you get suspicious is when, and this is just an example, when you combine the fat signal with the location, you can tell the diagnosis. And this, you can see, this is a fatty tumor in the course of the median nerve, so it would be lipomatosis of the nerve. So when you combine the signal intensity and location, you can tell even if it is a rare diagnosis, but you can confidently call it. So this is where when you start to get suspicious. You can see that this is lipomatous lesion. There is lots of things going on here inside. There is thick septi. There is areas that is not suppressed. So this is when you start thinking this is malignant, and this is probably a liposarcoma. And this is an example of a nodule which was not suppressed with fat, more than 2 millimeters. So this is, again, you can be suspicious of liposarcoma. Again, you can see that. Compare this fat to the subcutaneous fat. There is a lot of things more going on here that suggests that this is probably a liposarcoma, and it's proved to be a liposarcoma. So other things that is bright or high in T1 is that contain fat, is like hemangioma. Hemangioma always contain fat. Lipoma, intra-articular lipoma, we call it lipoma arborescens, and other non-fat, which is the hemorrhage and melanin. So there is some differential diagnosis. For us, if you report lots of soft tissue lesions, this would be a straightforward diagnosis. You see a lesion intramuscular or subcutaneous, and you can see there is fatty signal that's suppressed, and we see this bright signal inside. And when you and this kind of arborization is more likely to be a hemangioma if it is combined with calcification, and it really depends on the site where the calcification is. If it is peripheral and stippled, so it might be myositis ossificans, and again, really depends on the history of this patient. Have a history of injury or a previous fracture or not. And this is another example of a mixed lesion with a fatty signal, and it's intra-articular location make you think of something else like a hemochromatosis. So this will be combining the location and the signal intensity of fat. Okay, so this circle should be around the water, but it's just been displaced. Anyway, so this is another type of lesion that is represented by high signal in T1. And of course, from basic teaching, we know anything which is high in T2 is more likely to be cystic. So it could be a cyst, or the other differential diagnosis is what the myxoid or myxoma lesion. So if we see a lesion which is intramuscular, and we think it might be a cyst or look cyst, but the clue it have this kind of mild edema around it. So this is how the myxomatous tumor are presented. So they look very cystic. And to make sure to tell the difference between whether this is a myxoma or cyst is very simple. Either inject contrast. So if it is myxoma, we'll take peripheral. Or if you didn't inject contrast, simply you can just put the patient to do an ultrasound. An ultrasound to show this is a solid tumor and it is not a soft tumor. So intramuscular myxoma looks like a cystic lesion. I have this characteristic high T2, high signal in T2. Another example, and you can see after contrast, it shows enhancement, though it looks very cystic, but it has on MRI, but it has contrast. So this is an intramuscular myxoma. So we can tell another example of a lesion that have a myxomatous cystic, what looks like cystic lesion, and also have what a fatty signal. So the probability would be myxoid lipoma or lipomyxosarcoma. So we'll move over to the other spectrum. The other side of the spectrum is the low T1, and this is the list of possibility if it is low in T1. And by the way, the circle should be around the calcium, not muscle. It's just been shifted. Everything's been shifted a little bit to the side. So the circle around it should be around the calcium. So we're talking about a calcium, fibrous tissue, homocidrin, that all this tissue can give you a low signal in T1. So a big lesion, intramuscular, with a lot of low signal both in T1. So the differential diagnosis would be either, as I mentioned, calcification or fibrous tissue. And in this patient, turned out to be fibromatosis. Of course, to tell the difference between calcium and fibrous tissue is straightforward. If you can tell by its shape and MRI, but again, if you're not sure, simply do an X-ray. Okay, so you can tell this probably a fibrous tissue and not calcification. Another low, and its typical location in the Achilles tendon. So it is fibrous tissue in the Achilles tendon, so it is xanthosoma. So combining both the high signal, the signal intensity, the low signal intensity and the location. Okay, another simple, straightforward case. In my opinion, you can see a lesion with loss of low signal in the three sequences you have. So this would be hemangioma, and this low signal could be two possibilities, either flibbolith, or it could be just a single void area because of the flow. But it didn't enhance in the post contrast, so probably this is a calcification. Not sure, do an X-ray, okay? But this turned out to be hemangioma. And again, a signal void areas could be just because of the vessels. I find, with especially hemangioma, this compressibility maneuver is very, very useful, because sometimes you're not sure whether this is really a solid, it is really sarcoma, because in ultrasound especially, sometimes hemangioma doesn't look solid. And so when you see this heterogeneous and you can press and it is partially compressible, it is not specific. It wouldn't 100% tell you this is hemangioma, but it is helpful sign to add to your different signs of on the ultrasound and of course MRI. So partial compressibility. We already mentioned calcification, which will always be helpful, and this has happened when you see this low signal, and it's always the other way around. People, nobody asks now, whenever there is soft tissue tumor, nobody asks for any X-ray anymore. So patient comes for ultrasound, then MRI, then the third step. This is where the X-ray becomes as a third scan for those patients, and sometimes they don't do it. But I think for doing any kind of biopsy, it's better just to have a simple plain X-ray for the whole limb, because it might be helpful and might see some surprises on the plain X-ray. So this is a list of tumor that might cause calcification. And sorry, I didn't put it in what you call frequency. So synovial sarcoma is not the most common lesion that causes calcification. So it's just a list of possibility. So actually the most common one is the chondrosarcoma or hemangioma. So it's not put in order. It's just the mention of all the soft tissue lesion that might present with calcification. And this is just a few examples of lesions with calcification. We already mentioned the hemangioma, we mentioned myositis ossificans. And please, I find it a very helpful article, though it is 2009, but I think it's still valid to this day. And it's just very, very helpful for you. If you forgot about all of what I mentioned, it's just they mention exactly what I just been trying to explain in the last 20 minutes. And I will stop here. And this is just the take-home message. Most commonly, the lesion will be benign. And in the other end of the spectrum, you can see a patient and you say this most probably would be malignant. And of course, if you're not sure, always ask for biopsy. Thank you very much.
Thank you, Rami, for this informative and well-presented presentation on the soft tissue tumors. We would like to welcome back Dr. Abdul Rafi Khan to the podium for his next presentation on cases on soft tissue discussion of soft tissue tumors.
So thank you very much. Again, just some soft tissue cases. So when I was given this topic, I asked Dr. Vijay how many people are attending. I was told about 400 people. A lot of them are apparently online. So I said they can't be 400 MSK radiologists. It must be, radiologists, general radiologists, residents, and maybe medical students as well. So I've kept the talk very general. It's not particularly for MSK radiologists, but it is for general radiologists. And so the lesion I'm going to discuss about would be more ultrasound based. So, we run something called an MSK ultrasound clinic, and we get lumps and bumps over there. And my talk is about how do I approach someone who comes in with a lump in our ultrasound clinic. So, and predominantly it is going to be about, the lesions that I see, I can dismiss, I can tell, go home, nothing to worry about. So those are the kind of the lesions that I want to show primarily on this talk. So when I have a patient come in for a lump or bump scan, so I kind of place them into two categories. Either they're benign, so I can tell them go home, nothing to worry about, or they're indeterminate or malignant looking. So if they come into the second category, then of course they need further imaging and they need referral to a specialist center. So, but if they are benign or potentially benign based on ultrasound scan, and you can confidently call them non-sinister, then you can dismiss them and they would not require any further referral or imaging. So that is the kind of focus of my talk today. Whenever a patient comes in, I'd like to normally take history myself as well in the clinic. Patient would tell you they've got a lump. You want to know how much duration they've had it for. Sometime, they've had it for 20 years, but they happen to see a doctor and the doctor examines, say, go and have your scan done. They had it for 20 years. It's not changed at all. In my books, it's a benign lesion, so I'm not too much worried about that. Change in size. If the lesion is rapidly changing in size, then I get worried. It is something which potentially can be sinister. And whether it's painful or not, again, that would kind of suggest about it being sinister or otherwise. History of trauma. If they've had trauma, could it be a muscle tear, hematoma, or something like that? So these are the common questions that I always ask in my MSK clinic when I'm scanning the patient or even beforehand. And I also like to examine my patient before I start my scan. So I ask the patient to localize. So I want to exactly scan, what they're worried about. Sometimes the lump or the lesion that they're feeling, it might not be very evident. So it's very important to ask them to localize that for yourself. Then you should physically examine the patient as well. How does the lump feel like? Is it fluctuant? Is it adherent to any, the skin, or adherent to some underlying structure? So that kind of gives you a feel before you start the scan. Even before we had our MSK clinic running, we used to still do the same thing for anyone who comes in with a lump or a bump. And the two broad categories that I kind of place the lesion based on my initial scanning is it solid or is it cystic? Cystic lesions I tend to worry less about. Not all the cystic lesions I can dismiss, but cystic one is that I'm not too worried about compared to solid lesions. Again, I would take that with a pinch of salt. Not all cystic lesions are benign. So the ones I'm going to show you, of course, are benign. Other thing, when I'm scanning the patient, I'm thinking about where exactly is it located. If it is in the subcutaneous fat, under the skin in the subcutaneous fat, it is less likely to be malignant. But again, it is not a characteristic based on which I can totally dismiss the lesion. However, if it kind of touches a deep fascia, gets across a deep fascia, is intramuscular, crosses facial lines, again, I tend to get worried about. And other thing I look at is the vascularity. That is very important. So anyone who comes in for ultrasound scan, I want to establish solid, cystic, where exactly it's based, how vascular this lesion is. These three things I always want to look at. Now, this is a 32-year-old chap who's got a lump on the wrist. So if we look at this lesion, so it is anechoic, so there's nothing inside, it's just jet black. If it's jet black, there's posterior acoustic enhancement. And if I put a Doppler on it, there's no flow. There's no flow inside the lesion. There's no flow hyperemia in the wall of the lesion, or it has an imperceptible wall. And the lesion is related or closely placed to a joint or a tendon sheath. Then this is a benign lesion. It's a ganglion cyst. So I'm not worried. I can reassure the patient. I can send the patient home. Tell them this is something you can, dismiss. This is someone else who had a lump in the finger. So again, you see over here, there is a jet black lesion related to a tendon sheath. It has posterior acoustic enhancement. By that I mean, when the sound waves gets into this cystic area, fluid makes them go, they increase their flow, and you get brightness behind that fluid structure. So you get posterior acoustic enhancement. So it is jet black, it is anechoic, it has an imperceptible thin wall, it has posterior acoustic enhancement, there's no flow, it's related to a tendon sheath, it is a ganglion cyst. So again, I'm not worried about it. So ganglion cysts, like I said, they're benign cystic lesions. They are related to joints or tendon sheaths. They can cause pain or discomfort because of their sheer size. They can have mass effect. By this mass effect, I'll just explain what I mean in a second. Or they can be, troublesome because of cosmetic reasons. They're very obvious on the wrist, for example, and patient wants that's dealt with. Otherwise, these are the lesions which you don't necessarily have to deal with. However, having said that, I do want to mention ganglion cyst could potentially point to an underlying pathology of a joint or a ligament. So you have to bear in mind, if they've got a painful joint, they have a cyst next to it, it might suggest there is some pathology in the joint, non-malignant or benign pathology, that is exhibiting in the form of this cystic, cyst. So again, it can suggest some underlying pathology. I said about the mass effect, sometimes these ganglion cysts, if they get into narrow spaces, for example, this is a cross-section of the wrist, and you have the ulnar nerve, which goes through a narrow space, which is called the Guyon's canal. If the ganglion cyst, it might be very small, but if it gets into this canal, that can cause pressure effect on the ulnar nerve, and you can have features of ulnar nerve impingement. Again, this is a patient who has this MRI scan of the shoulder, and they've got this high signal multiloculated cystic lesion, which is in the suprascapular region. So it is impinging on a narrow space through which the suprascapular nerve passes, and that can lead to denervation, and denervation means you get denervation edema, so the muscle becomes edematous. This is the infraspinatus, which is slightly edematous. I can see it's probably not very well projected over here, but this can cause denervation edema. So you have to deal with this cyst because this is causing pressure on a nerve, similar to a cyst which can be sitting in the Guyon's canal. So this was otherwise a parameniscal cyst, paralabral cyst, which was suggestive of there is an underlying pathology of the glenoid labrum. Like I said, they can suggest there could be a joint pathology underlying, and they can, in this case, also have a mass effect like they're having on the suprascapular nerve. This is a 34-year-old chap. He comes in with a lump at the back of the knee. So back of the knee, commonest lump would be a Baker cyst. but we have to be sure this is a Baker cyst. How do we become sure it's a Baker cyst? It is on the medial side of the popliteal fossa, and then we have to see its relationship with two tendons. Those two tendons are, I'll demonstrate over here. This is the tendon of the medial head of gastrocnemius, and this is the tendon of the semimembranosus. If the cyst originates from this hiatus, then it is a Baker cyst, again, a benign pathology. And again, this is an MRI scan demonstrating the very same thing. This is the medial head of gastrocnemius, and this is the semimembranosus tendon. And through the hiatus between these two structures, there is a cystic lesion. So that cystic lesion is a Baker cyst. So I can dismiss that as a benign pathology. If it doesn't come from this hiatus, then it could be still a cyst, but it is not a Baker cyst. It would be a cyst due to some other pathology, or it would be a cystic lesion. So I won't be able to dismiss it as a Baker cyst. I need to see getting into that hiatus, only then I can call it a Baker cyst. So this is a 27-year-old female. So it comes in with a lump at the medial aspect of the knee. And if you look at the plain radiograph, again, you can demonstrate you can appreciate there is soft tissue swelling. And looking at that, you would think about, okay, it's related to the knee, so it's probably going to be something like a parameniscal cyst. So they might have underlying meniscal pathology, like I said. However, when you put the ultrasound probe, it doesn't look like that. It is something very different. And in the initial, looking at it, you would say, it's a hypoechoic lesion. So I'm kind of a bit concerned. So what I'm dealing with, it could be something nasty. So I kind of follow my principles. So I try to locate the lesion where the lesion is. So it is in the subcutaneous fat. It is in contact with the skin. I put my Doppler on it. There's no flow in it. And then I look, there is posterior acoustic enhancement. If I analyze this lesion now in a bit more detail, so it has got certain characteristics which would help me to characterize it and get to the diagnosis just based on this ultrasound scan. And this is a lesion which is commonly presented in, lumps and bumps clinic, and it could be presented to a general radiologist who would have to diagnose it. If you find these features, then you can confidently dismiss this is a benign lesion. And the features are, it is ovoid, it's hypoechoic, it looks like a pseudotestis appearance, and it is subdermal, like we said, just in contact with the dermis. This is the dermal layer. And then it has anechoic or black, jet black filiform areas. Then it has some hyperechoic areas, these stripes over here. And it has posterior acoustic enhancement, and there's no internal vascularity like we saw. And top of all, it has a punctum. It has this hypoechoic tract, which is going to the skin surface. So this is a sebaceous cyst or an epidermal inclusion cyst. If I see all these characteristics for something which on the initial images looked something not totally benign to me, but having been able to demonstrate all these features and being able to see that punctum getting to the skin, then I can confidently call it is a benign lesion, which is a sebaceous cyst or an epidermal inclusion cyst. Okay. For the sake of time, I'm just going to go quickly. So next patient, 30-year-old female, lump in the arm. Okay, again, same principles. So this is a lesion which is in the subcutaneous fat away from the deep fascia. It is rounded, it is hypoechoic, and if we did a Doppler on it, there was no flow in it. And hyperechoic lesion in the subcutaneous fat is about 2 centimeter. And when I examine the patient is mobile, it is most likely a lipoma. So it's something which I can dismiss as being a benign lesion. This is someone who's got a relatively large lesion over the shoulder. Again, if I follow my principles, it is in the subcutaneous fat. This is the dermis. This is the muscle. So it is in the subcutaneous fat. It is hyperechoic. So we said lipomas can be hyperechoic. Lipomas are mostly hyperechoic, but not always. So this is hyperechoic in the subcutaneous fat, in contact with the deep fascia, but doesn't get into the muscle. It is probably a lipoma. However, having said that, we said if the lesion is deep in contact with the deep fascia, and if it has obtuse angles, is not less than 90, but more than 90 degrees, then I'm a bit more concerned. This is kind of the malignant side of things. This is the benign side of things. If I go back to it, So this has an obtuse angle with the D fascia. So it looks like a lipoma, but it's a large size, it's more than 5 centimeter. So I would confirm it with a MRI scan before I dismiss it as benign. So it is a benign lesion, but this would need further imaging to confirm that. Okay, based on the principle that we talked about. This is again someone who has a lipoma. So we said lipoma can be hyperechoic, but sometimes they're isoechoic. So this is isoechoic. It's located in the subcutaneous fat. It makes an acute angle with the fascia. So it's outside the fascia. It's not inside or not crossing the fascia. And it doesn't have any internal heterogeneity. There's no flow in it on the Doppler scan, and there are no thick septation. So this is again most likely a lipoma. This is someone who's got what looks like a lipoma, but it is intramuscular, and it is a fairly sizable one, more than 5 centimeter. Any lesion which is subfacial in the muscle, I do want to take it forward and make sure it is what I'm thinking. It's a lipoma, so I have to prove it's a lipoma. Okay. And it was proved on MRI scan, it is an intramuscular lipoma. Sometimes you have these strands of muscle running through the lipoma itself. It can be towards the periphery, but it can be in the center as well. Don't get these mistaken for as if they are heterogeneity. There is heterogeneity in the lipoma. These might be just normal strands of muscle, like you can see in the bottom right image. So normal strands of muscle running through a benign looking lipoma. So everything which is bright is not necessarily a lipoma. This is a 58-year-old female, comes in with a neck lump. So it is hyperechoic. Is it in the subcutaneous fat or deep to the deep fascia? What is it? What am I dealing with? I follow my principles. I try to locate it. Then I put my Doppler flow on it. It's very, very vascular. So this turned out to be a malignant lymph node due to a medullary thyroid carcinoma. So they can be very hyperechoic when they are metastases from a thyroid carcinoma into the lymph node. So this was a malignant lymph node. So not all things which are bright in the soft tissues are benign. Okay, so we've talked about the lipoma. Just going to move forward slightly. Things which concern me when I'm scanning and I found a lipoma would be, it's the first presentation and they've noticed a lump and they're kind of in their older age, more than 60. Or there is a rapid increase in size, or it's painful, or the size is larger than 5 centimeter. It is deep to the deep fascia. If it has thick septations, it has nodular, non-adipose areas or non-fatty areas. All these things would tell me that it could potentially be something more than a simple lipoma, or it could be potentially be a liposarcoma. When I do my ultrasound scan, I want to exclude these features to call it benign and send the patient home with reassurance. If I see any one of these, then I need to refer them for MRI scan and to the local sarcoma service. Okay. So this is a 54-year-old man, comes in with abdominal pain. So now why would I be showing something over here with abdominal pain? So they've got this diverticulitis over here, which is causing the abdominal pain. However, if I look at it, there is a bit more fat over here around the kidney. Okay, you just have to see carefully. You can see the kidneys getting pushed forward. If I look at my reconstructions, then I can see, yes, there is definitely fat. All the mesenteric vessels are pushed forward, getting displaced. So this is a large fatty lesion in the retroperitoneum. The take-home point for this is any retroperitoneal fatty lesion, no matter how homogeneous it looks like, you have to treat it as a liposarcoma unless proven otherwise. So this has to be referred. If you see this on a CT scan, you report the diverticulitis, but you don't say incidentally there is a fatty lesion in the retroperitoneum. You mention that the patient has to be sent to the local sarcoma service for evaluation to exclude a retroperitoneal liposarcoma. So this is a 65-year-old man who comes with infrascapular mass. We do an ultrasound scan. So ultrasound scan shows what looks like, slightly heterogeneous, hyperechoic, relatively large lesion. Again, it is deep to the deep fascia. So that's the deep fascia there, that's the subcutaneous fat. So I can't dismiss this lesion. I have to take it forward. It might be benign, but I can't dismiss it. I have to take it forward. Or I look at the previous imaging. Previous imaging, like one of our friends says, is very useful. So this is a CT scan done for the same patient, which was done maybe 2-3 years back. If you look at this CT scan, in one look, you would say, no, I can't see the lesion. However, if you carefully scrutinize this CT scan, this area over here corresponds to that left infrascapular mass. So but it has density similar to the muscle over here. It's very easy to overlook this. This scan was looked at, but kind of missed that, it was looked as a skeletal muscle. And therefore, the patient went on to have an MRI scan. And again, we can see that lesion over here, but we see there's a lesion on the contralateral side as well. Again, we see a lesion on the left side, but there's a small lesion on the contralateral side. So this is an elastofibroma dorsi, which is a benign lesion. And it is incidentally picked up many times. So it's incidentally present in about 2% of the CT scans. So every 50 CT thorax that you report, you would see one, but I'm sure we don't see it that often. It is present, but it's very difficult to spot. That's the reason we don't see it. However, if the patient presents, they've got a lump in the scapular region or the infrascapular region, that lump potentially could be a elastofibroma dorsi. So it's a benign fibrofatty lesion. So it is not something malignant that you need to worry about. It is due to chronic friction. And like I said, it could be subscapular, it could be infrascapular. It is deep to the serratus anterior and latissimus dorsi. And this was bilateral. Again, you don't have bilateral symmetrical malignant lesions. So this again would suggest that this is not malignant. This is a benign pathology. So ultrasound, again, CT scan, old imaging, that could supplement and tell you this is a benign lesion. You don't have to go down the route of doing MRI scan. But it is difficult to spot. Like I said, it looks like almost like your skeletal muscle. So you might just overlook it if you scroll through the CT scan quickly. And many times it's asymptomatic, or it can cause pain or snapping sometimes. Apparently, it can be hot on PET scan. So if you see it hot on PET scan, it is not necessarily malignant. If this comes across in your tumor board and it is hot, that lesion is in the classical location, and it is bilateral, it's on this side, it's on the other side as well. So this is a benign elastofibroma dorsi, despite the increased uptake on the PET scan. So this is a 27-year-old male. He comes in with the lump in the lower leg.
One minute.
Okay, thank you. It is intermittent. And if you do the ultrasound scan, you can see there are muscle fibers herniating through a defect. So this is just a muscle hernia. So they've got a defect in the deep fascia, and the muscle fibers herniate through it. And if you do dynamic scanning, you can see the muscle fibers going back, coming out, going back, coming out with contraction and relaxation of the muscle. So you can again confidently tell the patient this is just muscle hernia related to a defect in the deep fascia. This is a lady who came in with a lump on the chest, upper chest. Patients would tend to worry about, could this be something very nasty? But if you put the ultrasound probe, this was actually just, osteoarthrosis of the sternoclavicular joint. So osteophytes and osteoarthritis with joint hypertrophy, they can mimic lumps as well. We tend to commonly see them in the upper chest related to costochondral junction, sternoclavicular joint. See it on the dorsum of the foot, very hard lump, put your ultrasound probe, it's an osteophyte related to midfoot OA. This is an example of a plantar fibroma. So again, a benign lesion. You want to identify the plantar fascia. So this is the plantar fascia. It would be originating from the calcaneal spur, and you would have a hypoechoic nodule. If that nodule is located within the plantar fascia, this is a benign plantar fibroma. Again, you can reassure the patient. Last thing to say, like Rami said as well, lump, you have to prove that this is a benign lesion. If you can't confidently prove this is a benign lesion, you have to treat it as a sarcoma. And it has to go to the sarcoma MDT. It has to go to the local sarcoma service, MRI scan, and further imaging, maybe down the route of biopsy if it is still inconclusive on MRI scan. So this is my take home message. Thank you very much.
Thank you. Thank you, Dr. Rafi, for giving us those tips. Before I invite the next speaker, Dr. Rashid Sharan, I think there's one thing which I would like to add to the soft tissue sarcoma talk. Any unexplained hematoma, you have to be wary of, because malignant soft tissue sarcomas, they can present as hematomas. So if you've got a deep-seated hematoma with first presentation without any history of even with a history of trauma, I would say, but there is no direct explanation why this patient got a hematoma, and it's deep. Do a follow-up, because you'll be surprised that soft tissue sarcomas can present as hematomas. And obviously you have to do on MR, you can look for enhancement patterns and all that, which will help you decide it's just a hematoma or a sarcoma. But unexplained hematomas, be wary of those. Right, so towards the last half of this session, from soft tissue tumors, we're going to go to bone tumors. And it gives me pleasure to invite Dr. Rashid Al-Sharhan from Mohammed bin Rashid University Hospital. And he is going to give us a talk on imaging of bone tumors, pitfalls and tips, followed by tumor cases from his team. Thank you.
Thank you. Assalamu alaikum. First of all, I would like to thank my friend BJ for the great organization, and I would also extend the thanks to the SSMC team of radiology here. So at the beginning of the talk, when I got the title, I was thinking, shall I give it as a didactic lecture? But then I decided to go as a case-based with some tips or take-home messages following every case. I have nothing to disclose. So now let's deep dive into the talk. So first case, there was a presentation of a limping toddler. The onset started about 4 days before the presentation. The original or the first study performed was a set of toddler limb radiographs, which is the full limb, followed by the area of concern. This was reported as no fracture or dislocation is seen. We can agree, like based on the quick look. So the patient, the team was still worried about the patient, which made them go to further evaluation by MRI. On MRI, it was also done as a large field of view, although the complaint was only limited to a certain area. On MRI, you can see that there is, comparing the right to the left, there is lots of edema around the fibula here. You can see here on the T1, T2 FATSAT, and post-contrast images that there is lots of edema with subtle enhancement. The report of this case came as underlying neoplastic process cannot be totally ruled out, which freaked out the team. They decided to book the patient for a biopsy. Remember, this is a toddler, so the note to the family was not well received. After a small MDT discussion, we went back and then we further analyzed the radiographs, and we saw that there is a subtle linear lucency. This is like an extremely windowed, and if you can see here within the arrow, if we go back to the original image, it was at this location here. So we had like, we were left, so this is a case of a fracture, but because the family received a news about a tumor or a neoplastic process, we had a dilemma, like, do we just addend the original imaging and we tell them that this is the finding and that's it, or shall we repeat radiographs focusing on that area or do a CT? The team opted for the CT, and which was done, showing that there is an undisplaced fracture with subtle periostea reaction involving the mid-fibula. So the take home from this message is gather enough data about the patient before labeling them with dreaded diagnoses like tumors, and analyze all the imaging modalities available for you. Most of the patients will get radiographs, CTs, and MRIs. So whenever you are dealing with a questionable finding on an MRI or something that looks very aggressive, just go back to the radiographs and see if you can identify that area, knowing the site that you will look specifically for. Next case, I have shown this back in the tumor talk that I gave back in October, but for those who are new here, it will be maybe something new. Adult professional dancer presented with knee pain. The patient was in the early 40s. The original radiographs performed, they were reported as normal. Then when we went back with extreme windowing and zooming, we were able to see that there is lucency in the proximal tibia, which with extreme windowing is much more clear than the original radiographs. So the patient had, because of the status, professional dancer, and it was labeled as some sort of a VIP. The patient had an expedited appointment at the MRI where it shows that there is an intraosseous lesion with soft tissue component and a bit of periosteal reaction, some periosteal permeative changes. Full bone scan was performed subsequently. And then the patient had surgery, and this was a path-proven high-grade osteosarcoma. The take home from this case is don't hesitate to adjust the windowing, don't hesitate to zoom on the images, either zoom in or zoom out, because sometimes you have the MRI in your face. If you zoom out, you might see the abnormality better. And for our colleagues that are not here from different services like orthopedics or clinicians or rheumatologists, if our report does not match the patient's symptoms, it's always better to negotiate or discuss the case again to see if we can do something better with the next imaging modality or adjustment of the previous report. And don't hesitate to ask for further evaluation by MRI or CT, especially in cases of suspected fractures. The most important, all of the fractures are important, but some of them, they have bad outcomes if untreated, including scaphoid fracture, hip fracture, and elderly. In cases of osteomyelitis, if you see a normal radiograph and the clinical suspicion is very high for osteomyelitis, don't stop there. And in this case, where there is suspicion for neoplasm. Sunset. Third case was of a 30-year-old female presented with a left knee pain. So on the original radiographs, I'm not sure if you can see it or not, it will highlight more or less something similar to the earlier case with extreme windowing. You can see that there is a lucency in the medial femoral condyle. No obvious cortical breach, but this is within the radiographic limitation. The patient had further evaluation by an MRI with contrast that shows that there is a mass with posterior cortical breach, some soft tissue component, and enhancement in the joint, which means maybe the joint is also compromised. The patient underwent surgical treatment with packing. This was a case of, as we saw on earlier presentations, a GCT, giant cell tumor of the bone. It is a typical location in adult patients. So with the treatment here, the patient had some packing, but if you can see that the border, let me go back on this image, the border here is very clear, while when we come superiorly and more on the upper part of the packing or the cement packing, it becomes less clear or more lucent. So the patient had resurgery with extension of the cement and more including more larger area of packing. So those tumors, although they are labeled as benign, those are locally aggressive tumors with high chances of recurrence, local recurrence. So for those cases, whenever there is cement or prosthesis in place, don't ignore the interface between the cement or the prosthesis and the bone. And when you do compare to previous images, don't just use the latest comparison, just go maybe 2 or 3 studies earlier. It is also important sometimes to go to the first original examination to see how was the tumor primarily seen on radiographs. This is a painting by the famous artist myself. Fourth case, we have a 35-year-old pregnant female presented with hip pain and inability to weight bear. She was early in her pregnancy. The question here, how would you approach her if you see the abnormality? I hope that everyone saw that the left superior pubic ramus is missing on this image. Sometimes it is very difficult to see what is missing on images. The patient underwent MRI. This was a questionable, like the treatment plan was not very clear since the patient has an early pregnancy. She was keen on keeping the or proceeding with the pregnancy, but she had this pathologic process going on. We opted to work her up and then rediscuss the potential termination of pregnancy or adjustment of the therapy plan or treatment plan. So as you see on MRI, there is a large soft tissue mass almost showing the superior pubic ramus on the left with extension to the acetabulum. Actually, if we go back, you can see that there is the acetabulum here is missing with some sort of a protrusio acetabuli picture. And here, this is the gravid uterus. The biopsy result was of a plasmacytoma, which is not a very common tumor on this age group since he was young. The patient underwent surgical resection of the area with reinforcement of the acetabulum, and she decided to terminate that pregnancy and then proceed with the treatment plan. Sometimes, so this is the fourth take-home message, that sometimes the missing structure is difficult to appreciate than having the extra structures. And I always advise whenever you have something that is present in pairs, like both brain lobes, eyes, lungs, you have two things you can compare internally to the opposite side. And it is also nice when the patient has bilateral imaging of a joint or something that you can have internal comparison to the of the pathology. So can you tell who is this? Our colleagues from UK. So this was Queen Victoria on one of the statues at Montreal General Hospital. So the fifth case is a 55-year-old patient who presented with hip pain. As you can see, the arrow is pointing to the area of the pathology where there is a well circumscribed lucency with a sclerotic border. So here, this case was presented in our sarcoma rounds, or the multi-modality rounds, MDT rounds. And the question was, is this something benign or something aggressive? Fortunately, the patient had other imaging in her chart before, which was a previous CT, where you can see that there is a track communicating or extending from the joint to the cystic structure or the lucency. And this was either a large subchondral cyst with mild OA, as there were some osteophytic clipping and mild narrowing of the joint space, or what they call primary cystic arthrosis if the patient is young and there are no osteodegenerative changes. More or less, they are the same entity. So this is a companion case, a young patient on treatment for Burkitt's lymphoma, now complains of foot pain. Here you can see the arrow pointing to a lucency with a small opening into the joint space. Bless you. With a small opening into the joint space. This is a 3D image showing the same abnormality. So do you think this is the same entity, like a large geoid or something else? I vote for something else. So here you can see an axial image. This study was done as a dual energy, which will make you think what was the diagnosis. It was gout. So with tumors, and his urate level was very high. So with tumors, there is the tumor lysis syndrome, where there is high turnover or fast turnover of cells, and there will be lots of urea in the blood that can deposit around the tissues. And my saying is, when in doubt, always think of gout. So the take-home message for the past two cases: not every bone lesion is a tumor or a neoplastic process. Sometimes it's just gout in the intra-articular gout or geoid cyst. So always analyze the images before labeling the patient with a bone tumor. Lower. Last case, we have a 36-year-old male patient. The history is withheld. Can anyone spot the abnormality? Huh? Okay. What about now? So there is hyperdensity in the right lung apex, and when you compare both sides, there is clear asymmetry. So the question is: this a primary lung process? Is this something external in the bones, or the patient had previous infection with pleural thickening? We went with the CT, and from the CT you can see a lesion in the first rib on the right. If I cut this one and put it in the foot, it will look like the case our colleague presented of bone tumors, of brown tumors, but this is not brown tumors. So it is an expansile lesion involving the posterior part of the first rib. And MRI was performed because the patient was worried, the family were worried, and it also found its way to our MDT meeting. On MRI, was the MRI useful? Not sure, but on MRI, you can see that there is an expansile lesion, low on T1, intermediate to high on T2 with some enhancement. The patient had multiple biopsies and all of them were inconclusive, which made up the diagnosis of rib fibrous dysplasia as opposed to enchondroma. So the take home from this case was to pay attention to the different hidden spots. Burj Khalifa. Oh, actually I have one more case. So 21 years old female had also an incidental finding on radiographs. Can you spot the abnormality? I hope yes. It is like in this area closer to the aortic arch. So the question is this primary lung neoplasm, anterior, posterior, middle mediastinum. We have the lateral to show that this is a posterior mediastinal process. And then we go down the posterior mediastinal lesions. This was none of the posterior mediastinal lesions, like nerve sheath tumor, extramedullary hematopoiesis, something myelocele, but was not that. The patient had a CT that shows that there is a large soft tissue neoplasm, soft tissue mass with irregular margin of the posterior rib. Also, the mass is extending to the posterolateral aspect of the vertebral body. There are few calcifications or mineralization areas of mineralization peripherally and within the lesion. MRI was performed to this patient, and there is the lesion is T1 hyperintense, T2 T1 hypointense, T2 hyperintense with heterogeneous enhancement. So this was a path-proven costovertebral chondrosarcoma. This is an atypical location for this entity. Usually they are more on the typical areas like the humeri, around the pelvis here, or around the hip joint. This is usually also it's seen in older patients, but the one that involves the rib, it can be seen with younger patient than the normal population. There was no take-home message for this case. So can anyone explain this image? No? So this is me when I was many kilograms less than today. But this was throwing boiled water in a minus 30 degrees, where the water will evaporate immediately in contact with the water surface, the cold air surface. Of course not. Yes. So just remember that before you analyze any bone for any case of bone tumors, you need to recognize that there is an abnormality. Not recognizing it, you report as normal and it will go away. But you need to recognize it, and then you analyze and characterize the lesions. And based on that, you can come up with your differential. This is the approach that I used on my previous presentation. I decided not to include it again. It's just for our view. You need to take into consideration the patient's age, the location of the neoplasm, the margins, and then the presence of cortical destruction. Is there any periosteal reaction, and the pattern of the periosteal reaction? The internal matrix, sometimes you will need to do CT scan to analyze the matrix. And then is this a single lesion or multifocal? Because some of the benign or less aggressive lesions can be multifocal, and metastases can also be multifocal. This is from radiology assistant. And labeling the patient as benign doesn't mean that it is not aggressive, like in the cases of GCT. And with malignant, usually the picture is more dirty looking with poorly defined borders, wide zone of transition, permeative appearance, and aggressive periosteal reaction like Codman's triangle. By that, we come to the end of the presentation. Thank you.
Thank you. That was excellent on time. So we're going to continue with the case presentations, and second last presentation today is bone tumor cases case discussion by Dr. Bushra Muhammad Tahan and Dr. Abdullah Hussain from Muhammad bin Rashid Medical School. Or these are residents, isn't it? Yeah, radiology residents. Yeah. Please welcome. And for the online candidates, I hope you guys have looked through the quiz cases. There's a link shared on the chat box. You could download the presentation and go through the cases before we discuss the answers. So yeah, please, over to you. Thank you.
Thank you. Okay, sure. Yeah, it's working now. Assalamu alaikum, everyone. I would like to thank Dr. Rashid and the organizing committee to give me this opportunity to present today. I'll present two cases. I have nothing to disclose. So I have two cases of two patients presenting with similar clinical presentation of a prolonged leg pain. And those were the initial radiographs taken on arrival in the AD. So I'll continue with I'll go into the details of the clinical history and we'll see the findings. So starting with patient A, he was a 33-year-old male, presented with right leg pain, started 3 months ago after playing football. So the pain, there was no pain at rest in the night, no swelling clinically, no tenderness, and the range of motion was intact. His labs were normal. Interestingly, in this patient, he had surgical nailing for stress fracture 3 years ago. So his initial radiographs showed cortical lucency and the anterior cortex of the right proximal tibia, as you can see here, with mild thickened cortex. CT was done and it showed well-defined hypodensity, intercortical well-defined hypodensity within mildly thickened cortex, as you can see by the arrow here. MRI was done for the patient and it showed the same focal hypodensity seen in CT as hyperintense focal lesion on fluid-sensitive sequences. There was no marrow edema and there was no soft tissue edema as well. Up to this point, the diagnosis was that this lesion is osteoid osteoma. However, revising the old radiographs of the patient for the other contralateral leg, what he gave history of stress fracture, which was internally fixed, as you can see here, that the finding is actually very similar. It showed also the same lucency in the cortex of the other leg. So a diagnosis of stress fracture was made for this patient rather than osteoid osteoma. Patient B, he is a 17-year-old male, presented with left leg pain, started 5 months ago, which is worsening at night. And this is to be noted because this is important to differentiate from stress fracture. There was no swelling or tenderness. The range of motion were intact, no history of trauma. Labs were normal and his past and surgical history were negative. The initial radiographs showed focal fusiform cortical thickness, as you can see, in the lateral and posterior cortex of the left tibia. There was no other finding on radiographs. On CT, it showed intercortical hypodensity surrounded by the cortical thickening and reactive sclerosis. So a diagnosis of osteoid osteoma was made in this patient, hence the typical clinical presentation of pain at night. So this is a differential diagnosis for focal sclerotic bone lesions. It's wide and it includes multiple causes, like it's seen in trauma in cases of stress fracture and insufficiency fracture, and bone infarcts, chronic osteomyelitis, and neoplasm benign and malignant, and in Paget disease, and of course in bone islands. Limiting the discussion here for our cases today of a stress fracture and osteoid osteoma. Typically, osteoid presents in children and young males. They have pain at night, which is relieved by aspirin. And of course, the presence of nidus is characteristic in this case, and that it's of course enhancing on post-contrast MRI. The nidus is usually less than 1.5 centimeter, and this is a differentiating point between it and between other bone lesions like osteoblastoma. And stress fracture, it will present in young adult males. However, it can also be seen in females, which is a risk factor, actually, female gender for stress fractures. Pain is usually after recent physical activity. There will be no nidus, and we may be able to see fracture line with burstal reaction in the subacute and chronic phases. Osteoid can show double density sign on bone scan, while stress fracture will show linear uptake on bone scan. The cortical thickening on osteoid is fusiform in shape, as we saw in our case. And stress fracture, marrow edema usually regress in follow-up scans. So our take-home message from those two cases is that the clinical and radiological manifestation of osteoid osteoma can be very similar to that of other pathologies. So combining clinical history and using multimodality imaging approach typically help us in diagnosing osteoid osteoma correctly. And this is the end of my talk. Those were the references that I used. And thank you.
Good afternoon, everyone. So I'm presenting a case today about bone or osseous hemangioma and specifically vertebral. Okay, so I have nothing to disclose in this case. My case is a 43 years old female who had chest x-ray for routine pre-op evaluation for a traumatic lower limb fracture. I believe it was bimalleolar fracture. And in this pre-op chest x-ray, incidentally, the patient found to have well circumscribed radio-opaque lesion with the suspicion of having underlying T7 extension or involvement. So it thought to be either a paravertebral lesion or it's the wrong place. A paravertebral mass or abscess. And there was no evidence of underlying rib erosion or splaying. I don't think I'm able to move it to the next slide. Can you go? Yeah, I'm able to do it now.
You can just use these to go forward.
Okay.
Might not be able to use them as.
Yeah. So we did after that a CT with contrast, which showed the patient to have heterogeneous expansile bone lytic lesion involving the vertebral bodies and its appendages, T7 vertebra. And the soft tissue component, the paravertebral component of it, it found to show a minimal heterogeneous enhancement. And obviously there is mild thoracic spondylodegenerative changes. Then later on the MRI, the lesion found to be hyperintense on T1 and T2, and with some enhancing areas mainly posteriorly and posterolaterally, compressing the spinal canal or the epidural space and pushing the spinal cord posteriorly with some diffusion restriction posteriorly. So this case was diagnosed as vertebral hemangioma because it showed the typical features of hemangiomas with some atypical characteristics. So the typical features of hemangioma, as we all know, that on a plain radiograph, it may show, it usually show a lucent medullary lesion with trabecular thickening, which will be more evident on CT, as you can see here on the axial plane, which is known as polka dotted or salt and pepper appearance. And on the sagittal or coronal view or plane, it will appear as the well-known corduroy sign. On MRI, those thickened trabeculae, they may be subtle because they will appear hypointense on both T1 and T2. And most of the time on T1, the lesion itself, when it is lipid rich, it will demonstrate high signal, and it will appear even more brighter on T2 due to the high water content. It will show significant enhancement due to high vascularity on post-contrast images with no restricted diffusion. Now, how to differentiate it from other differentials, including, or before that, the osseous or bone hemangiomas, it can have atypical features like containing little or microscopic amount of fat, which will have a low signal intensity on T1, similar to our case, or the case that I will show next. And it can have expansile nature, and it will show mass effect, compressing the spinal canal. And it can show vertebral collapse, as it was seen also in our case, especially when the paravertebral or the extraosseous soft tissue component is quite large. So the differentials can be metastasis, especially if the vertebral hemangioma is poor in fat. However, we can differentiate it from hemangioma by doing the chemical shift imaging as the lipid poor vertebral hemangiomas will show drop signal on out of phase images due to its microscopic fat content. And the other differential can be bone lymphoma, which will also show high signal intensity in T1. However, it can show variable T2 signal intensity, and it will be more hypointense by time on T2 due to the high cellular content. So the vertebral hemangiomas, they are the most common spine tumors with estimated incidence of 1.9 to 27% in general population, and rarely it can exhibit extraosseous expansion, which result in compression of spinal cord, as we saw in our case, and this account for less than 1% of the spine hemangiomas. So this is another case. I found it in literature, a case report of a 68-year-old female which presented with progressive walking difficulty and sensory disturbances in her lower extremities. And as you can see, the thickened trabeculae, the characteristic thickened trabeculae on the X-ray, and then the high signal intensity in T2, also somehow high signal intensity in T1, with the large soft tissue component compressing, like severely compressing the spinal canal and the spinal cord, pushing it posteriorly. So the summary, as long as we know the typical radiological characteristics of vertebral hemangiomas along with the atypical features, we can easily diagnose the vertebral hemangiomas, and especially if we do a CT and correlated in cases where the vertebral hemangioma is initially diagnosed on MRI, because the thickened trabeculae might be subtle on MRI. So the take-home message is, if the lesion looks like hemangioma, then it is hemangioma, even if it shows atypical features, including collapse or vertebral body expansion or compression, etc. Those are my references, and thank you.
Okay, thank you, Dr. Bushra and Abdullah, for the presentation. We're coming now to our final but more exciting quiz discussion with Dr. Asad. I hope you had time to do some of these cases which were available online.
Great, okay.
Hopefully the online also guys on Zoom managed to go through them. So there are 11 cases for you to go.
That's great. Thank you. All right. So I know, I mean, it's the end of the day, but to keep the excitement going, I mean, I've been given the position to to run this quiz. So I hope the guys who were online, they managed to go through the cases. I mean, ideally it should have been interactive and all that, but just to keep the excitement, if you've got your answers in front of you, let's see how many out of 11 you have scored correct. So just waiting for the answers presentation to come. Right. Thank you for the dear colleagues and friends who stayed till the end. So really appreciate that. I hope it's not only for me, isn't it? You're not waiting for this last lecture. That's the answers one. Yeah. Oh, great. Okay. So that's it. Yeah, good. Right. This is the answers one, yeah? Yeah, great. Okay. So 12-year-old female presented with right ankle pain and swelling. I think I'll pause for 10 seconds on each case and then because the next slide I'm going to describe what it is, right? Okay. Rather, I describe it now. I think if you notice, obviously there is soft tissue swelling around the ankle. You can see there is some bimallular, like overlying the malleolar, there is some soft tissue swelling. But the thing that I need you to appreciate is there is homogeneous sclerosis of the talus. I know it's subtle, but when you compare, well, it's not that subtle once you spot it, but it's something that we don't tend to kind of, it doesn't come naturally. But when you compare the texture of the talus, especially on the AP with the tibia, it looks a bit white out. I mean, you can argue it's a bit of edge of the film, but still allowing for that, it looks homogeneously sclerotic. So whenever I see that, I get worried that there might be something happening to that bone. So the patient had an MRI. The top two images are T1 weighted images, top bottom are proton density fat suppressed. Whenever we think about bone sclerosis, we think about AVN, infarct, sclerosis, things like that. I mean, if you look at the T1 weighted image there, I mean, there is an infiltrative process. There is isointense T1 signal involving most of the talus, right? Fatty marrow in the calcaneum and navicula. On the fat suppressed, you see there is kind of some hyperintensity, but the thing that I need you to appreciate is this. See, there's a nubbin of soft tissue which is extending beyond the bone. There is extraosseous extension. So this is an infiltrative tumor, infiltrative process that has gone into the joint, causing this reactive effusion. So that sclerosis was real, and this is marrow infiltration. Okay, I show you this case. This is an adult. And similar kind of process. If you look at the distal humerus on this lateral radiograph, it looks sclerotic in contrast to the radius and ulna. And the concomitant, the sagittal stir, it shows you there is stir high signal within the marrow, is extraosseous soft tissue extending from the distal humerus, and there's all this large extraosseous soft tissue mass in the triceps and anteriorly. Any takers? Well, the first patient is 12, the other one is 60. Diagnosis is the same. Lymphoma. So always think about lymphoma. Lymphoma is a great mimicker. I agree. I think with like Asir said, when there's extraosseous soft tissue, you always think about Ewing's. But in adults, lymphoma can do anything. But diffuse sclerosis, it can give lytic lesion, it can give sclerotic lesions. But these are two cases in which they were biopsy-proven lymphoma. So think about lymphoma. Next one, relatively easy case, 10 seconds. Pregnant lady, our colleague actually in my previous hospital, walked in crying in pain. I think she was probably 30 weeks pregnant at that time. And then she wanted to do an ultrasound. I did an ultrasound. I couldn't diagnose. I thought that she might have a subscap tear or something. And then she was in so much pain, she went to a hospital. They did an MR. The X-ray happened after the MR. So AP and lateral X-ray of the left shoulder, and then I've got a T2 weighted coronal image there. So very aggressive process, as you can see. On the lateral, you can't even see the head. You can see the glenoid through the head. Okay, it's all melted away. The bone has been replaced by this T2 hypointense soft tissue. Okay, and there is a pathological fracture as well. If you see on the AP, there is a crack in the lateral cortex. She's 27, plasmacytoma. I know Rashi Shorhan said it, but I mean, I think we have seen 1 or 2 plasmacytomas in young people in this hematology tertiary care unit, but it's rare. But common things common. I think okay. Well, let's keep it to the side. This is another patient. She was 27. This other case I have put on for you. This is a 60-year-old with known renal cell carcinoma. Okay, so similar kind of process, aggressive lytic lesion, cortical destruction. But There's a large extraosseous soft tissue mass with this. This is expansile renal cell carcinoma metastases, right? That's a 60-year-old, 40 plus metastases. We're coming back to this case, 27-year-old with this aggressive lesion, T2 hypointense. Sorry? She went to the States. They biopsied it, they replaced it. Very aggressive tumor in a pregnant lady. Think about hormonally sensitive tumors. Choriocarcinoma, okay, yeah, she didn't have any lung metastases. It was she had a viable pregnancy. She had a viable twin pregnancy actually. This is GCT. So think about GCT. Rashid said they are locally aggressive tumors. They are very aggressive tumors in pregnancy. ABC and GCT, they can spread like fire. In my DD first report, I said it's a Ewing's, it's lymphoma, and GCT I put in the end, but I was surprised when it came back. So think about GCT in pregnant patients. It can look as aggressive as this. Okay. Next case, abdominal X-ray. I know my colleague Rafi, he showed a couple of abdominal films there. So abdominal distension, again, young patient. I don't know where our radiographer colleagues have gone. They would have appreciated that. Dr. Wissam, you see anything? How would you report this X-ray? It's a male, it's not a female. That's an important distinction. If it's a female, you would think about ovarian something sitting there, isn't it? Yeah, excellent. Yeah, Dr. Asir has said it. So you see, there is the transverse colon, the bubble loops are kind of pushed to the side. Do a CT. Simple. Large, fatty, retroperitoneal tumor liposarcoma. I mean, I know Rafi showed one around the kidney, but this is typical large retroperitoneal fatty mass liposarcoma. Okay. Okay. 12-year-old hip pain. I like the pelvic radiograph because when I show them in the web, I don't tell them which side, so they have to pay. Sorry, say it again. Which side? No, it's normal. Excellent. Asir has correct diagnosis. I mean, okay, yeah. So if you compare the left superior pubic ramus and compare it to the inferior or the other side, it's a bit sclerotic. I put them there. I know Rashid showed one of these cases. He said it's difficult to pick up when something is missing. Obviously, I mean, if something is missing, like a scapula is missing, then it's tricky. But when this is missing is easily the chin drops. But when there is something sclerotic, then it's tricky. And now there is sclerosis of that. So this patient on this was a Ewing sarcoma. Okay. Similarly, this patient an MR, and you can see there is sclerosis on the T1 weighted image. You can see it's hypointense. There is periostitis. There is a small extraosseous component as well. This is Ewing sarcoma. So sclerosis is not, I know sclerosis or permeative, they are tricky. You need to have the eye for it, but compare to the other side. Okay. Uses Ewing's. Okay. This is typical kind of easy case. I think Wissam even can take it. 11-year-old male. Wissam. So chest pain and leg swelling. What do you see on the chest X-ray? Sorry? Yeah, you can make, I mean, this is not an exam. But... So obviously there's a portacath there. So this patient is on chemotherapy. Yeah, okay. But you see there are all these calcified masses in the left lung with some changes, even I think there's left lower lobe collapse. Okay. But what about the pelvis? I was looking at Codman's papers. Codman was the orthopedic surgeon in New York who started this Codman triangle, and he kept the first bone tumor registry. And one of the cases in his archive is like this. We don't see these kind of cases nowadays, thankfully, right? This is an unfortunate kind of case, but it just, you see there's a large ossified mass arising from the proximal femur. And I take you back, this is 2 years back. Young child presented with a diaphyseal abnormality. You can see there is sclerosis, there is kind of this bone from osteoid matrix, you got this irregular kind of periosteal reaction, you got some saucerization, you got this abnormal enhancement. This is osteosarcoma with metastases. Okay, and then It was like, because of it was at high stage, they gave him chemoradiotherapy. It responded a bit, but then it came back with this. So this is kind of unfortunate, but that's always think about, not everything calcified on a chest X-ray is fibrocalcific change from TB or previous infection. Yeah, so think about, it is like textbook case. Yeah, okay. Metastatic osteosarcoma. Okay, this is a nice one. This kept us intrigued for a while. So this is a patient who is 35-year-old, I think from Africa or somewhere, and then he presented to ER with a fungating mass in front of his right leg. And these were the X-rays done on the right side. So you can see there is a soft tissue mass at the anterior aspect of the midshaft of right tibia. There is some saucerization, anterior cortex. Yeah, the guy said adamantinoma. I like that. Yeah, whenever you see a tibial lesion, you think about adamantinoma. Yes, that's what we thought as well. DFSP? Yeah, DFSP is a good thought. Good, there's the two. I was thinking it's periosteal osteosarcoma because the diaphyseal lesion, you got extra osseous and all that. Okay. I'm going to show you the MR, but the key thing is in 4 months' time, the patient went, it was biopsied. We knew the diagnosis. He was offered treatment. He denied it. He absconded. He came back with, if you see here, there is probably a fracture here now. There's a fracture here now. Okay. But in 4 months, you can see that first there was a bit of saucerization of the anterior cortex, and now the process has invaded the cortex. So just looking at the X-ray, we can imply that it started on the surface, then went into the bone, rather than in the bone and out. Do you agree with me? It's plausible, right? Okay, so let me take you to the MR. Sorry? Yeah, okay, well, the question is surface lesion, or it's most likely a surface lesion, isn't it? Yeah, okay, let me take you to the MR. This is the first MR study we did. So we got a coronal T1 weighted image showing you some T1 abnormal signal in the medullary cavity. But the primary lesion, as we saw, is this extraosseous soft tissue mass. And the key thing is the axial. If you look at this axial post-contrast, you see there's a flat kind of like Rafi was saying, a flat surface wrapping over the interior aspect of the tibia. Okay. So we thought this is a surface lesion that is secondarily involving the bone. So this was the soft tissue was biopsied, but I was not happy with the signal in the bone. I asked the surgeon to go in the bone as well. And then he biopsied that. But they were two different pathologies. But then this is the MR now. Current admission, you've seen the infiltrative mass has grown. It is invading the compartments. It has caused destruction and all that. So it's not periosteal osteosarcoma. It's not DFSP. DFSP, I have never seen DFSP cause this amount of destruction. This was this. So this patient had some kind of ulcer there sitting for years. It developed into marginal, it went squamous cell. I know it's tricky. I mean, I thought it could be marginal ulcer, but we were thinking about, like you said, surface lesions, periosteal or post-periosteal osteosarcoma, periosteal chondrosarcoma. But yeah, you can be surprised sometimes. So squamous cell cancer, and I haven't got the picture. It's a very ugly looking picture. You've got a fungating tumor with slough on it and all that, and that secondarily involved this. And there was osteomyelitis of the tibia on the first biopsy. So it was squamous cell carcinoma with cortical invasion, with osteomyelitis, and now we are dealing with something that is not salvageable. The limb has to be sacrificed, I think, in this case. So think about lesions that in the skin that can go into the bone rather than surface or inside out. Okay. Yeah, this is relatively easy. Yeah, this is a nice case. It came with chest pain to our ER in my previous hospital. We did a CT chest. And there was something in the shoulder we spotted. Then they thought he's got right upper limb pain. So they did an X-ray of his shoulder, his hand, followed by the MRI studies here. 41-year-old. Why do you say TB? Yeah, I mean, the picture is of more of septic arthritis, isn't it? You've got these kind of erosions, osteomyelitis, there's synovitis, there's bursitis. Similarly here, the key thing here is this lobular synovial thickening. I mean, it could be inflammatory arthropathy, it could be pyogenic, but pyogenic is typically kind of monoarticular, isn't it? But TB is this: if you look at the TB, multifocal TB, it affects the upper limb. There have been case reports, it affects the elbow and the wrist on the same side. Chest, yeah, exactly. Good spot. I didn't put a chest CT there for you, but yeah, there are changes in the CT. So, and I'm going to show you the next slide. So this is the T1 weighted image. This is the key thing. I think the key thing is this, the axial of the wrist. This lobular multifocal flexor extensor whenever I see this, whenever we see this, we know this could be, I mean, obviously you can have it with rheumatoid, you can have it with psoriasis and things like that. But when you see this lobular amount of extensive thing, it has to be granulomatous. It was biopsied, I think, Vijay biopsied the abnormality around the shoulder. It showed caseating granulomas. And there were changes. There were endobronchial TB in this guy. So think about even multifocal TB can exist. All right. Okay. I leave this on for 10 seconds. Young lady, chronic limb shortening. We see a lot of young patients have with chronic limb shortening. Either they had dysplastic hips that was not picked up, or they had some childhood infection that was not treated. But this is quite abnormal, isn't it? I mean, you can see there is says left DCFE. What is DCFE? That's femoral DCF, displaced capital femoral epiphysis. No, there's no DCFE. It's an adult patient. So there is, if you look, I think if you look at the 3D reform, it tells you it's interior, anterosuperior kind of dislocation of a deformed right femoral neck and head. And the key thing is the shape of the femoral head here. It's like an hourglass. I mean, when we were taught if there is this kind of thing, you think about amyloidosis and things like that. They can give you this sclerosis, pressure effect, and all that. But okay, let me get you the next page. Everybody will say this image on the right, this is polio. This is polio hip, isn't it? Hypoplastic pelvis, hypoplastic gracile femur with a fracture, that kind of thing. So now I want you to, so this is polio, right? But now let's go back to the pelvic X-ray in question. Look at the soft tissues. Yeah, there's soft tissue hypertrophy. If this is the abnormal side, why there is soft tissue hypertrophy there? Well, it could be that kind of Trinoni, Klippel Trinoni and all that stuff. But then how would you describe the dislocation? Okay, I'm going to show you the MR now. This is the MR. This is the MR now. Asir is going to tell me what's the diagnosis. Somebody saying Paget's. It's a 27-year-old. You don't get Paget's in 27-year-old. Sorry? No, look at these images. So these are I put just fat suppressed images for you: sagittal, axial, and then coronal. No, they are solid lesions. They were. I mean, I'm not showing you the contrast, but the key thing the key thing is, if you see, I think the key thing is the subcutaneous fat. These are plexiform neurofibromas and all that. This is neurofibromatosis type 1. A very weird kind of presentation, but it probably she had neuropathic joint or things like that. I know it's difficult, but she was known to have it, right? But the key thing I think here is not to call it polio, because there is hypertrophy. It's not hypertrophic, right? Okay, think about that. Yeah. Okay, this is Dr. Vijay's case now. Again, so knee swelling, young patient, bit of pain in the back. Okay, so back of the knee. Yeah. So T1 weighted, T2 weighted, and then a post contrast. Sorry. This is a quiz. It can't be that simple, isn't it? I know. I mean, any intra-articular lesion, the commonest one around the knee is PVNS. It could be focal. It could be focal PVNS. It's a solid lesion, solid intra-articular lesion. Okay. There's no tendon there. You're going to make it a GCT of the PCL. What else? If there's a nice series from Stanmore with Dr. Saifuddin and but Michael Koo probably, they did They looked at about 100 cases of synovial lesions they biopsy, because in Stanmore, they'll biopsy everything. Anything synovial, they'll biopsy. Typical PVNS, they'll biopsy because they saw one synovial sarcoma in probably 10 years or so. So there is like, obviously focal PVNS is there, hemangiomas are there, but there is something else. Okay, I'm going to get to the next one. So just showing you the coronal PD fat suppressed T2 gradient and T1 fat suppressed. So if it was PVNS, I mean, it obviously is T2 hypo, right? So on gradient, it should typically bloom. Obviously, you can, I mean, you would expect it to bloom if it's that solid. It'll have hemocyte, it will bloom. So it's not typical appearances on the gradient echo for a tenosynovial giant cell tumor or PVNS, but it enhances. Sorry? Gout, yeah, possible. I mean, but it's not as hypo-intense. Gout would be very kind of craggy, irregular, hypo-intense. It is a solid lesion. It needs biopsy. It could be synovial sarcoma. Those synovial sarcomas are more juxta-articular than intra-articular. So doctor, okay, ultrasound. There we go. It's solid. Yeah, it's. I mean, that's ultrasound showing you, and then Vijay biopsied, and it came back as. Any guesses? Nodular fasciitis. It's well described. I know. I mean, we all think. I mean, we all were like, really? But I mean, it was. If you read that series paper, there were about 5 or 6 nodular fasciitis cases in that. Solid intra-articular knee lesions. Think about nodular fascia. We think about this is something related to the fascia, right in front of the elbow, something like that. But yeah, but it was a sarcoma unless proven otherwise. So we proved it. It was otherwise. So it was excised. He's doing okay. Right. This is the second last case now. I think a few of you have seen it. Okay. So I know Asir has spoken about the Chopard joint. That's something when we look at the oblique X-ray, that's the area we look for tarsal coalition, isn't it? Calcaneonavicular coalition. So I want you to just look at there. This is a young patient, by the way, 30-year-old. She had very non-specific symptoms, actually. She was under the rheumatology with big toe pain, then kind of mid-foot pain. It was, and she's a dancer. So it was like, you can see there is a bit of osteopenia generalized. Okay. I did ultrasound of her toe. There was no synovitis there. And then I was just scanning the tib post. And then I saw this thing. I'm not showing you the ultrasound, but I saw this. Then I went back to the MR, which was done elsewhere. And then I said, there's something there. So this is a T2 weighted image, very hypo-intense lobular lesion sitting kind of in the region of the spring ligament, causing some scalloping of the navicular. And then we did a PET CT. We did a SPECT to say that, is that really the cause of her pain? And there you go. It's very hot there. So the bone generator is this. Sorry, the pain generator is this. Okay. I mean, hemophilic arthropathy is a possibility. I mean, that can give you this appearance, like this this hypo-intense thing. This is the focal PVNS, and this is the PD facet. This is T1 weighted image. So we were, but the question was, is it calcified? We did a CT, by the way. Well, there's a dual LD CT, but I've got a plain CT with it, which didn't reveal any calcification. But there was no uric acid crystals. So gout is out. I mean, this I would think there's a gouty tophus, with that had high activity, that erosion, and all that. Okay. This was easy. Man, that guy has Dr. Mali. Yeah, this is PVNS. I mean, PVNS. I mean, it can be in the joint. It can be next to the joint. But I found it difficult. I think the reason we missed, I won't say missed, but we kind of overlooked it. It was in the region next to the spring ligament. It's a hypointense area. You don't kind of think any hypointense thing sitting on there. But then with ultrasound, patient pointed, you were just kind of screening, and then you saw something really vascular, which didn't look like a traumatic tear. And then we'll get back to that. So it was biopsied, and then it was excised into by the orthopedic surgeon. Last case. 62-year-old. Enlarging thigh lump. I think even if I don't show these images, you would all think about, I mean, what you will be worried about, enlarging thigh lump. Okay. So the coronal stir, you can see a large elliptical kind of fluid signal kind of lesion with some solid bits in it, some extravasate, some kind of edema or fluid-like signal there. This axial T1 weighted image. Well encapsulated kind of lesion with T1 hyper intense and then T1 iso intense thing. Yeah, Morel Lavelli. I wanted somebody to say that, Morel Lavelli. Anybody knows what is Morel Lavelli? degloving injury, but the degloving injury happens at the subcutaneous fat and facial interface. Is this lesion above the fascia or deep to the fascia? Deep to the fascia. That is the key thing. If you look here, this is your ITB. This lesion is deep to it. So this can't be moral lavelli. This is a deep lesion. And then going back to Dr. Rami's thing, do a X-ray. You do X-ray, you see a speck of calcification there. What's the diagnosis? Does it look like hemangioma? It is in the muscle. It's deep. Sorry? Hematoma or a hemorrhagic? It's not myositis. Okay, let me show you the next one. I'll just show you the post-contrast. It's getting exciting. AV malformation, no. Where is the next? It's not. This is not working, guys. Next slide. Yeah. No, next. Go forward. Yeah, keep going, please. Next. That's it. Yeah, stop it there. Okay, so you say it now with the post contrast, is it? With the post contrast, you can see there is that solid bit. If this is a complex, deep, cystic, hemorrhagic, solid mass. This is soft tissue, isn't it? It's in the compartment. Yeah, okay, yeah, myxoid sarcoma is a thing, but there is calcification in it. So which sarcomas calcify? Dr. Rami said it. Can you? It's not working, this thing. Just press next. Just click there. That's it. Biopsy proven. This is synovial sarcoma. Sarcomas that calcify, and synovial sarcoma is a misnomer, as we all know. They're not in the joint. They're next to the joints. They're soft tissue sarcomas next to the joint. This is a sarcoma. Deep to the fascia, not moral level. It looks like moral level, but it's got more kind of heterogeneous solid bits to it. So facial, you have to think, you have to assess whether it's deep to the fascia or above the fascia. So I think that's it. Yeah. Any questions from the audience? Thank you. So they were all from here. They're all from UAE. There's nothing, I mean, from UK on these. So I'll ask Dr. Vijay to have the closing remarks and please, yeah. Thank you for your attention.
Certificates there.
Yeah, there are certificates for the presenters. So
we have certificates, appreciation certificates for the speakers and chairs as well. Thank you. I would like to thank all the on-site delegates. We stayed. It's been a long day, but you all stayed until the end. Thank you so much, and all the online delegates. And I would like Dr. Rami Mansoor coming all the way from UK and sharing his knowledge with us. Thank you so much, Rami. Always appreciate and enjoy your company. Dr. Rafi Khan and Dr. Asad Shah, my dear colleagues, they have been really supportive and made this possible. And Dr. Rumaiti, Dr. Al-Bastaki, and Dr. Holland, they've been really supportive and encouraged me to organize this event. Thank you so much. And my esteemed colleagues from the newly formed Emirates Club of MSK Radiology, thank you all for participating and making this a big success. Without you, we couldn't have pulled this off. And lastly, but not the least, the SSMC and the CME team, the academic affairs team, who have made sure of all the arrangements, have done a fantastic job. Big round of applause for the academic affairs team of SSMC, please. Ahlam, Mark, and Krista in particular, they have done a fantastic job with the arrangements. Thank you so much. So we have certificates. I think some of the people have left, so we can hand over directly. I think we'll hand it over directly to them. So the video link will be available soon for a certain amount of time, so people who have missed can catch up later on. And the evaluation forms will be sent out for the people who attended, and they will get the, after filling the evaluation form, they'll get the online CME certificate. Thank you so much for your contribution to this course conference. Thank you so much.